Yo, welcome. It is time for the Trauma Conference. This has been years, decades in the making, well, months in the making. We're really excited to present this to you today. We've got lots of fantastic topics, fantastic speakers and experts, but the real magic of today is in the interaction on YouTube in the chat, where lots of questions occur, and they actually occur simultaneous to the lectures occurring. And many of the people giving the lectures, those experts, will actually be in there with you. So that is the magic. And I can see that people are from all over the world. I mean, literally all over the world. So let's do some introductions. First of all, Chris Colwell. He is the Chief of Emergency Medicine at San Francisco General Trauma Center. He has extensive trauma experience. He was actually, sadly, a physician at the scene of the Columbine High School shooting. He's an associate editor of Compendium for the trauma section. So he comes as our trauma expert. If Chris doesn't know it, it doesn't exist. And so Compendium will actually be the syllabus for this conference. Over here to my left is Britt Guest, who is the Chief Medical Officer of Whoop Whoop, which is the conference division of EMRAP. And she's also a fellow, the AIM Fellow, which stands for, Britt, what?
Access and Innovation in Medical Education.
Fantastic. And she's also faculty at UCLA starting in July because her fellowship is Dunsies. Next to her is the beautiful Ryan Ernst, who is faculty at UCSF Fresno. He is the Director of Education of EMRAP Go. He's also co-director of this course. My name is Mel Herbert. I need no introduction because I'm an idiot. Background, people. We got Graham, who's running the show from behind the little booth over there. You can't see him, but he's Oz. And downstairs is Katie, who is our events director. And there's a ton of other people that have been involved in this puppy. So before we go any further, Chris wants to say a few words about what we're doing here today.
Well, thanks, Mel, and welcome, everybody. It is really exciting to be here today, and we're doing something now that I think we have needed to do for really a long time, and that's focus trauma discussions on emergency medicine. It feels like, at least from my perspective, that so much of the literature and the conferences still focus a lot on surgeons. I don't mean to disparage surgeons at all. We love our surgeons. I'm really happy they do what they do. But from my perspective, you guys are the trauma docs. Emergency medicine is what sees everything that comes in, sorts out the high acuity, the low acuity, stabilizes our patients so that surgeons can come in and do what they do when they need to. And in some cases, many cases, are the only folks taking care of these trauma patients. So again, my perspective is all trauma discussions should start and focus on emergency medicine. That's what we're doing these next couple of days. I'm really excited. Britt, let's get us started.
Preach, brother, preach.
Whoop, whoop. All right, so to kick off the trauma conference, we had questions from all over the world, around the globe, about trauma. And we're hoping that in the next 2 days, we answer all of those questions. So let's turn to our first video and see what those were.
Hi, I'm Emmanuel Quaidu. I'm a PGY4 at UCSF, and I want to know when are pressors indicated for trauma?
Soy Sirán Casaciano, urgencióloga de Santiago, Chile. Me entra una duda. ¿Serán estériles las heridas por arma de fuego?
Hi, I'm Jeremy Cordado, and I'm a chief resident here at Denver Health. In the setting of penetrating trauma, like a stab wound, when is it appropriate to loosely approximate, if ever, or should we not close these wounds altogether?
Hey there, my name is Michael Boyle. I'm one of the second-year residents in the UCSF San Francisco General Emergency Medicine residency program. I was wondering, how do you interpret the FAST in the setting of a pelvic fracture with suspected hemorrhage?
Salut Ryan et l'équipe de EMRAP. Je m'appelle Eric Contant, je suis urgentologue canadien qui travaille actuellement au Lands Hospitalier à l'hôpital universitaire de l'Islande. Écoute, j'avais une question pour vous. Tu sais, en trauma pédiatrique, il y a tellement de chiffres à se rappeler. Les tubes nasogastriques, les tubes endotrachéaux, les tubes pour les chest tubes. Je me demandais si vous n'avez pas des trucs pour nous aider à nous en rappeler. En tout cas, j'ai bien hâte d'entendre la réponse. À bientôt.
Hey, I'm Seema. I'm a resident at UCLA Allevue, and I've always wondered, can I give contrast through an EJ in a trauma patient?
Hi, I'm Lizzie Ferreira, and I'm one of the PGY3s here at the UCLA Allevue Ronald Reagan Medical Center. I have a question regarding a patient who sustained multiple facial fractures and ended up having entrapment in one of their eyes. It was 2 o'clock in the morning, and it was hard to reach their consultant. Is it okay for these patients to wait to be seen later in the clinic that day?
Là bác sĩ Võ Hạnh, khoa cấp cứu bệnh viện Chợ Rẫy, cách tốt nhất để quản lý và an thần ở một bệnh nhân được cần là gì?
Não dá seria a paixão, mas seria excelente, não urgência, não lutar universitário no balé. Portanto, ele conhece o teatro, não manos visites, dizimani for caimala avec Thomas, canicere.
I'm Gail. I go to UCSF Fresno in second year, and here we wear fanny packs. My question is, what's the best way to control pain for a chest tube?
Hæ, og bestu kveðjur frá Íslandi. Ég heiti Eva Hrund og deildarlæknir á Landspítalanum Háskólasjúkrahúsi og mér langaði að spyrja ef að það kæmi inn barn með jákvætt fast eftir tráma, væri þá rétt að gefa því TXA eins og maður myndi gefa fullorðnum?
Hi, my name is Leslie Pepin. I'm a Denver Health Chief Resident coming in from our Winter Park Urgent Care. My question is, should we ever be doing needle decompressions in the ED?
So oftentimes when we have tough access in our trauma patients, we move towards an IO. Is it acceptable to use an IO for IV contrast when you're getting our CT scans?
Hello, I'm Dr. Ezekiel Aluda from Kenya, Kenyatta University teaching in Afaro Hospital. My question for the EMRAP crew was, when do we start or when do we stop chest compressions in traumatic cardiac arrest?
My name is Bryce Burdell. I'm a third-year resident in emergency medicine at Sinai Grace Hospital in Detroit, Michigan. If you have a trauma patient who you're starting MTP on, is it adequate to just have two 16-gauge IVs, or should you put a cordis catheter in? How about if you have two 14-gauge IVs?
Hi, I'm Ganaja. I'm one of the emergency physicians from Kalthar Hospital, Sri Lanka. What is the best way of sedating an agitated trauma patient?
I'm Nivi Kula. I'm an emergency medicine resident at SUNY Downstate and Kings County Hospital in Brooklyn, New York. Do you have a quick and systematic way for emergency medicine doctors to read chest and abdomen pelvis CTs to look for traumatic pathologies?
Namaste, मेरो नाम सुवर्ण अधिकारी हो. म UC Davis मेडिकल सेन्टरमा फर्स्ट इयर इमर्जेन्सी मेडिसिन रेजिडेन्टको काम गर्छु. मेरो प्रश्न, फेसियल ल्यासरेसनहरू कति ढिलोसम्म रिपेयर गर्न मिल्छ? धन्यवाद.
All right, that was awesome. We are going to do our best to answer these questions for you here today and tomorrow. But let's just get right into it. Say your next patient in the department, stab one to the neck, they walk in. Do you immediately know your first, second, third steps? If not, Swami's going to help straighten you out right now.
All right, guys, for the next 20 minutes or so, we're going to talk about penetrating neck trauma, something that I think gives us a lot of anxiety in the emergency department. I think a lot of the anxiety revolves around what exactly our roles are, what our focus should be on. And so we're going to try and simplify this. And a lot of this comes out of the fact that in my new job, I've seen quite a bit more penetrating trauma, especially to the neck, than I've seen in the past. And so I really had to kind of up my game, learn more, and really focus in on the things that were important as emergency clinicians for us to be doing. Ideally, you have a trauma team that's going to be managing this patient as well. I know that's not always possible, but I think these are the realms that we really have to focus on. And number one for those realms is airway. We need to be focused on how to control the airway properly. What is the best approach to doing that? Number two is the hard signs. The hard and soft signs are necessary to understand, but really focusing on the hard signs and how that dictates management. And then finally, hemorrhage control, something that is so simple and yet done incorrectly so often. So we're going to focus on these three areas during this talk. Now let's frame this with a bit of a case. This is a patient I saw recently, and I think getting a little bit of this framework in our minds will help us as we go through. So I got a call from EMS that they have a 23-year-old man who was stabbed in the neck. He is hypotensive, he's tachycardic, he's tachypnic, he's got a lot of blood on scene, and they tell you they're going to be with you in about 7 minutes. 7 minutes isn't a lot of time, but I think that's time that can be either smartly used or completely wasted. And so we need to have an organized approach of what we do in the time before that patient hits the door. Many people think about the primary survey as the first thing we do. It is called primary, but actually it's the 0-point survey that we should be thinking about. This is a concept that Cliff Reed has discussed. We've talked with him on EMRAP about this about a year ago, and I definitely recommend that you check out Cliff's discussion of what he goes through and what he thinks about before the patient hits the door. The main areas that I want to focus on, number one, is self. Are you ready for this resuscitation? Are you running something else that also is taking your attention? Are you not ready? In which case, maybe you can pull in a colleague to take that patient instead. Now, sometimes that's not possible. So wrap up whatever you need to wrap up so that you can focus on the patient in front of you. One of the things that I was taught very early on is that you have to empty your bladder before you resuscitate. You cannot appropriately resuscitate a patient with a full bladder. So that's another part of self. Empty your bladder, be focused on that patient. From self, then we move to team. What team members do I have? How many nurses do I have? How many other physicians are there? Do I have a trauma team? And getting that team organized and tasks assigned. This is the airway team. This is the blood team. Something that I have overlooked in the past with resuscitations, especially trauma resuscitations, is having someone dedicated to getting the access and then pounding blood into that patient if they're hypotensive. So we have to make sure that we have our team set. Everybody knows what their roles are. And then we have to focus on the patient as they come in and setting the environment for that patient. So environment is the next thing to think about. Do I have my ultrasound machine? Do I have all my airway equipment? Is there good lighting? Do I have enough room? Ideally, you do all that way in advance, and all of those things would just live in your trauma resuscitation bay. But taking 30 seconds just to look around the room and see if everything's laid out properly is great. Now the patient comes in and you start with your actual primary survey, and you might have set some priorities before the patient came in, discuss that with your team. Now, as you do your primary survey, you might have to reshuffle those priorities, update your team as you go. As those priorities are addressed, what's our next big thing that we have to look at? Depending on where you work, you can have a very large resuscitation team, multiple teams actually, an airway team, maybe anesthesia comes down for that, your trauma team, all of your nurses, your other ED colleagues that can be pitching in as well. Or if you happen to work in a smaller place where it's just you, then your team is going to be much smaller as well. But we have to, again, make sure that everybody knows what they're supposed to be doing in that situation. And while the small team is challenging, the large team can be challenging too, especially when people don't know what their roles are. So set that team up for success by preparing them, assigning roles, and telling them what they're going to be doing, what our priorities in management are going to be, and then updating your team as you go. Now, once the patient gets to you, we're going to focus on these three areas: airway, hard signs, and hemorrhage. And let's start by focusing on airway, because this is the thing I think that gives us the most anxiety in these cases. Am I going to be able to intubate the patient? Do they need an intubation right away? Do they need an intubation later? Do they not need to be intubated at all? There's so many questions circulating here, and we have to have a really organized way of looking at this. It's not that every single patient who has a penetrating trauma needs an airway. And so we have to also assess that. Do I actually need to take this airway? And while we're doing that, we should look at what the challenges are in managing those airways. The anatomic challenges are clear in many ways: large expanding hematomas, blood in the airway. There are things that are going to be obstructing our view from delivering that tube. And those are very important, but we should also remember that there are physiologic challenges. We have focused a lot of time recently in those physiologic challenges because they're much more common overall in airways. Physiologic challenges are more common than your anatomic challenges, but we have to think about both once again. The physiologic challenges that we're going to see here are things like hypoxemia, acidosis, and of course, hypotension. All of these things make it more difficult from a physiologic standpoint to intubate the patient. And so when I have a patient coming in with a penetrating wound, I'm thinking of both of these challenges. From an anatomic perspective, we want to think about, is the patient able to maintain specific airway architecture because they're awake? In which case, paralyzing them might be deleterious to that architecture. Are there dynamic processes that are going to occlude that airway in a short period of time? Or maybe I can wait. And then from the physiologic perspective, how much time do I have to do some resuscitative maneuvers to put the patient into a better place so that when I decide to paralyze or just induce, it's less likely they have a peri-intubation arrest? Again, many of these patients are not going to need an airway at all. It's only a minority of patients that have an emergency indication for airway. This is the patient who has an obstruction, who you can't adequately ventilate or oxygenate despite basic maneuvers like bag valve mask or dropping an LMA. In these cases, yes, the patient needs an emergency procedure. They need an emergency intubation, but again, they're not frequent. There's also the semi-emergency, and I think more of our patients with penetrating wounds fall into this group. Semi-emergency, meaning they are oxygenating and ventilating okay, but you predict that in a short period of time, they're going to have either an obstructive process or they're going to have oxygenation or ventilation issues. In the semi-emergency, it means that we have time to resuscitate, to get blood products in, to maybe reverse that hypotension, the acidosis, get some pre-oxygenation going. In the emergency intubation, we might not have that time. We might have to resuscitate and intubate in parallel. So we have to really think about both of those. And then finally, there are patients who really have a delayed or elective course for that airway. These are patients who you predict are going to the operating room, but they're stable. There is no dynamic process in their airway. You don't predict an obstruction. They're oxygenating well, they're ventilating well. And these patients, sometimes you can defer to the operating room for that intubation. And a lot of this is going to depend on where your operating room is. Are you transferring the patient somewhere else? That might push your hand to intubate, even though the patient doesn't have an immediate indication for that intubation. So we really have to think about all of these and say, where does my patient fall? Not every patient with a penetrating neck wound is going to need an emergency airway, but some of them are. And so we have to then have a structured approach to do that. So once we decide we are going to intubate the patient, how are we going to do it? What's our approach? Now, I think we can overcomplicate this, as we often do with many airway situations. We overcomplicate things. If the patient has no external signs of an obstructive process, of an anatomic process that's going to stop you from getting into the airway, then your standard approach will probably be okay from an anatomic standpoint. Now, the physiologic standpoint, maybe not. If the patient's hypotensive, if they're hypoxic, if you predict they're acidemic, or if you actually have a pH, then those are going to be challenging intubations. And we have to really think about what resuscitative maneuvers can I do, and do I want to do a standard RSI? So from an anatomic perspective, if there's nothing externally that says we're going to have a challenging anatomic airway, you can probably go about this your standard way. On the other side of it, the physiologic challenges can be there, and we have to address those as well. We often talk about fiber optics as being the ideal way to intubate a patient with a penetrating neck wound. A awake intubation with fiber optics, keep the patient awake, keep the airway anatomy, keep that patient breathing spontaneously, and then you can use the fiber optics both diagnostically to look at that upper airway and see if there are injuries, as well as therapeutically to deliver a tube. It all sounds great, except many emergency clinicians don't have fiber optics. Many emergency clinicians who have fiber optics aren't completely comfortable with them. And I think that we would be doing our patients a disservice and ourselves a disservice to reach for something that we are not comfortable with. This is not the time to break out fiber optics for the first time. You should be practicing this on regular patients or more straightforward patients for intubation. These patients, we need to approach them with things that we know we do well. So do what you do. If you don't use fiber optics, this is not the place to do it. If you don't use video laryngoscopy, this is not the place to break it out for the first time. So approach these patients with something that you are comfortable doing. Now, there are going to be some variations, and I'll talk about how I like to intubate these patients. And I think how that can inform us is skills that we can learn to bring that to these patients. But if you see this patient tomorrow and you don't have the skill set for awake intubation or fiber optics, not the place to break it out. One thing that we need to make sure we're doing while we're resuscitating, while we're setting up for our airway and getting that airway in place, is to make sure that we also have a second operator ready for front of neck access. This is really critically important because you might not predict anything, but then you get in that airway and you're like, oh, I can't intubate from above. And we need to have somebody ready to cut the neck. Again, if you're working as the only clinician, there is no other backup, then you're going to need to be ready to cut the neck if you can't intubate from the top. So this is going to be a really important thing to make sure you have planned out. And I like to communicate this to my team. I'm going to do this for my airway. If that fails, then I'm going to move down and I'm going to do a front of neck access. Or I'm going to do this for airway. And then I've got Dr. Smith ready if I fail, and she can then cut the neck and go for front of neck access. So we really need to have this plan well spelled out. Now, how do I approach these patients? Most of the places I work, I don't have fiber optics. My skill set is probably not as good on fiber optics as I'd like them to be. So I'm not usually reaching for that. What I prefer is to have a standard geometry video laryngoscope. I've got a nice big screen, and so everybody can look at that screen and see what I see. They can see the airway anatomy. They can see some injury patterns as we go in for that airway. And that allows me to be able to see everything, but also rapidly switch to direct laryngoscopy. So standard geometry blade, video laryngoscopy. I'm going to have a bougie ready. I'm always going bougie first for my intubations. And then as far as meds, I'm typically going with a ketamine only approach here, or a ketamine facilitated intubation. This isn't truly awake, but I'm not paralyzing the patient. And the reason I'm not paralyzing them is because I want to maintain that airway structure. If they keep the patient awake, more likely we maintain whatever airway anatomy that patient has. So we give the dose of ketamine, we go in with our standard geometry blade, and then we try to deliver bougie and then tube over bougie. But while I'm doing that, I will have my backups in place, especially rocuronium. I will have a dose of paralytic ready. And there are two situations where that rocuronium can be helpful in this ketamine facilitated approach. If I go in from above and I'm having trouble delivering the tube despite having a good view, well, now I can paralyze the patient and deliver that tube. Fantastic. But there's also a situation where I go in from above and actually I can't intubate the patient. There's an obstruction. And now I'm going to need to go to front of neck access. That is much easier done with a paralytic on board. So I have my rocuronium ready, but I'm going with a ketamine facilitated approach, standard geometry blade, video laryngoscope, bougie first, tube over bougie, and the rocuronium ready in case I fail. All right, so that's our airway approach. Again, making sure that we have a structured approach to getting this done, knowing that we have our backups in place, we have somebody ready for front of neck access, and again, doing what we are comfortable with. Now let's move from there to the hard signs. And in the past, when we heard about patients with either stab wounds or gunshot wounds coming into the ED, we had a couple of questions we would ask. First was mechanism. Was it a stab wound? Was it a gunshot wound? And we thought this was important because it would predict or help us predict what injuries we would see. We know that's not true. Even if a patient has a stab wound, they can have considerable amount of damage that we might not be able to predict just by knowing that it was a stab wound. And yes, gunshot wounds have a lot of energy around them. They can ricochet and cause a lot of damage. So it's not that this information is useless, but it's not nearly as useful as we thought it was. The other thing we would often ask, either to our EMTs or look and find out as soon as the patient came in, is what zone was the injury in? And we thought these zones would help us predict injury patterns and then destination for the patient. The old kind of way we looked at this was that a zone 2 injury, there was so much that could be damaged there, all those patients needed to go for neck exploration. What we found out over time is that if we take every zone 2 to the OR, we've got about a 50% negative exploration rate. Probably a little bit too high. Our colleagues in trauma are not happy with that. So instead of going with this zone approach, what we should be really looking at is a no zone. And that's where hard signs come in. Instead of looking at where the penetration into the neck was, let's look at signs that we see on our physical exam that might help dictate what management this patient's going to need. And we find this is a much better way to predict where the patient needs to go safely. And that's why we focus on no zone as opposed to these first, second, and third zones, or zone 1, 2, and 3. And a lot of this is predicated on the fact that the external wound we see is a poor predictor of what's actually injured underneath. Now, while we have that patient come in and we have that team looking at the patient doing the primary survey, there are two challenges that we often see. One is that we get distracted by the neck injury and forget to look all over the rest of the body for other injuries. And the other is that we don't see the neck injury because it's hidden under a C-collar. And there is no role for C-collars in patients with penetrating trauma. We've got good evidence that tells us patients who have C-collars and penetrating trauma experience increased mortality and morbidity. This hides wounds. And while it might seem ridiculous, it can hide a large wound. So we have to make sure that the collar never goes on, or if the collar went on before the patient came to us, that we take it down and look underneath early on, and then don't put it back on. There's no role for it. Now, once we see these big wounds, let's not get distracted. Let's do our good trauma management, meaning a good primary survey, a good secondary survey, looking for all of the different injuries that could be there. And then focusing on things that, again, we know are important in trauma. So activating our massive transfusion protocol, giving the patient tranexamic acid. Don't lose the forest through the trees. Make sure we do good trauma management, basic trauma management. And then now we can focus back on that neck wound. And what we're going to do is look for hard signs, the hard signs of vascular injury, as well as the hard signs of aerodigestive injury. The hard signs of vascular injury, again, these are going to help to predict the course of the patient. So the patient has an audible bruit, if they have shock with no other source of bleeding, if they have pulsatile bleeding, if they have any neurologic symptoms, because neurologic symptoms in a penetrating neck wound, that's a vascular injury, not a neurologic injury. And then also if the patient has an expanding hematoma. If they have any of those signs, that's a hard sign of vascular injury. Expanding hematoma, pulsatile bleeding, shock with no other source, and audible bruit or focal neurologic deficits. Hard signs of vascular injury. And then we're going to look for hard signs of aerodigestive injury. These are the patients that have an airway obstruction. They have a bubbling wound, extensive subcutaneous air, stridor, or they've got significant hemoptysis or hematemesis. Now, a little bit of hemoptysis or hematemesis, not such a big thing, but if you look at that airway and you're like, that's a lot of blood, that's a hard sign. So hard signs of aerodigestive injury, airway compromise, massive subcutaneous air, a bubbling wound, a patient who has stridor, and then significant hemoptysis or hematemesis. And if we see any of these hard signs, we need to know what's next. We've got a great little flow diagram in Corpendium. Let's focus in here. If the patient's hemodynamically unstable, if they have hard signs of vascular or aerodigestive injury, there's only two destinations for that patient. They either go to the OR or they need to go to angio, the angio suite, not CT angio, angio suite. Now, there's a third option as well. That's the patient who is in a place where you don't have trauma surgery, you don't have an OR. That patient needs to be transferred to wherever that OR is. So if the patient has hemodynamic instability, they have hard signs, then either OR, the angio suite, or transfer for an OR. If the patient has one of these signs and you're going in that direction and you haven't controlled the airway, this is the time to do it. We really don't want to send these patients out of our resuscitation bay without a managed airway, because even in the time it takes to go from your resuscitation bay upstairs to the OR, they can decompensate. We don't really want to intubate in the elevator. So this is the time to take that airway. And especially if you're going to be sending the patient in an ambulance, you're going to have a transfer time, I would take the airway at this point if you haven't done it already. Now, the patient doesn't have any hard signs. We can look for soft signs, and the soft signs are tested and you need to know them, but they're not as important to me. What's important to me is knowing what the hard signs are. I'm going to mention the soft signs because there's some overlap that we need to be aware of. So an expanding hematoma is a hard sign. A non-expanding hematoma, that's a soft sign. So non-expanding hematoma is not necessarily an indication to go directly to the OR or angio. Things like hoarseness or dysphonia, that's also a soft sign. Vascular bruit or thrill that are palpable, that's a soft sign. Crepitus, but not massive sub-Q air, same thing. So we need to understand that there's some overlap between these and it's really extremes. Now going back to that Corpendium flow diagram, if the patient has no hard signs, they should go to CT angio. CT angio of the neck is extremely powerful in finding out what's injured and does the patient need the OR? Does the patient need angio? So the patients with hard signs, directly to the OR, going to the angio suite or transfer for OR. The patient who has no hard signs, they can go to CT angio. The caveat to that is if you're going to transfer that patient because you're not a trauma center, don't get the CT first, just transfer them. You might still have to manage that airway depending on how long your transfer times are and what your predicted course is, but you don't stop in CT first. Just send them over to the receiving center. And remember that even if they don't have hard signs, these injuries are dynamic. They can shift, they can change. The non-expanding hematoma can become an expanding hematoma. The little bit of sub-Q air can become massive sub-Q air. So keep an eye on these patients and understand they can decompensate and they might still necessitate that airway. All right, so those are the hard signs. Remember, aerodigestive hard signs, these are things like massive sub-Q air, a bubbling wound, if we see stridor, and if they have one of those hard signs, or the vascular hard signs, pulsatile bleeding, expanding hematoma, focal neurologic deficits, shock without another source of bleeding, those patients need to go directly to the OR or to the angio suite or transfer to wherever you have an OR. In the absence of hard signs, and the patient's stable, you can go to CT angio first. All right, finally, let's talk a little bit about hemorrhage, which again, I think is a simple thing and yet gets done wrong many times. We're very good at managing hemorrhage from an extremity wound. We know now that tourniquets save lives. They reduce mortality, they reduce morbidity. This is limb and life saving. If we put the tourniquets on early, we can help people. We know this. Unfortunately, neck wounds, they're not so easy to put a tourniquet on. Tourniquet's likely going to kill the patient from strangulation. And this isn't just a problem at neck injuries, it also is a problem in other junctions. So if you have a patient with an injury to the groin or the axilla, we can have the same issues. So a tourniquet's not going to work. But we do have a tool that can work extremely well here, and it's your finger. One finger. This is how we can control hemorrhage in junctional bleeding, neck, axilla, groin. One finger, we're going to put it in that wound, we're going to hold, we're going to compress, we're going to stop the bleeding, and then that finger is not going to come off of that wound until we get to the operating room. Every time you remove the finger, the patient bleeds. There's no reason to take it off. So we're going to put one finger on the bleed or where the bleed is coming from, hold pressure, and not remove that pressure. And this doesn't mean putting a wad of gauze on the patient and then pushing down with your hand. It's one finger because this gauze hides blood, hides bleeding. It doesn't fix bleeding. So one finger, pressing down on the wound and leave it there. Now, sometimes these patients have really deep neck wounds and you can't get down there with their finger. Then you have to use a finger extender, which is basically a Foley catheter. Take a 14 French Foley catheter, shove that Foley catheter into the wound, and then you're going to expand the balloon, and that's going to give you tamponade. If you can't get tamponade, or you put that Foley catheter in, you blow up the balloon, they're still bleeding, you can put a second Foley catheter in. And between those two Foley catheters, you're gonna get control of bleeding almost every time. So finger first. If the finger doesn't work, Foley catheter, blow up that balloon, and then you can follow that with a second Foley catheter if necessary. And that really brings us through the three things that we need to focus on. So going back to airway, remember, not every patient with a penetrating neck wound needs an airway, and not everyone needs an airway emergently. Some of these patients can be delayed. Whatever you think, if you think the patient needs that intubation, they have an obstruction, they have problems with oxygenation or ventilation, resuscitate the patient to get past some of those physiologic challenges, and then have a structured approach to taking care of that airway. If you're not comfortable with fiber optics, don't reach for it now. If you're not comfortable with a ketamine facilitated intubation, don't do it now for the first time. Do what you do best, and most of the time that's going to be successful. But always have that double setup ready for front of neck access. When it comes to hard signs, this is where we should focus instead of the zone 1, 2, and 3 injuries. Remembering that the external wound doesn't predict what's injured underneath. Instead of that, we're going to focus on hard signs of vascular injury. So this is pulsatile bleeding and expanding hematoma. If the patient has a focal neurologic deficit, if they have shock without another source of bleeding, or if they have an audible bruit. And we're also going to look for the aerodigestive hard signs. Airway compromise, if they have massive subcutaneous air, a bubbling wound, if they have stridor, those patients are going to need an airway, but they also need to know where they're going to go next. Hard signs, OR or the angio suite, or transfer for the OR. Patients without hard signs, you can go to CT angio first to figure out what's going on, what's injured, and then get the patient to the operating room. And then finally, hemorrhage control. We can't slap a tourniquet on the neck. And so we're going to control bleeding with one finger pressing down in that wound. Don't remove that finger once you get control. And if you can't get deep enough with that finger, then you're going to take a Foley catheter, throw that in, blow up the balloon for focal tamponade of the bleeding vessel. Thank you guys very much. I think if we can control these three areas, if we're comfortable taking care of these three issues in in penetrating neck injuries, we're going to do a lot of good for our patients while the rest of our team manages the other problems that are going on.
All right. Well, nothing like a little neck trauma to get us started, and nobody better to start us off than Swami. Thank you, Swami, for that talk, and lots of good stuff going on in the chat. Swami did a great job of addressing a lot of that stuff. We're also writing these questions down, and we're going to do our best to address all of them in the future segments. But right now, we're going to change gears a little bit and start our first session of radiology rounds. So now to talk to us today about this is Andy Perrin. So Andy is currently the Associate Dean for Graduate Medical Education at Dartmouth. Prior to that, he was the Program Director at Maine Medical Center in Portland, Maine for almost 20 years. So Andy and I went to med school together. He was struggled a little bit at the end of medical school with what to do with his life, and decided, despite my strong suggestions otherwise, decided to go to the neurosurgery route. So he spent about 3 years of his post-medical school life focusing on neurosurgery before he saw the light, came into emergency medicine, and the rest is history. But he's got a lot of good experience with reading head CTs. And I got to say, I feel like, sure, I can see those big Goombas on the head CT and know what to do then, but there's a lot about reading head CTs that I feel pretty inadequate at. So Andy's going to correct all that for us and tell us everything we need to know as emergency providers for a head CT. So Andy, tell us what we need to know.
Hey, I'm Andy Perrin. I'm an emergency physician at Maine Medical Center in Portland, Maine. And my dirty secret in life is that I started out in life as a neurosurgeon. And as part of that job, I had to teach myself how to read head CTs. And so this skill I kind of honed over time and did some writing and research on it. And I'd like to share that with you guys today. So I want to talk about emergency imaging and reading a trauma head CT. Now, the goals of this talk are really simple, but really important in my mind. So one is, I think any emergency physician should be able to pull up a head CT and figure out, is there a life threat there? Is there something that I can't wait for somebody to call me about? If I'm a sender, I want that patient gone long before I get the phone call. If I'm a receiver, I want that patient in the operating room before I get that phone call. But the idea is that there are some basic things that we should all know what they look like on a head CT so that we can see them and call them and then move on and take care of the next patient. Some other goals of this talk, we're going to learn to differentiate some of the common diagnoses. How do you tell an epidural from a subdural? How do you tell a subdural from a contusion? Try to identify some pitfalls that people sometimes fall into. And then try my best to not turn this into a boring radiologist lecture. Here are the stated not goals of this talk. We're not going to debate who needs a CT. We're not going to decide whether CT and radiation is good or bad for people. We're not going to decide whether CT is better or worse than plain films. We're not going to decide today whether we order too many or too few CTs. We can all agree CTs are expensive, and we can probably all agree nobody does a physical exam anymore also. But those are not the goals of today's talk. So, you're an emergency physician, bad things happen. Patients get brought to you, you run into the room and you do stuff to those patients trying to figure out what's going wrong and try to stop it. Everybody gets one goal in life, which is to get the patient from that room to this room. We get the patient to this room. They push a button, a bunch of things happen. And then what you hope, because what has happened usually in your training program, is that those have been magically beamed over some dimly lit, climate-controlled room where there's hushed whispers going on and people are consulting, or there's a whole wall of pictures that people are pointing at, or I sometimes get this person who barely grunts at me when I walk in the room, but at least will look at them for me. But that may not be your practice situation when you get out of residency. You may be in my state and you may have taken your first job up here in Fort Kent. And so you have that bad accident happen, that patient comes to you in Fort Kent. You have to get that patient down here to me in Portland, Maine, which is 5 hours and 5 minutes away. And what you don't want to do is waste the first hour to 2 hours awaiting a read on a head CT that you could have already had that patient about halfway down the state to me in that time. You're also not going to get that nice climate-controlled room. This is where you're going to look at the CT. This is my ED where I work, and you're going to have somebody trying to get you to answer the phone. You're going to have somebody else telling you why they can't admit your patient. You're going to be working between the Tupperware and the bag of looks like a tired sandwich, and you're going to be looking at that CT in a brightly lit room with 1,000 other things going on, and you're still going to look at it and make the right call. So here's the issues with trauma patients, right? The clock is ticking. We only have so much time to fix important findings. And there are definitely some things that can wait for Nighthawk or some off-site radiologist to read, but there are definitely things that cannot wait for Nighthawk to read. They do not share a lot of data, these off-site reading services. There was a 2009 study where they did it was a report of their time, and they showed that about half the CT studies were read by a teleradiology service within 60 minutes, which by my simple math means 50% were not read within 60 minutes. A 2010 study reported there was about a 1 in 20 or 6% chance of major discrepancies between the offsite read and a local read, and about 1 in 5% chance of a minor discrepancy. Again, back to the first premise, you don't have an hour, you don't have 2 hours, and you don't want to miss major discrepancies. You just should know how to read the life threads, and that's why we're here. The only other thing I could find on it is not literature, it's an ad to decide how long does it take to get these off-service reads, and it's from a service that's advertising why you should go with them and not Nighthawk, and they say that Nighthawk is going to take you up to 2 hours to get a preliminary read. Again, you don't have 2 hours. That's why we're here. So there's a lot of systems described. There's, for looking at imaging, inside out, top to bottom, organ system based. My favorite, blood can be very bad. And they are great in certain situations, but if you have to make a quick read and make a decision, you're going to be busy for a while if you use an organized system like that to look at a whole CT. So for this kind of imaging, I would go with what are the things that I need to know about and do something about right now. And it's really based on the head CT in trauma on one simple premise. You need to be the blood hunter. You need to find blood. When you find blood, you need to figure out what kind of blood it is and what is it doing. While you're there, you're going to look for some other stuff too. You're going to look for some skull fractures and pressure and shift, but you're not going to miss blood, because in the trauma head CT, that is really important for us to know about, is blood. So when I walk away from that monitor, that they didn't have an epidural, a subdural, a skull fracture, I don't see a contusion or a traumatic subarachnoid, and they don't have pressure or shift. Those are the things I want to know when I walk away from a trauma head CT. You have to do a little bit of review just to remind people what the brain looks like. We see so many traumatized brains. This is what the pristine, uninjured brain looks like. Starting down lower, we have the brain stem. We have the lateral ventricle peeking in here. We come up. We have the quadrigeminal cistern, the sylvian cistern. We see denser, hence lighter than subcortical white matter. The brain is beautiful. It has side-to-side symmetry, so you can look for abnormalities. If you see something odd on one side, on this does mostly clot, but this area right here hasn't actually clotted yet. Blood becomes isodense with brain somewhere around a week. It depends how fat the clot is and how big it is, but somewhere around a week is when we think about blood getting isodense. And somewhere around 2 weeks is the time when you can pretty reliably say that blood is probably going to be hypodense to brain. So we're going to start with epidural, the things we're going to tick off and know that this patient doesn't have. So epidurals are described as lens-shaped. They do not cross sutures. The main sutures in the brain are the coronal suture, which comes across here, and the lambdoid suture, which comes across here. Since it's above the dura and the dura is tacked down at those sutures, it is an epidural collection of blood. It's classically described as the direct blow to the middle meningeal artery, but you can do it with veins, you can do it with other arteries, it can be in other locations, but that's just the classic description. And neurosurgeons love epidurals, mostly because if you can get that epidural out of there before that person loses consciousness from this epidural, they're going to generally do really, really well, because it's really more of a blood problem in the wrong place. It's not so much a brain problem, it's a blood problem. And if you get rid of the blood, the brain is generally pretty happy in most situations. So let's look at some different epidurals. So again, lens-shaped, lens-shaped, lens-shaped. It doesn't go past a suture. There's some mixed density in here, so it's not fully clotted. So you've figured out there's blood. You've figured out what it is. It's an epidural. And the third question is, what is it doing? Well, this one on this side isn't doing that much. There's a little bit of midline shift there, but look at this one. This clot, you say there's a clot, it's an epidural. Oh, and by the way, look at all this. This lateral ventricle, the right lateral ventricle is still there. The left lateral ventricle has been completely compressed and midline has shifted over. So this person's going to generally be doing better than this person. This person needs an operation fast to do well. Some other examples. Here's another one. Again, it's not going to cross this suture. It's not crossing this suture, so it's an epidural collection of blood. This one has started to liquefy a little bit in the middle, and it doesn't have much mass effect. And again, here's another one, lens-shaped, tacked down at the dura. And again, this one is less worrisome. They're all going to need a brain surgeon, but this one is not causing a lot of pressure or shift. This is kind of a summary of why neurosurgeons like epidurals so much. Look at this. This is a pediatric one. This is a patient I took care of. But if you look at this scan, you get the sense, this is before you get into the clot, but you can already see there's a problem on this brain. There's shift over to here. This is the left lateral ventricle. This is the right lateral ventricle. There's no posterior horn. It's been effaced. But something's going on over here. The next cut shows you what that something is. It's a huge epidural collection. That's, again, lens-shaped, tacked down at the dura. It's mixed density, so it hasn't fully clotted yet. And you see almost half this brain is clot on this patient. But the patient actually clinically was not great, but wasn't terrible. So the patient came to us. We got the patient to the operating room right away. This was the immediate post-op CT right after they got out of the operating room. And you can already see there's a little bit of blood left here, a little bit of air, so you know somebody was in this skull. But look at the brain has bounced back. And then the winning picture is the 1 week post-op. If you look at this CT 1 week post-op, it looks pretty much perfect. There's no shift. Everything is back in midline. The brain is not injured. And this patient actually went on to do well. So that's the epidural. Let's talk about the subdural. And I'm talking specifically, we're going to talk about acute subdural because the acute subdural is a really bad actor. So typically these are going to be sickle-shaped or falx-shaped, and they're going to cross sutures. Here's a suture here. Here's a suture here. They're below the dura. The suture's only tacked down above the dura, so the blood can track below the dura. So it will cross sutures, generally won't cross midline. The difference between the acute subdural and the acute epidural is the acute subdural is a marker for really severe head injury. And the mortality for these people is much higher than those with epidurals. Now, this is different entity than the chronic subdural, which is if you do something slowly to the brain, it can deal with it. But if you get a bad enough whack on the head and you accumulate this amount of blood, not only is the blood the problem, but all the brain under here that's been damaged is really in trouble. So these generally are bad actors. So the subdural, again, falx or sickle shaped, you're a blood hunter. So you didn't miss the blood, you see the blood. What kind of blood is it? Well, that's subdural blood for sure, because it's crossing sutures left and right. And what's it doing? Well, this is unhappy brain. Here's the posterior horn of the left lateral ventricle. The right side is gone. There's obviously been a skull fracture. But the problem is all this brain under here is going to be injured regardless of taking out, if the surgeon takes out or when they take out this clot. The problem is all this brain under here has probably sustained a really bad injury. Another example here with subdural crossing sutures, loss of this lateral ventricle, really no gyral pattern left. This is the look of a tight brain, and you see this kind of homogeneity in here. This is all injured, edematous, unhappy brain. Another subdural, just an example here, coming all the way from front to back. Another subdural, again, you're the blood hunter, you find blood, it's subdural. This person's probably doing a little better than this person. Midline isn't so far off on this person. If you look at midline on this person, here's the midline, that's the septum pellucidum there, that should be in the midline there. So this person has a subdural with an acute subdural with a huge amount of shift. Just an example of walking through a CT with a subdural, the sequential cuts. So blood, subdural, crossing sutures, what's it doing? It's really pushing this midline over. So this is unhappy brain that's getting pushed over, midline is shifted over, big acute subdural. They're not going to do well with that. And this is why, again, so you go in and you say, well, I took out that epidural and I saw how beautiful that kid's brain looked immediately post-op. And then 1 week later, it looked like normal brain. The difference with the acute subdural, again, is it's a marker for somebody who's been whacked in the head really, really, really hard. So you go in and you take out this clot, which is the right thing to do. But the problem is all this edematous brain starts coming out through the craniectomy there, and you can't get it back in because it's so edematous, and it's probably not going to be viable. All this brain in here, it's been so injured. That's the difference. That's the fundamental difference why 20% of people with epidural do poorly, but 80% of people with the acute subdural do poorly. And then again, just to differentiate chronic subdural, if you do something slowly, if you accumulate fluid in the brain slowly, it can tolerate that much better. So you'll see people walking around with big chronic subdurals. You'll know it's chronic because it's hypodense, it's lighter, it's less dense than the brain. It's a subdural, it's crossing sutures. And these generally do okay with, with drainage, with burr hole drainage by neurosurgery. Skull fracture, ironically, skull fracture, when we first started doing CT, we got dumber about finding skull fractures than we had been, but that's over now because we have scouts and recons and you can always find the fracture. But you just need to know where the sutures are. You can look for sutures, they're symmetric or they're usually pretty symmetric. You just know the anatomy of where they are. You can get a fracture anywhere in the bony skull, obviously. If you see air anywhere on the inside of the skull, that means by definition, there's a skull fracture and a tear in the dura because it had to get from outside to inside somehow. And so once you see air, if somebody has an open skull fracture, you just got to find it. And then basilar skull fractures, they can fool you a little bit. They're a little bit harder to find. The bone is real dense at the base of the skull. And so they can sometimes hide basilar skull fractures. And so we'll look at some of those in the pitfalls. So the first thing you want to do is if you're looking for a skull fracture is window your CT so that you can see the bone. This is the cut on the left and on the right. It's the same cut, but on the left it's windowed so you can get nice detail about brain and know what this person has done to their brain, but I can't tell you really anything that's going on with the bone in here. So then I just need to go up on my whatever application you use to look at x-rays and make sure you tell it, I want to window this for bone. And then you can see the segmental fracture right there that you just wouldn't pick up otherwise. So window it appropriately so that you can find a fracture. Here's just some, these ones you're not going to miss, but when you window them, they show up nicely. These are depressed skull fractures, a little bit of air inside here. So clearly there's an open fracture, depressed skull fracture here. I don't see air on the inside of the skull on this one. Basilar skull fractures, like I said, the bone in the base of the skull is really, really thick, and you may not get a lot of movement at a fracture line, and you need that movement in order to see a fracture. So I have two examples here. On the left is this patient who's been in an accident, and I can tell you they have a basilar skull fracture. I cannot tell you where it is, but I know it's there because I see these nicely aerated cells over here. This is the petrous portion of the temporal bone, and over here they have blood in them. So if you have air it's supposed to be full of air, clearly something happened in here to cause the bleeding. The thing that happened is they have a basilar skull fracture. There just hasn't been enough movement at that fracture line yet to see the fracture line, but there's a fracture in there somewhere. The blood in those air cells is telling you that. This one, you can see it. You can tell the difference again. I see some nicely aerated cells over here. There's blood in these cells. They're not nicely aerated like these, and I can see the fracture line running right through there. Just a couple examples. Again, if you can't find the fracture, but you see air, either these small dots of air here, these bigger dots of air here, there's a skull fracture. There's a communication from the outside world to the inside world of this person's brain. Even if you don't see it, it's there. And then, like I said, in the modern era with 3D recons, you physically can't possibly miss a skull fracture. They certainly show up nicely, and it's not nearly the problem that it used to be. Contusions, you want to know what a contusion looks like. They will look like a high-density area. They're going to be hemorrhagic contusions, and they're going to be at places where the brain and bone come together in disharmony. For instance, you're driving along at 80 miles an hour and you run into a bridge abutment and you decelerate your brain into the front of your skull over the course of 1/10 of a second. Where that brain and that bone comes together, there is going to be hemorrhagic contusion. It's going to be an immediate phenomenon, so it's not something that develops later. You'll see those pretty much right away. They're going to get bigger over the next few days, but you'll see them pretty quickly. But you're going to look for those on the CT where bone and brain can come together. Well, where does that happen? That happens at the temporal tips here. So we know the sphenoid bone reaches across like here, like that big arch. And when you slam this brain forward into that sphenoid wing, there's going to be hemorrhagic contusion. There's also going to be frontal contusion where the frontal lobes slam into the front of the skull, or on the bottom of the frontal lobes where they bump across the ridges that make up the base of our skull. And that's what you see on this person here. These are subfrontal contusions, where this person decelerated their brain and it went bump, 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 bump over the ridges of the bone, resulting in hemorrhagic contusion. A little more subtle on this side. So you think about this also in like coup contra coup injuries. So if you get hit on one side, you can get the contusion showing up on the opposite side. Just it's an area of hemorrhage, dense hemorrhage in an area where brain and bone came together. And these are just examples of the, again, temporal tip contusions, where that temporal tip slides forward into that sphenoid wing. A couple other examples. Here's a contusion. There's also subarachnoid, traumatic subarachnoid in this patient. You see it here, ringing the midbrain. You see it here, layering out in the cortical surface, and here layering out in the cortical surface. That's traumatic subarachnoid with a big hemorrhagic contusion. And once again, contusion, traumatic subarachnoid, traumatic subarachnoid, traumatic subarachnoid with a subdural. And then pressure and shift. CT scans are not good for subtle pressure. They'll show you subtle shift, but they're not always a good indicator for subtle pressure. When there's high pressure, you'll see it, but if it's subtly elevated, you may not see it. What you're looking for is loss of cisterns and sulci, compression of the ventricles. You know the falx should be midline. You know the septum pellucidum should be midline, so those are markers for shift. And you can do side-to-side in comparison, which is nice, at least if you have a unilateral process. So here's two scans, two different patients at about the same cut on the CT scan. They're a little bit older, but they really demonstrate this principle nicely. This is a 29-year-old male. This is a 39-year-old female. If anything, a 39-year-old female should have more room in her brain than a 29-year-old male. And when you look at this brain, the one thing that stands out to you is you should say tight. That is a tight brain. You see the third ventricle here is completely compressed. The quadrigeminal cistern, which I can see on this 29-year-old, you maybe catch a hint of it right there, but it's about gone. There's no lateral ventricles. You see a cortical gyral pattern here. There is no cortical gyral pattern here. So you should look at this scan and say, that is a tight brain, and this is a less tight brain. Again, you should look at this, and your first gestalt should be, that is a tight brain. I see no cortical gyral pattern at all. I don't see any cisterns. There's no sulci. There is nothing. This brain is pressed as tight as it can be against the inside of the skull, trying to burst. And it doesn't have to be a bilateral process. Here's somebody with a unilateral tight brain. You can see as you get up to the higher cuts, they preserve their gyral pattern over here on their left, but there's a process going on the right that is causing increased pressure on the right. Now, they have not shifted midline, so it's not shifted midline yet, but they definitely have a pressure process on one side that is not going on the other. And then shift, you can find something that's supposed to be in the midline again. So you know the bone from prominence to prominence, that's the midline of the skull. And then you want to say, well, where's the midline of that brain in relationship to the midline of that skull? Find something that's supposed to be midline, like the septum pellucidum again, and you can simply measure that distance. That tells you how much shift. It doesn't matter specifically how much shift. You should look at that and say, that's a lot of shift from this subdural right here. Here's a patient with an isodense subdural right there that is causing shift. You can see this lateral ventricle is gone and the midline bows over right here. One quick test slide. Take 30 seconds, look at it, think about what you got. I'll tell you what I got. So I have two things. I have an epidural back here. So it's tacked down at the sutures right there, tacked down at the sutures. Doesn't have to be middle meningeal. They don't all go from coronal to lambdoid suture. This goes from the lambdoid suture back posterior. And there's contusions. There's temporal tip contusions and there's subfrontal contusions. So you got a bit of an epidural and some contusions. It's a tough one. So your job is to find blood, be the blood hunter. You look at a CAT scan, you want to walk away from that monitor knowing that they did not have blood on their scan in the trauma situation. If you see blood, figure out what kind of blood it is and what is it doing. Make sure you look for skull fractures, window it appropriately, think about pressure and shift. We're emergency physicians. We find the life threats and we act on them without any, don't need anyone to help us doing that. What we are not is neuroradiologists, and that means we are going to miss things like tectal plate lipomas and agenesis of the corpus callosum and cavum septum pellucidum. And that is totally okay. Nobody dies from those things waiting a wet read or a final read or a 10-day later read, doesn't matter. But our job is to find the threats, figure out what they are, what they're doing, and then if we're senders, get that patient to a place where they can get help. If you're receivers, get them to the right caregiver and hopefully into the operating room, especially for things that we can impact with operations. I appreciate your time. Feel free to email with any questions. I'm always happy to answer whatever I know. These are ways to get a hold of me. Thanks a lot.
So that was awesome. I got to say, I have heard Andy speak on that subject for years now, and I still learn something new every single time he talks. So thank you, Andy. Great job. We've got a couple minutes now for some updates, so let's go to Britt and see what we need to know now.
So a couple of things on the app and slides. A few questions are coming in about that. So on the app, if you go to the schedule and click on the lecture, on that lecture, you will have an area where you can submit questions. So you can do questions either through the app or through the live YouTube chat. And then just below that is a link for documents. And if there's slides for that lecture, they'll be already downloaded right there. You can also, this link for the YouTube will go live. You can watch this over and over and over again so you can see the conference there. Or the slide material will also be, all the lectures, all the content will be uploaded after the conference onto the EMRAP HD website. So hopefully that's clear where to find them. The slides are all available to you. a couple questions have already come in. Actually, a ton of questions have already come in. One of which was the bougie. Now, Chris, are you using the bougie every time you intubate? Is this just your rescue and it's kind of collecting dust in the corner? How frequently are you using bougie?
So I am using bougie virtually every time we are intubating now. And one of the benefits of age, and I'm looking for any benefit I can find, is you get a perspective. And when I started off in emergency medicine, it was before the time of the bougie, and I think it really has, in many ways, revolutionized airway management in the emergency department. We were probably in Denver, where I trained and I did my early part of my career. We were probably doing maybe a crike a month or so in the emergency department. Come along the bougie, and it's been almost zero. It really has almost taken cricothyrotomy outside of some of those extreme situations like Swami was talking about earlier. It's really taken cricothyrotomy out of what we're doing on what was then too regular a basis. And so I really think it has changed management. I really encourage our residents to use this on every intubation. I feel like if it's going to be your backup, you're going to have to know how to use it. And so I really do use it for really every intubation at this stage. What about you, Britt? Do you guys use it?
Yeah, I mean, I think it really should be used almost every time, and especially early learners. If that's your backup and you don't have the hand-eye coordination, I mean, it can be a little fumbly to use at the beginning, and especially just like using the bougie and feeling those rings, that vibration. I mean, that touch is very important. So I think practice it even on the easiest, most straightforward airway, because when you need it in a pinch, you're going to know how to use it.
I agree. I think a lot of times too, the muscle memory is slightly different. So, you're leaving the blade in until you get the tube passed. And so practicing that, because otherwise you kind of default to your muscle memory from using a stylet. So I think being proficient at both is helpful.
Okay, so this actually hasn't been entered into the chat yet, but I know Chris pretty well, and he's got some opinions. And one of those opinions is on how much he loves the C-collar. Did I get that right?
So thank you for indulging me for just a minute to me that we are using what I think is probably nothing more than a sanctioned torture device on our patients. And we have allowed this to stay a standard in a time when we're demanding better science. And here is something, there are some significant concerns with C-collars. They probably increase intracranial pressure. They decrease venous return. They complicate airway management. There's been no data that shows it actually restricts spinal motion. And yet we are nowadays, particularly without needing to sedate somebody, simply because I had to put it up over their face so they blocked out the light and they could go to sleep. And it's probably the best use of the C-collar I have seen in a long time. So we do have some better data now and good position statements that are out there that have said we should just get rid of it for all penetrating trauma. We don't need it for in that scenario. That once we have a CT scan that doesn't show any C-spine fractures, we can get rid of it in that setting. We don't need to wait for the MRI. Yes, they could still have some ligamentous injury, but we have good evidence now from my perspective that the C-collar is offering no benefit at all. And I realize that I don't have enough data to be able to convince you to just get rid of it on every single patient. And we haven't quite done that even in my own emergency department yet. But I would ask you to, let's rethink this, recognize that the data just doesn't support the amount that we are continuing to use it. There are some risks with it. And for every patient, we have to do this across the board, right? We have to balance the risks and benefits of what we do. And I would argue that the risks of the C-collar in many of these situations where we're using it are greater than the benefits that it's providing. It really has come down to, it's reminding us that we haven't cleared the C-collar yet, and I believe we have much better ways of doing that. So I just asked you to consider that, get rid of it in penetrating trauma, get rid of it once you've done that CT, but even in those other settings, balance that risk-benefit ratio with our C-collars, and maybe, just maybe, we can find more situations to get rid of this torture device. So anyway, that's my quick rant on C-collars. We got lots more coming up. Right now, we're going to move into our vascular session. So I'm going to ask Mel to introduce our next lecture.
Our next lecturer is actually a vascular surgeon, Joe DeBose. I can't speak. I haven't got my words. So I'm going to ask you a question. Do you know the hard signs of vascular injury? Do you know the soft signs of vascular injury? Do you know what those sounds are when you put the Doppler on somebody's artery? Do you know what they mean? No, you don't. That's why we're going to have to do this lecture. Go, Joe.
For this segment of Consult Corner, we're going to talk about all things related to vascular injury. So, we're pretty used to having amputations and arterial bleeds coming through the trauma bay, but I have a feeling that the management of these patients is probably more complicated than me holding pressure and calling a vascular surgeon. So, here to answer all of our questions about vascular trauma is Dr. Joseph DeBose. Now, he is dual trained in trauma and vascular surgery, and he currently works at R. Adams Cowley Shock Trauma Center in Maryland. So welcome, Joe. Thank you so much for being here with us.
Thanks for having me, Brittany. It's great to be here.
All right, so I've got a ton of burning questions about vascular trauma, but I think where I want to start is just kind of presenting a vascular trauma case. We're running around the ER seeing a ton of patients. You're in between surgeries. What information do you need to know right off the bat? And is there some kind of systematic approach to present this patient to you over the phone?
Yeah, it's a great question. And we don't expect you guys to be vascular fellows in terms of presenting things to us. I think a great place to start is just helping us define the category. Where's the patient at in terms of the expediency with which we need to move to come and help you out down in the ER? And one of the easiest ways, the most tried and true, is to help us identify hard and soft signs of vascular injury. So what does that mean? These were categories that were defined in the 80s and probably even more loosely before to just help us identify the patients that need something now versus those that, like the soft signs, that need some additional imaging and help us figure out what's going on. The hard signs constitute active pulsatile bleeding, absent pulses distal to the injury site, expanding or pulsatile hematoma, a bruit or thrill at the injury site, and then unexplained shock. So if you come in with a stab wound to the leg and you've got a bunch of blood on your clothes, but shock from nothing else, that's what falls into that.
Stop right there. We're going to do a little bit of emphasis right here, right now. So hard signs of vascular injury equals a really high probability that this person has a vascular injury that needs surgery. And so no pulse distal to the injury, of course. Pulsatile bleeding, that's always a good sign. An expanding hematoma, so that means you're going to have to re-examine. A bruit or a thrill, so you can hear the noise over this injury or you can sort of feel it. That's bad. And then unexplained shock. After you've excluded everything else, this person's in shock, then you got to think about that there is a vascular injury. Okay, so they're the hard signs. Know them, memorize them, continue.
Soft signs are kind of those categories that say, this sounds suspicious. It's not an immediately threatened limb that needs to go directly to the operating room with no other workup, but we can get some more information to figure out what's going on and develop a plan. And those constitute diminished but present pulses distal to the injury site. And it's always useful to compare the opposite side in this case, right? Because people come in with diminished pulses because they have native atherosclerotic disease. So what does that mean? So compared to the other side, stable hematomas, proximity to major vessels. You guys know the anatomy as well as we do. Does the trajectory or the injury site look like it's near a vessel? Peripheral nerve deficits, because the blood vessels and nerves traverse the human body in close proximity to each other. So if the nerve is out, the blood vessel is likely to be injured. History of hemorrhage at the scene, which is often can be elusive, right? You cut off all their clothes, or the medics did at the scene. If they say there was a lot of blood everywhere and it's a single stab wound or a single open fracture, that lends itself towards additional investigation. And then just a suspicious fracture or dislocation can also mean that a blood vessel was kinked or injured in that process.
Soft signs of vascular injury. So you've got diminished pulses on the injured side compared to the other side. And these all suggest the possibility of vascular injury, but not like the hard signs. You've got a stable hematoma, it's not getting bigger. You've got an injury that's proximal to the vessels. You've got a peripheral nerve deficit because the peripheral nerves and the arteries often go together. You've got a history of hemorrhage at the scene, or you've got a high-risk fracture or dislocation. Okay, so they're the soft signs. Remember the soft signs and the hard signs. Okay, continue on.
So identifying those and communicating them to us is important. Other little tidbits to kind of consider is I mentioned comparison to the opposite side in a patient without vascular disease. Anytime you have somebody with a fracture, reduce that fracture first before you assess for the vascular injury as best you can, because if the blood vessel's kinked but not injured, it's going to implement some of these soft signs that really probably don't exist once you get the fracture reduced. And then other little factors that are not completely incorporated in the hard and soft signs, like refill, capillary refill, obvious pallor, if the patient has a skin tone that you can assess that. And then is it one limb colder than the normal limb? Those are all tells that help us put into a triage category how quickly we need to respond, and if we need to guide and work together with you to help identify additional imaging that might help us sort it out.
All right, I think that's super helpful. It sounds like, one, you've got two sides, so compare them. Know those hard and soft signs, and if there's something to reduce it, and then reassess.
Yes, ma'am.
All right, so my next question. This is about kind of that bedside Doppler. So say I have a patient and maybe they've got, a big open tib fib fracture, and I'm having a hard time feeling the pulse, so I get my Doppler, and I hear a faint pulse, but the foot is cold and I'm still pretty worried about this patient. So I call you. And you tell me, well, is it monophasic, biphasic, triphasic? Can you explain what that actually means, and does it matter?
Yeah, it matters some, but certainly what we're really trying to figure out is if there's any signal at all, and then really don't worry about the triphasic, biphasic. It's either monophasic or multiphasic, and the really only way. There's great ways to kind of do the impersonation of this, and I hope nobody, makes fun of me and this doesn't get dropped into some kind of pop track as a background beat. But the monophasic
We won't show anyone, I promise.
monophasic is just like it is. It's direction in one sound. It's like you're squirting a 10 cc syringe against the wall at the same pressure. It's just right. So biphasic and triphasic, you can think about it in some ways. If you remember how to float a swan and all those multiphasic signals that you see where the valve closes, the pathology here is a little different because what you're getting is elasticity of the vessel recoiling from the initial heartbeat of blood flow and then an initial additional push. So your biphasic would sound, and then the triphasic would be one extra added oomph to that. I got to clear my throat to do all these. I feel like I'm beatboxing. Yeah, right. This is going to be a great remix. It literally is like it sounds. You hear three distinct sounds, and it's much more subtle, but it's there you go. Drop the beats. So no one, even most vascular surgeons probably can't, with the bedside Dopplers you have available, can figure that out. If you have the vascular tech roll it up and you get nice audio and you get a waveform that corresponds, it's really just easy to assess triphasic versus biphasic. But if you can assess it's either present signal or no signal, or it's monophasic versus multiphasic, you are ahead of the game with regards to most of the calls we get. And the big thing is just establishing signal, no signal, because that tells me that the limb is either ischemic and I have a clock started to save that limb, or there's some blood flow that's getting by.
Okay, so kind of back to still palpating that pulse.
Yep.
If people, it's an older person, they have a lot of, claudication and atherosclerosis, it might sometimes be hard to palpate a good pulse. So if I'm having trouble palpating pulse, but I still get a pretty good cap refill on my exam,
yep,
does that rule out any serious vascular injury, or could you still get decent cap refill and have some terrible injury?
Yeah, it's a great point because these vascular injuries occur in a wide array of patients. Most of them are young patients who have no atherosclerotic disease. But if you get the 60-year-old who has a knee dislocation or a 50-year-old with a stab wound who's a heavy smoker, they may have at baseline monophasic signals with non-palpable pulses in the legs. If you have the chance to elicit those little bit of history, hey, did you have problems walking before? Did you have kind of claudication symptoms? That starts to build a presentation that you can kind of take into account and communicate to your vascular surgeon as well. The big thing in the early phases is just establish any evidence of flow. And the more evidence of flow that you have in terms of cap refill is great. A palpable pulse is even better. Multiphasic signals better than a monophasic. Building out that case, that implies that we have some time and the limb is getting some perfusion. It may not be optimal, and there may be a true injury there that needs to be addressed. But it will help us figure out what the expediency with which we need to respond and what additional, if we have time for additional imaging to help us figure out what we need to do.
Okay, so depending on the patient, it sounds like sometimes it can just be hard to palpate a pulse, but if there's good cap refill, that's at least a good sign in the right direction that there's probably not something catastrophic.
Absolutely. And another thing is to check the pulses proximally. So if you don't have pulses in the feet, feel up in the groin above the injury level. If there's no pulse there, then you have the right patient milieu, maybe atherosclerotic disease is an element of this that is masking the impact of injury.
So I want to shift gears a little bit and talk about knee dislocations. You kind of just mentioned it before, and this can be tricky. You know, if you have a patient come in who has an obvious knee deformity and no pulse in the foot, I mean, that's easy. We know what to do. Relocate the knee, try the pulses again, get them to the CT scanner and get a CTA. Okay. But what about, that there's always this fear that there's the dislocation in the field and relocation of the knee. And so when you see the patient, they tell you that they have, knee pain and they've had trauma to the knee, but it's not dislocated for you on exam and you feel a pulse. In those situations, who do we really need to worry about vascular injury on, and who needs to get a CTA and who doesn't?
Yeah, great question. So, with these knee dislocations, if they present you with a pulse or you reduce it in the ER and they have a pulse that comes back, that's a good sign, right? We know that there's some distal perfusion to the limb, but what we worry about are dissections of that artery. The artery gets torn, the layers of the artery, and that can come back to haunt us and cause some problems. So one easy way to do this, and this is a tool that can work for any vascular injury, is the ankle brachial index. Right. So, and it's referred to as the ankle brachial index, or it's the brachial index if it's comparing one arm to the other, or the injured extremity index. Sometimes you'll hear IEEE. But basically all you're doing is comparing a normal extremity in that patient to the abnormal extremity and looking for some discrepancies in terms of the ratio of the blood pressure that you're able to get using the Doppler and the blood pressure cuff. If that ratio, if it's less than 0.9, comparing the injured to the normal extremity, then you probably need to do some additional workup, and it's prudent to probably get some additional imaging. If it's above that, then you probably don't need anything, because there's no degree of injury. Any dissection is most likely to cause a ankle brachial index that is lower than 0.9.
Got it. And it sounds like, again, this is a good time to compare the other side, compare the other leg. Right. Okay. Yeah. So take that patient and you decide, what, the ABI is abnormal, we need to get a CTA. Mm-hmm. But now this patient's, 65, 70. We know they have known CKD. We get labs back, their GFR is terrible. And the radiologist is like, no, we can't give this person contrast. Yeah. Can we get an ultrasound? Is that good enough? And if the ultrasound's negative, can we stop there?
Yeah, I think if you can get an ultrasound by a formal vascular tech, the problem is these things occur at 10 p.m. or 2 a.m. And that vascular tech is a 9-to-5 job. It's a great job to have. And they're very good at most hospitals. And they're very good at what they do. And they can frequently image these things. But in the middle of the night, I can't wait 6 hours to get that answer sometimes. So because the limb may subsequently move towards frank ischemia and cause a problem. So contrast and enhanced imaging is going to be the way to go. I think you have to weigh the risk benefit in each patient, but I would suspect that the amount of contrast that you're going to give for just an isolated extremity angiogram is not going to be enough to throw them over into lifelong dialysis if they're on the cusp. I've never certainly seen that. I think most people would agree. It's certainly something we have to think about. The other option would be to get an MRA, but the best studies for MRA also involve contrast enhancement, just a different form. And they're often, you guys have tried to order an MRI in the middle of the night or a busy trauma. It takes a while. And the MRI, they always put way at the end of the medical center, and it takes transport and everything else to do, where your CT imaging capabilities are married essentially to your ER capabilities. So I would say that a CTA in less than 0.9 in the vast majority of patients is going to be your next answer.
Yeah, I couldn't agree more. I feel like that MRI machine is always far away, and the last thing you want to do is send an unstable patient there.
Yep.
All right, so shifting gears slightly, I want to talk about when central lines go wrong.
Oh, yeah.
We've all heard stories or been involved with cases where, despite our best efforts, these things happen and things go wrong. So if I have, say a hypotensive trauma patient, and we're trying to put in a femoral line, we're having difficulty with access, and we try to put in a triple lumen, and instead of going into the vein, it goes into the artery. What then? And is there a difference between, just a puncture of the artery versus a full dilation of the artery, and how we manage that?
Yeah, no, absolutely. Great question. So access can be very challenging in these really sick patients. We're doing something on kind of an emergent basis. Using ultrasound helps if you can do it. I think that's the standard of care. I wish I could teach more of my trauma surgeons to be as proficient as my ER colleagues at that. But it absolutely, the degree that you're into the procedure in terms of when the arterial puncture happened plays a role. If you've just stuck it with the needle and it's a compressible site, you can almost universally just hold pressure for some period of time. We stick very big sheaths in the femoral artery and just hold pressure for a period of time. General rule of thumb for that is, it's based on the diameter of what you had in the artery. But for a needle, hold pressure 10, 15 minutes. Make sure there's not an expanding hematoma. If you want to get an ultrasound later or some imaging later, you can move on and do that. If you have placed a vascular device and suddenly you put a cordis in, for example, and you open it up and blood starts shooting out of it with some aggressive, this is definitely arterial, or you get an arterial waveform with it. At that point, just leave the device in. We have some options from an endovascular perspective that we can do that don't necessarily convert that to a major open intervention. And leaving that in place allows us to kind of exercise some of those from either percutaneous closure devices or stent coverage. I think I sent you a graph, some pictures of a unfortunate dialysis catheter that went into down the innominate artery through a subclavian. And you can see there, I mean, it looks pretty impressive on the angiogram. And before that angiogram, they had obtained a CTA. But you can see what an exquisite, nice little fix that we can do for that to salvage that situation with just endovascular capabilities. And in this case, they actually left that device in. That angiogram with the contrast extraving everywhere is after we've gotten wire across it and we're ready to deploy the stent. You can see the stent is literally there ready to deploy. And then we got the angiogram to confirm the positioning. So we can fix that. We can be partners with you on that. And it's nothing to be embarrassed about or feel bad about. I have stuck things in the artery before in the context of crash situations. But if you do have the time to use ultrasound and take your time with it, do it. Yeah.
All right. You heard it. Joe even has done it.
I absolutely have. And I think most trauma surgeons have too at some point. I know they have. So it's just a matter of, we get put in bad situations sometimes with these patients that are coding. If you try to put in a central line with active CPR ongoing, you're hitting a moving target. It's crazy, right? So if you get the access, great. If you stick it in the wrong place, occasionally in that context, trying to do your best to save a patient, I think it's excusable. Just own it, move on to it. Don't be embarrassed by it, and bring on the next expert who can help you out.
I mean, and that's just such a great point too. I mean, sometimes in these hypotensive crashing patients, you aren't going to get that shooting arterial bleed that once you puncture the artery, it's like, oh, I'm in the artery. It isn't always obvious.
Absolutely.
So in terms of that, your biggest thing was holding pressure. So what if you put this line into a place like you were trying to get a subclavian access and you can't really hold pressure? What then?
Yeah, if it's just been the needle or just been the needle and the wire, you're probably at very low risk of having any major catastrophic things go wrong. Some additional imaging is probably prudent in the form of a contrast enhanced imaging, a CTA of that area, to make sure you don't have some kind of extravagant or expanding hematoma. If it's a contained pseudoaneurysm or something like that, again, we can bring our endovascular minimally invasive capabilities to bear and really salvage that nicely. And in many instances, even if it's an initial pseudoaneurysm, we may not need to do anything. So, but getting some additional contrast enhanced imaging if you're worried. I think a simple needle stick at compressible sites is not a big deal, hold pressure. If it's a subclavian in the context of a patient with a lot else going on and you can get the contrast and enhanced imaging to help yourself, then that's probably useful and prudent.
All right. So staying with central lines, we get the line in, but we forgot to take the wire out.
Yeah.
Then what?
Well, fortunately, this doesn't happen very often. And I honestly, when we started talking about this, I tried to find pictures of a central line wire that I couldn't find one. I know I've taken them out before, but it's been a while. I did send you some pictures, and I think we can bring them up, of actually a Reboa tip. One of my trauma partners got a little too aggressive, taking one out in the context, again, of a crashing and burning patient. And the tip tore off, which is not common. I've never seen it before. And this was truly man versus device. It wasn't a device failure so much as maybe a trauma surgeon's been in the gym too much. But that came off, and it's the same as a wire, right? What do we do with it now? It's a foreign body, a non-occlusive foreign body in the vasculature. And again, the answers that we can bring to bear in terms of minimally invasive capabilities, in terms of snaring those. And it's just like you put a little lasso in the artery under fluoroscopic guidance and you literally grab it. It's something that we do quite frequently in a variety of other contexts in vascular surgery, something we know how to do, nothing to be embarrassed about, and just get us involved early and we'll take care of that for you.
And all it takes is a lasso.
Well, sometimes it can be technically challenging. Sometimes they're tough games. It's a video game to some degree. People want to draw that correlation. Some video games are tougher than others. The big thing you want to be in terms of expediency, really these devices only get into trouble when they can cause thrombosis. Great, we can deal with that. When you have like a central line that you've put in and it gets in the heart and starts to irritate the heart, that gets a little more hairy. But the big thing is take time and try to avoid it at all costs if you can. It's very rare. We are all, just make sure with your trainees to emphasize that. I think we've all been instilled with that fear of losing the wire enough that we all are very cautious against it, and we keep our trainees that way. And fortunately, even at a busy place like shock trauma, I see it so vanishingly rare for that purpose. We just need to continue to train and think about it as we get to that step.
Okay, so don't lose the wire, but if we lose it, it can be fixed.
Yep, use your interventional radiologist or your vascular surgeons can help you with that.
Okay, perfect. So now let's talk about those arterial bleeds and bleeding control. Mm-hmm. Say I have an amputated arm that comes in, and we have these arterial squirting vessels. Is it appropriate for me to ligate some of these vessels? And if so, is there any technique that you think would be like kind of easy, preferred in the ER to quickly control these bleeds?
Yeah, bleeding from any site you got to control. So amputations are easy, and extremities are relatively easy in that you can typically place a tourniquet, right, to control those things. Some other locations, tourniquets may not work. If you get bleeding at any location and you can't control it with direct pressure, which is always your first choice, bump up to tourniquet. And then as a temporary fix, a nylon or a Prolene stitch, something that's visible that we can remove later while you're getting your vascular or trauma surgeon to bedside, is not a crazy answer. It's not a wrong answer. What I would do, even a hemostat stuck on the spot, if you can control it, works, right? You need to control the bleeding and move on to the next patient priority, because a lot of these patients are polytrauma. So there's several different stitch patterns you can do there. I think you've got some nice pictures of a U-stitch or a purse string stitch. Get good healthy tissue around the area of bleeding so that you get stuff to kind of cinch down on that side of bleeding. Leave the tail long so you can see it easy and we can deal with it easy. Another nice answer is what we call our figure of 8 stitch. Basically kind of crisscross directly over the site of the injury and then pull and bind the tissues up over that spot to get some pressure on it to stop it. I don't think stitching would be your first choice, but at the end of the day, you can't have continued bleeding because the trauma surgeon may be at bedside if it's one of those kind of responses, but your vascular surgeon is going to take a while to get there. And depending on the environment you're at, you may be a while before a surgeon gets there. So control the bleeding as best you can in that stepwise fashion, direct pressure, tourniquet for extremity stuff, and then stitching at other places to control the bleeding.
So in terms of tourniquet use, because this is so important, especially in our amputated patients or partial amputations, they frequently come in from the field with a tourniquet on. When I'm first assessing this, sometimes I've taken the tourniquet down and the bleeding's actually controlled and we don't need the tourniquet anymore. Or I start to unloosen it just a little bit and you have, a geyser going off. Yep. What's your approach to that tourniquet and initial assessment when the patient comes into the trauma bay?
Yeah, great point. So key things are, don't divert from your ATLS. Do your airway breathing and circulation control. If they've had a lot of bleeding at the site, on the scene of injury, or they come in with a lot of bleeding, or it's a spot that looks like, wow, that's got a high risk of being a major bleeder, get your resuscitation started first. Because one of the things when you take that tourniquet down is you're going to get also venous return. And that venous blood, if that tourniquet's been on for a bit of time, has had acid buildup, and you'll take somebody with a pH of 7.3 and send them to a pH of 7.1, right? Because they get that washout. So get your resuscitation going. And then after you've got your ABCs taken care of, take a look at the tourniquet. Start as part of your secondary survey and evaluate it. Many times, if you can put a finger under the tourniquet, and tourniquets do move. When we, in the military, we teach people every time you move somebody, retighten the tourniquet, because as they move them even from the stretcher or to put them in the ambulance bay or in the back of the ambulance, it's going to loosen up a bit. And so that tourniquet may not even be on, so that you can check that. And then once you've got everything else controlled, you've got your resuscitation going, letting that tourniquet down to see if there's actual bleeding at the site. You're absolutely right. The majority of probably the tourniquets I see that come in from the field, people put them on and they're not necessarily needed. I still would tell them to put them on because you'll save more lives by putting those on than an unnecessary tourniquet with short transport times. But it's time after we've done the ABCs to take a look and see if that tourniquet's actually needed. If you have any suspicion, put the tourniquet back up, call your vascular trauma surgeon and press on.
And I mean, I think that's such an important point. You know, these patients come in and it's so easy to be distracted by the big bleeding thing when really it's back to A, B's, and C's. And even the best care, it sounds like, for this bleeding thing is the initial resuscitation, controlling the airway, and getting, you know, blood products started and resuscitating this patient, and then looking at the big bleeding thing.
Absolutely. Absolutely.
Okay, so a lot of us work in rural centers that unfortunately don't have Joe, the vascular surgeon. So when you have a patient, then, you know, they have the tourniquet up, they've got a big bleed to, say, the leg. We need the tourniquet on. How long is too long for the tourniquet? Because if we have a long transfer time to get to higher level of care, do we just leave it on and control the pain? Can you take it down intermittently and release that pressure? Is there any benefit to that, or just leave it on and get to a vascular surgeon?
I think after your initial assessment that if the tourniquet is needed based upon you take it down and it's bleeding, the down and up thing is only just causing more bleeding. I don't think that's a sound rationale. If you, after taking the time of getting your ABCs and your resuscitation started, think that tourniquet's needed, leave it on. You're running against the clock. The classic teaching is that 6 hours of tourniquet time causes irreversible damage to the tissues. It's going to start with the nerves because it'll be the most susceptible and most needing that vascular supply. So you'll at least get irreversible nerve damage after 6 hours in terms of that limb function. So, and that's in research with non-hemorrhagic patients. In a patient who's had a bleed on top of that, it's probably shorter. At least some of our military data suggests you may shorten it to 4 hours. So if the tourniquet is needed and you don't have somebody sitting there and you need to transfer, it needs to be a pretty expedient transfer to get them over if you want to salvage that limb.
All right, so it sounds like leave it up if you have to and just try and get them to a vascular surgeon as quickly as possible.
Yes, ma'am.
All right, so we've talked about a lot of extremity bleeds and where we can hold pressure and put a tourniquet on. But what about those situations that get all of our adrenaline pumping, which is penetrating trauma to the neck? I can't put a tourniquet around that, Joe. I think I would cause some bigger problems.
Wouldn't work out very well for you.
Yeah. So any tips and tricks to kind of controlling bleeding in these delicate places where there's a lot of big vessels in the airway and a lot of things here that are, you know, can be very dangerous for our patient when they're injured? Any ways to control the bleeding there?
Yeah, direct pressure is going to be your biggest friend here. And to augment that, in many instances, you're going to need to get control of the airway first. So getting a definitive airway so that when you're pressing down, sometimes quite firmly on the neck on one side, that you're not occluding the airway or compromising the airway. Get that secure airway, make sure it's safe. Not everybody needs to be intubated, depending on the location, but use and hold pressure. There are, in some instances with stab wounds and gunshot wounds, there's neat little tricks. If you can because you can't sit there, you're not going to transport the patient with your hand on it, right? So you either got to come up with some kind of compressive dressing that's not circumferential, or people have used in specific and select injuries, a Foley balloon. If you can put a balloon in that tract and blow the balloon up to hold pressure internally next to that bleeding side of that vessel, and that works, use it.
All right, Joe, I actually just have a personal question for you that I would love the answer to.
Yeah.
Interventional radiology, vascular surgery. I feel like sometimes I get stuck in this trap of, I think it's IR, and IR tells me it's vascular surgery. And then I call the vascular surgeon and they say, no, that's managed by IR.
Yeah.
Is there a list that exists? Please tell me there is. That just says, this goes to IR, this goes to vascular surgery. I have a feeling you're going to tell me no, and I have a feeling you're going to tell me it depends on your institution. But is there just in general, this is IR and this is vascular?
Well, I think your intuitions are correct. It does matter some. I think if it's an external injury, a vascular trauma surgeon is going to help you, because coming at that through the wound is going to be something they're going to do. And an IR doc is not, they didn't get in to do that, right? IR docs didn't get into their business to get blood on their shoes. Trauma and vascular surgeons are kind of used to that. If it's a dissection or an injury that doesn't communicate actively bleeding into the outside world, then you have to, and there's endovascular options, you have to kind of consider what your local capabilities are. And other scenarios like that wire that gets away from you. A lot of places IR is more agreeable to doing that for you than the vascular surgeon. So you have to understand your institutional capabilities. You never go wrong by getting if it's traumatic bleeding, getting your trauma surgeon involved first, because they'll often understand those relationships and who's most likely to respond and what the local interaction is. And then if you have any doubt, you can always call the vascular surgeon and explain to them the scenario. And if they think it's something that could be done interventional, then they'll steer it out. I think if you call an interventional radiologist as your first call for something that's bleeding externally, you're going to be talking to the wrong person and just wasting time. Not that they can't help in some instances, but you got to figure out that lay of the land. And default's always going to be the trauma surgeon, probably vascular surgeon next, and then IR for those things that are not actively bleeding but might be amenable to endovascular adjuncts.
All right, so it sounds like this list that I want to exist doesn't exist.
Sorry.
Dang it. Know your institution. If you're in the trauma bay and your trauma surgeon's already there, good to just start that discussion with them. And then when in doubt, call the vascular surgeon and they can re-triage to IR if necessary.
Yep.
All right. Now, we don't like to call our consults at 2 o'clock in the morning, but as you alluded to earlier in this discussion, a lot of these injuries don't happen Monday through Friday, 9 to 5. And unfortunately, we do have to call you at 2 o'clock in the morning. My question is, what is the thing that you're like, yep, I'm out of bed and in the car driving to the ER? What gets you up and running to the ER at 2 a.m.? What can we wait a day? What can wait a week? And what's the true emergency that you need to come in for?
Yeah, it's all contextual, right, in the context of the specific patient. But I think if you have ischemic tissue because the blood vessels have been injured, that's kind of an emergency with a time clock on it, right? So that 5 hours, 6 hours, whatever you want to call it. And then uncontrolled bleeding is going to be your other primary. So those are the big things. Some of the injuries that you would think are the scariest, like the blunt thoracic aortic injuries, what we've learned is the majority of those patients don't die from those injuries. They die with those injuries, meaning it's typically a polytrauma type patient. And we can medically manage those patients and treat them in more of an urgent fashion, meaning first case the next day, and those kind of things. But any uncontrolled bleeding, even as either as a sequelae of direct delay of injury or the controlling of that bleeding, if you get ischemic distal tissue, that's an emergency and somebody needs to kind of be getting out of bed at various expediencies. You may be able to make a cup of coffee before you run out the door, but you're going to be moving in the direction to help the patient.
All right, so it sounds like cold stuff and active bleeding that we can't control. Yep. You're getting in your car and you're coming in.
Yep, absolutely. And you can frame all the vascular injuries you ever see in those two contexts, hemorrhagic or ischemic. And if you can frame that discussion and presentation to the vascular surgeon, they know exactly what context it's in.
Okay, Joe, this has been such a helpful conversation. I've learned a ton. I'm sure the rest of the people out there in the EMRAP universe have learned a ton. If there are just 3 takeaway points, 3 things that you want us as ER doctors to take away from this conversation about vascular trauma, what would they be?
Yeah, don't make vascular trauma more complicated than it needs to be. It's either immediate hemorrhagic and ischemic, which means it's a vascular emergency and needs to probably go to the operating room pretty quickly, or it's something that needs some additional workup. Utilize the basic tools of physical exam, the hard and soft signs, the ABIs, and you'll be as much of an expert as probably any of our trainees. And that we are, despite our reputation, vascular surgeons, most of us are pretty nice folks and are certainly willing to help you and appreciate everything that you do. So communication is key. Early communication is not offensive or a detriment on your part to have not gotten through all all of the elements of the physical exam and evaluation. So just communicate what you know, and let's work as partners to do what's best for these patients.
Awesome. So when in doubt, hold pressure and call Joe.
Yeah, well, I can't be everywhere, but yeah, I'm happy to call one of my partners for sure.
All right. Thank you so much, Joe, for taking your time to talk to us. And we'll hopefully see you later in the chat to answer all of the questions that we have during this live segment.
Sounds fantastic. It's been a pleasure. Thank you.
What an awesome discussion. Lots of really good comments in the chat. And there have been a bunch of questions. Some of them have really focused on ABIs, ankle brachial indexes. And so I thought we would just take a minute and try to address some of those. Joe did an awesome job of describing how we can use a lot of these techniques in the emergency department. But Britt has a case. Let's hear this case and then talk a little bit about how we might be able to use ABIs in the ED.
Yeah, and Whoa. Yeah, I do have a case. And I think a lot of the discussion was around, ABI, CTA. How do I know when I can just rely on the ABI or when I have to get the CTA to rule out a vascular injury? And I was thinking about this recently because I just had this, interview with Joe, and I had this trauma. He was a motorcyclist. He got thrown probably like 20, 40 feet on the freeway, and he clearly had knee trauma. He didn't want to really move it. He could range it, so I knew it wasn't dislocated, but I also knew that he was going to need to go to the CT scanner, and we wanted to rule out any serious injury. And at that point, in the trauma bay, resuscitating this guy, I didn't really have time to do an ABI. So at that point, I said, if we're already going to the scanner, let's just get the contrast and do CTA runoff of the leg. I think in that particular situation, I'm not just focusing on a single injury on the knee, but ruling out other serious injury, that it's probably okay to bypass the ABI and go straight to the CTA. What do you think, Chris?
So I absolutely agree. And I think the use of the ABIs in the emergency department, and I do use those, and I believe they are very valuable, but it's not in that patient. It's not in the one that is critically injured and is already going to the CT scanner. And right, you may not even want to take the time to do that. For me, the real use for ABIs is that patient that has the isolated knee injury. They are feeling fine. Maybe they even want to go, and you're trying to decide, can I discharge this patient without doing an angiogram? And to me, that's really where the role of the ABIs is. If you do the ABIs and you do them well, and they're over 0.9, you can absolutely use that as a reason to send that patient out, assuming it's otherwise normal exam, without doing an angiogram. And I think there's some really good data that suggests that is a very reasonable practice. And so that's where we use the ABIs in the emergency department at San Francisco General, and I think in many other places as well, for that isolated knee injury where you're kind of on the fence. Do I need to do an angiogram or not? ABIs are really valuable in those settings and can be used. A couple of the questions are, can I even use them? And my answer to that would be absolutely. If you have normal ABIs over 0.9, that you can use that as a reason to, with a normal exam, not go on to angiogram. So more stuff to come on that, and some great chat going on while these lectures are going on, while those discussions are. Thanks, Britt, Joe, for an awesome discussion there. Ryan, take us to the next segment.
Thanks, Chris. Great chat there. So most people suck at being patient, and you can't really blame them. They have suffered some horrible insult. It is their worst day, and they may not handle that with great composure, let's say. Now, we're trained to deal with adversity. They necessarily aren't. And so this may range from some mild anxiety all the way up to just absolutely wilding in the department, agitated delirium. And so when you have these patients, you need to deal with them efficiently and safely. Chris is going to tell us about this. Take it away, Chris.
All right, so we're going to talk about managing the agitated trauma patient. And my name is Chris Caldwell. I work at San Francisco General Hospital. This is where I work. This is the new San Francisco General as of 2016. And we are certainly a level 1 trauma center, cardiac center, stroke center. But I actually will say and make the case for that we are a level 1 agitation center. We see a lot of agitation, and many of them are coming in as trauma patients. And so we're going to talk today about how we manage the agitated trauma patient. And from my standpoint, it comes down to this. So I know what to do with this. I feel like I've got my next steps pretty much already set for what to do with this. I think we are pretty comfortable with what to do with things like this, but I don't always know, even though I've been doing this for many, many years now and always in busy trauma centers, I'm not always sure what to do with this. So we're going to really focus on that management today. And from my standpoint, it really comes down to a couple of key decisions. And here is our decision tree. So first and foremost, does the patient have capacity? Now, there's obviously going to be times when they clearly don't, and you don't have to really spend a lot of time worrying about that particular decision. But I find that some of the most difficult situations I face on any given shift are when it's not clear whether or not that patient has capacity. And that's actually the first part of this decision, because that will certainly inform many of those next decisions. And a patient with capacity is going to have the ability certainly to direct their care. And one that does not have capacity is now, it's really my responsibility to ensure that that patient is safe and well cared for. And so that first question of capacity sometimes can be a very difficult one. And then if they don't have capacity, do we need to sedate them? And if the decision is to sedate them, we do need to sedate them. How are we going to do that? What are we going to use? So those are really the key decisions that we're going to focus on today. So let's start with the first case. This is a 32-year-old that was assaulted by 3 dudes at a bar. We're a little tougher in San Francisco. It takes 3 dudes to beat us up rather than the normal 2 dudes. However, this patient clearly has ETOH on board. You walk into the room and there's no question really that there's been ETOH involved. There's no slurred speech. You do get some nystagmus on your exam. I'm not exactly sure what to do with this, but he's refusing all care. He's already on the phone, his cell phone, with his lawyer. You do get a set of vital signs. It's 155/88. Pulse is 128. Not really happy with that, certainly. But he'll give you a very cursory exam, but he's not giving you much else. And then to make this tougher, wife is there demanding a transfer to a real trauma center. You've got 2 adult children who are calling on the phone, demanding that you just let him go, as he is saying. So who decides this? Who makes this decision? Does the patient? Does, in this case, his wife? Do the kids do it? Is there an insurance voice in this? Is this a legal decision? Or do you make this decision? And to add to that, the police are already asking questions. Hey, should I get a tox screen? Should I get a blood draw? And so obviously we are medical providers, and our first concern, our first approach is going to be, what are the medical issues involved here? And we need to think about, anytime you are dealing with an agitated patient, certainly are they agitated because of a head injury, hypotension from hypovolemic shock? Are they hypoglycemic? Are they hypoxic? And in fact, you will run into situations where the combative patient, the agitated patient, may be head injured, they may be intoxicated, they may be just have a bad disposition. And in fact, in San Francisco, we run into a fair number of situations where we're dealing with all 3. And then it's always important to remember that when the patient is annoying you, getting your attention for the wrong reasons, it's a great time to stop and say, okay, what am I missing here? Am I missing early signs of shock? Am I missing something that the patient is becoming progressively hypoxic or hypoglycemic? Other things, medical causes for this. Let's say, just for the sake of argument, in this case, you are confident that is not the case. His glucose is normal, his pulse oximetry is fine, and you're convinced that this is not a medical issue in terms of causing his agitation. So now, who decides? And the answer that is very clearly, in real time, it is you. And the standard that we have to use for this is the reasonable person standard. When you look at the courts, sometimes they still have the wording reasonable man standard, but what is important to know is that when you approach this, and if basically reasonable person is what would a reasonable person do under the same or similar circumstances, and it's really important for us to know that case law, when you look at the legal situations here, the courts have predominantly supported us when we have made these decisions in real time, as long as we've been clear that we're trying to make the best decision we can under those circumstances for our patients, both respecting their medical care and their safety, as well as their autonomy. And when we have done that, and we have expressed why we are making that decision, the courts have really bent over backwards. As part to get ready to this talk, I talked to a number of lawyers, both defense and plaintiffs' attorneys, and although it was very hard to get them to agree on anything, one thing they did agree on is that the courts really have been supportive of us when we have made these real-time decisions and documented why we made those. So how do we make that decision? How do we determine medical decision capacity? What's the impact of intoxication? In this particular patient, we know that there is alcohol on board, but does that mean that he's incapacitated? At what level is he incapacitated? Do we want alcohol levels? Do we want toxicology screens? How are we going to make this decision? So when you look at the legal definition of capacity and competency, we distinguish. Competency really is a legal determination, but capacity in real time is what we have to determine. And so is the patient able to understand the options presented and their associated risks? Are they able to make a choice using consistent set of values and goals? Importantly, not necessarily our set of values and goals, but a consistent set of values and goals. Are they able to communicate his or her choice? And then we have to make the determination sometimes, are they choosing not to, but at least we believe they could or can, or are they not able to do that? And then are they able to make a decision specific to that particular problem and that particular treatment? And so from a medical standpoint, to me, it comes down to, does the patient understand the problem at hand, what we're proposing as treatments, what alternatives to those treatment might be, consequences for the decisions they're making, and their influences on their decision, potentially family members or other issues. Are they able to determine that? And the key point here is that this is a clinical determination. This is not based on an alcohol level or a toxicology screen. We don't have a number above which a patient does not have capacity and below which they do. Lots of examples. I have a patient the other day that was able to truly come up with original and creative ways of insulting me, and their alcohol level was in the 300s. Now, I've been doing this a long time, and it's hard to get my attention by insulting me anymore, and yet this patient was able to do it with huge alcohol levels that would render many of us unable to breathe, and in many cases on a ventilator, and yet he was coming up with creative ways of insulting me. And point to take away from this is alcohol levels affect people differently. We do not have same with drugs and when we took it or other intoxicants. We can't define an intoxicant and a level there above which they don't have capacity, below which they do. And even though we can do that for when you can legally drive, we have to make that assessment. And regardless of what that alcohol level is, regardless of what's going to be on that toxicology screen, we have to make the assessment of capacity and determine, does that patient have capacity or not? And to me, that's actually, that's a very empowering position to be in. I don't have to rely on a number. There isn't objective criteria. I know for some that's a very uncomfortable feeling, but it is one that we need to be comfortable with when we're managing agitated trauma patients, agitated patients in general, is how are we going to assess capacity? And we need to be ready to do that on a clinical basis. Remember that the mere presence of mental illness, just like the mere presence of alcohol, doesn't preclude a patient from having the right to participate in their care. And our ultimate responsibility is to protect the patient and the public from harm and to respect that patient's autonomy. And it's going to come down, in this case, to capacity. So nice book here on informed consent, lots written about consent and refusal of care. I'm going to summarize that very quickly. When you address the issues of when can we allow a patient to refuse care and leave AMA, it is going to come down to your determination of that capacity. Are we free to make bad decisions? And the answer to that is yes, as long as we have capacity to do that. I would argue that my emergency department is often full of bad decisions, and my job security is in many times based on bad decisions, and we are free to do that as long as we have capacity. And then the final part of this would be that when you're in doubt, if you've assessed that patient and you've tried to bring every piece of information that you can into this decision, and you're still in doubt, you're still kind of on that fence, then err on the side of keeping the patient. And once again, know that when you do that, and when we, in these cases, we always hear that we have to document better. In this case, we do need to document carefully why we made this decision. And courts have bent over backwards to support us when you look at case law. And in fact, the plaintiff lawyers that I talked to were quite frustrated by that, but acknowledge that, again, they are very supportive when we have faced that decision in real time. So take home the points is ultimately you need to do what you would most like to defend. When in doubt, rules is basically when you're going to do what you believe is in the patient's best interest, and know that when in doubt, you're going to err on the side of keeping them, of protecting them, and know that case law would suggest that the courts will support us in this. Keep intoxicated patients until you believe it is safe for them to leave. There are ways we can do that without necessarily going into the sedation era. We can, or area. We can place IVs. We can remove their clothes. It's harder to walk out of a hospital in a hospital gown or naked. It's not impossible. We've seen this happen, certainly at our facility, but it's a little harder to do that, and it's easier sometimes to find them when they have left. Sometimes we're going to need to restrain them, and we'll talk about that in just a second. But there are ways we can interact to make it more difficult for a patient to leave once we've decided that we want to keep them here. So when we decide to do physical restraints, remember that we do medical versus behavioral. And the reason that I say that is because behavioral is really guided by the Code of Federal Regulations, and it's very restrictive. So we do medical restraints for medical reasons in the emergency department. How are we going to restrain a patient if we choose to do that? We're going to do that certainly supine, not prone, wherever possible. We're going to do 4 or 5 point, not 2. This is not, there's really, I don't think we should consider the term partial restraint. I know sometimes as we're getting restraints off, we will do that, but it really is it's like a decision to sedate a patient or paralyze a patient. Once we've made the decision, do it, and we will restrain the patient with 4 or 5 points and to the bed frame, not the railing. And in many cases, from the emergency department perspective, we are going to rapidly add chemical restraint to physical restraint. It really is unusual for me in our emergency department to just simply physically restrain, particularly trauma patients. Very quick word on documentation. Again, this is where the lawyers were very clear on this. When you're dealing with consent, refusal of care, and particularly capacity, and when you are dealing with restraint, you need to tell a story with that documentation. If the patient is abusive or uncooperative, you can absolutely document that, but most importantly, control yourself. Don't be reactive. Don't be documenting when you're angry, and don't speculate. The one thing that all of the lawyers said, and particularly the plaintiff's lawyers, is if I can read a chart and I can tell that the doctor was angry when they wrote it, that is a sign for me that I can take a case further. And I can sometimes convince the courts to second guess or to go against that physician's decision if they come across as angry on that documentation. So do take a moment to be sure in this case that the documentation is calm, thoughtful, and is describing what that situation is. Make sure it's accurate. Macros are wonderful in some cases, but be careful about a macro that has pupils are equally round and reactive to light. If you happen to have a patient with a glass eye, that cannot reflect very well. And then really, Bob Bitterman, an emergency physician and lawyer, came up with this statement that I absolutely agree with. The chart really should tell a story that can only have one ending, and that's the ending that you chose, and that's the reason that you chose it. So let's go into now we're in that next stage of we've decided that the patient does not have capacity and we do need to sedate them. How are we going to do this? So this is our second case, 38-year-old male, unrestrained driver of car versus tree, uncooperative at the scene, needed multiple EMS and law enforcement to restrain him. He's screaming and trying to turn over the gurney there in your trauma bay and thrashing about. You do get a set of vital signs. You're not sure how good they are, but this is what you have. A 150 over 100 with a pulse of 118. He's breathing at 24 to 26 times a minute and screaming and yelling and thrashing about. And now we need to intervene. So ACEP wrote a white paper. This was way back in September of 2009. I'm very happy to say that the new version is almost ready to go. I'm hopeful to be seeing that in the next month or two here, the updated version of this white paper. But they did describe a couple of important things here, and that is excited delirium. Some people like to call it severe agitation. Whatever you like to call it, it's a very real entity. We see it in the emergency department. You see it. You know it when you see it, and it is a real issue. And there is that entity that may be amenable to early therapeutic intervention, and in some cases in the premortem state, obviously where we want to be. And physical restraints should be rapidly supplemented with chemical restraints, which I find is absolutely the case, certainly in our emergency department. And this excited delirium or severe agitation, the pathophysiology is that profound metabolic acidosis. Maybe it's methamphetamine or cocaine or other intoxicant induced. Maybe it's a seizure. Maybe it's the trauma itself, something that has caused this process to start. But now we have the profound metabolic acidosis that the extreme agitation is just making worse. And we have this unchecked catecholamine surge that's in a cycle that that is only going to have one ending if we do not intervene. And our job now, once we've defined that severe agitation and or the patient doesn't have capacity and we need to keep them, our job is going to be to interrupt that downward spiral, particularly in the case of extreme agitation. And so how are we going to do that? There are a number of options. Really, when we're talking about sedating the trauma patient, it's going to be focused on benzodiazepines, the antipsychotics, and in our cases, it's mostly the typical antipsychotics. There are a few patients that will take oral meds, and we can start talking about some of perhaps the atypicals. I tend to lean more towards the typicals when we're dealing with these situations, and then dissociatives, in particular, ketamine. So from a chemical restraint standpoint, benzodiazepines absolutely work. They're tried and true. They have been used for many, many years, and in many cases can be used quite safely. There's midazolam or Versed, there's diazepam or Valium, lorazepam or Ativan, and they've all been used very effectively. I personally lean towards midazolam. I like the amnestic factor of midazolam a little bit, but in particularly if you're dealing with somebody that you suspect has ingested cocaine or methamphetamines, what we deal with a lot in San Francisco now, benzodiazepines can be very effective and very certainly safe in terms of managing these patients and sedating them. You do have to be careful with when you're combined with alcohol, and I would argue you have to be particularly careful in potentially head-injured patients, which many of these patients are, and I'll tell you why that is in just a minute. So here we're going to talk about my favorite drug, and particularly if we're talking about situations that maybe aren't reaching extreme or excited delirium, droperidol is truly my favorite drug. And I know it was gone for a long time. Many of you probably have trained and practiced in an era where you didn't have it available. It is back. We're using it again at San Francisco General, but I used it for many years, both as a resident and early on as attending. It's a great drug, and it works very effectively sedate all but the most extreme. It's not my first go-to when I'm dealing with something that I really worry is extreme agitation or excited delirium, but for almost every other situation, it is. Dose is typically 2.5 to 10. I will start with 5. It can be given IM and IV, and the more severe the agitation, the more really we're talking IM, right? Because these IVs, even if we were able to get them, are often coming out. So I will start with 5 IM and I'll go up fairly quickly from there. Again, very safe and effective. It is also a very effective antiemetic. It's great with patients that are coming in with headaches and a little bit of nausea as well. Not a trauma situation, but it is very effective for emesis as well. And just make a point, because many people have been worried about its safety, and that black box warning certainly didn't do it any favors. But lots of literature in the emergency medicine literature, the psychiatric literature, anesthesia, GI, OBGYN, all showing that this is a safe and effective medication. And if you want something a little more recent, here's an AAEM physician paper from 2015 and another paper in Annals that said it's safe and effective for the treatment of agitation. This is a talk in and of itself, but lots of good challenges to that FDA black box warning, and in particular why it was initiated, that no clinical trial or systematic review has reported an adverse cardiac events despite the concern for prolonged QT intervals, which of course is the case for so many medications that we use. But the idea and my perspective on, certainly in reading through all of this data, is that it does not impact the QT interval to a clinically significant effect in the huge majority of our patients. If you take a bradycardic patient with an underlying prolonged QT interval, granted, I'm probably not using it for that, but for our agitated trauma patients, it is a wonderful drug. Now, if you don't have droperidol, Haldol is certainly effective as well. It has an FDA warning as well. It's not a black box warning, but an FDA warning for prolonged QT intervals. But it is effective. And again, 5 milligrams, either IV or IM, not FDA approved for IV, but certainly is used often for that, and IM, which is what we're often talking about as well. Now, let's talk about what about those extreme cases where my go-to is often, I'll certainly use benzodiazepines if I think it's cocaine or methamphetamine, If not, if I think it's alcohol, psychiatric, or even potentially other things going on, but it hasn't reached a severe case, then droperidol is my go-to. But if it's severe agitation, if I'm worried about excited delirium, then we're reaching for ketamine really as a first-line drug. And a couple of good articles here that talk about it as a first-line drug medication for severely agitated patients. It's safe and effective in the field and certainly in the emergency department. When I trained, and for many years we heard, well, you can't use ketamine, and we took a long time to use it in the United States because we were worried about increased intracranial pressure. Here was a really good article that really put, I think, that myth to rest. It was published in Annals back in 2014. It evaluated the available evidence of the effects of ketamine on intracranial and cerebral perfusion pressure, and really found that there was no adverse effect on intracranial pressure, cerebral perfusion pressure, neurologic outcome, ICU stay, or mortality. Here's a couple of other articles that found not only no increased intracranial pressure, but in fact, in this case, improved cerebral perfusion pressure. And they even suggested it might be neuroprotective. There was another article that found it very safe in head injury here in 2020. So I think we've really put that myth to rest. And when you think about head injury, what are the very basic, what are the greatest predictors of bad outcome? It's hypotension and hypoxia, and ketamine actually is helpful for both. In the intoxicated, combative, uncooperative, non-compliant with their spinal motion restriction patient, what's the end result of that? It's going to be increased intracranial pressure, increased risk of spinal injury, and increased risk to providers as well. And this is really, again, a time that we need to intervene, and we need to intervene definitively for the safety of our patients. Benzodiazepines, the concern here, particularly with head injury, is that they can reduce the mean arterial pressure. They can decrease the respiratory drive, particularly when combined with alcohol. And ketamine has the effect of increasing the mean arterial pressure. It is a weak sympathomimetic. So the concern that, well, in a lot of these patients, they're already very hypertensive and tachycardic. Are we going to make them worse? And if you read through this literature and have any experience with ketamine as well, you'll see it is a weak sympathomimetic. So it's not going to have a clinically significant effect on those patients that are hypertensive and tachycardic, but it will be something that you can be very confident that it's not going to cause worsening hypotension. It obviously can't prevent hypotension in a hemorrhagic shock patient, but it will not be the cause of your hypotension. And it doesn't, particularly in the doses that we are using, decrease your respiratory drive. So it's not to say, again, that there aren't traumatic injuries that might do those things, but the ketamine won't be the one to do it. This is really a good paper that came out in 2020 in pre-hospital emergency care. It's a joint position statement that if you want any real references to help defend your use of ketamine in trauma patients, this is where you would go. This is a joint position statement from the American College of Emergency Physicians, ACEP, the American College of Surgeons Committee on Trauma, the National Association of EMS Physicians, National Association of EMS Officers, State Officers, the National Association of EMTs, all with this consensus statement. It was endorsed by the East, West, Western Trauma Association, so many of the different other societies. And it basically says ketamine is safe and effective. It has multiple indications, including analgesia, procedural sedation, as an induction agent for intubation, and certainly for the acute severe agitation and excited delirium. It's safe and effective in traumatic brain injury with eye injuries, and really put to rest those myths that had been circulating previously. Here are some of the doses. We'll use it for pain control, certainly for procedural sedation, and as an induction agent when we're concerned about a patient who may certainly not tolerate the induction very well and could potentially crump on us. This is our go-to medication for this. And for acute agitation, we will, again, once you've made that decision to sedate a patient, sedate them. 3 to 5 milligrams intramuscularly per kilogram is our starting dose for this. Oftentimes it is IM because IVs aren't going to be practical in these patients, but that really is, again, a safe and effective dose to sedate these patients who are at very real risk. So in summary for this topic, your first decision point is capacity. Sometimes that's going to be a very clear decision. If in doubt, keep them, and know that the courts have supported us and case law has supported us when we have basically explained why we have made the decisions that we made. And as long as those decisions are patient focused, they have supported us. Does the patient, when they don't have capacity, do they need to be sedated? If they do, restrain thoughtfully, sedate when necessary. Once you've made the decision to sedate them. And ketamine is safe and effective in our trauma patients. Anytime I talk about this topic, it brings up lots of thoughts. I welcome those. Please don't hesitate to reach out. This is my email, and I would love to hear your thoughts, frustrations, suggestions, or any other comments on this. And once again, thanks for spending some time really focusing on what is a truly important part of our trauma management.
Thanks, Chris. That was fantastic. It turns out that the only contraindication to ketamine is a ketamine overdose. Over here is a fake Corpendium textbook. We were talking about how do you do a continuously updated textbook. Chris has to come over to your house every weekend and redo the trauma section. It's fake. Next up is Approach to Penetrating Traumas by Jessie Werner. Jessie is a fellow at UCSF Fresno and an EMRAP faculty person, and now she's doing much more stuff on EMRAP, particularly the author interviews for said not fake online textbook. So when it comes to approach to penetrating trauma, it's just airway, breathing, circulation, right? Not. Go.
I'm Jessie Werner, and today we're going to talk about penetrating trauma to the chest, abdomen, and pelvis. We've got 30 minutes to cover this entire topic. All right, so there's actually no way that we can get through all of this in 30 minutes. It's just impossible. So what we're going to do today is basically give you a nice broad overview for approaching penetrating trauma. The rest of this conference has lots of nitty-gritty details about handling specific entities. So let me just cover a few important facts about penetrating trauma. Here's our overview. We're going to start with the general approach to the trauma patient. The next thing we're going to talk about is things you always wanted to know about penetrating trauma, but were afraid to ask. And then we're going to cover a few interesting facts. And these are things that came up while I was researching these topics, or things that came up while I was learning about trauma during residency or medical school and just didn't really know the answers to. And I think that you might find them interesting, such as, why do we still do DPLs in some places? And are gunshot wounds actually sterile? So stick with me and we're going to find out the answers to these questions. When you approach the airway, you should already be thinking about B and C and D. Because if you intubate someone who has a cardiac tamponade or a tension pneumothorax, you could cause cardiopulmonary arrest. You could really kill the patient. So you need to consider that before you intubate anyone. The other classic teaching is if someone has a GCS of 8, you should intubate. Not the case, especially in trauma, because patients may come in with a depressed GCS and then recover as time goes on. Also, some of these patients are intoxicated and their GCS might be a little bit low because they're under the influence. So GCS of 8, especially in trauma, does not necessarily mean you need to take that airway. Sometimes those patients need a little bit of time. Again, when it comes to penetrating trauma, you should have a very high suspicion for a pneumothorax, cardiac tamponade, hemothorax, and in a busy trauma bay, it's very hard to hear. It's very hard to appreciate breath sounds. You might hear nothing. You might think that you hear breath sounds, but you're actually hearing upper airway sounds, or you're hearing airway sounds transmitted from the uninjured side. So if you have a high suspicion for injury, if there's trauma to the chest, you should pretty much assume that it's penetrating the pleural space. Don't wait for imaging. Place a tube. Needle decompression is something that we're going to talk about throughout this entire conference. Basically, we're going to say, forget about it. So much evidence shows that the needle does not actually reach the pleural space, especially if you're doing it as taught in the midclavicular anterior line. A lot of times those needles do not reach the pleural space. So just don't needle decompress. Go for a finger thoracostomy. It's quick. You're going to need to place a chest tube anyway, and it's always going to be effective. All right, so we're moving through ABC just to give us a little outline to move through. So again, when you're on airway, you should already be thinking about B. When the patient rolls into the trauma bay, you should be thinking, what other injuries am I missing? Do I have the blood ready? Is there a tension pneumo? Is there a cardiac tamponade? And that should all happen even before you think about A. Now for C, a little bit of circulation facts. I just want to talk to you quickly about some basics. We're going to cover massive transfusion protocol later in the EMRAP trauma conference. I just want to quickly mention that you need to treat shock aggressively when it comes to penetrating trauma. And that doesn't mean that we're shooting for systolic blood pressures of 120. We're not aiming for normal blood pressure. We're aiming for permissive hypotension because studies have shown that there's increased mortality if you're aiming for a normal blood pressure. So your goal should be about a systolic of 90, and it's fine to use normal saline. Yes, plasmolite and lactated ringers are ideal because they're physiologically more similar to our fluids, but in someone who's bleeding out, giving them a liter of normal saline right before you start blood is not going to hurt them. That being said, it should just be 1 liter of crystalloid before you move to blood. Also, let's talk a little bit about TXA. The CRASH 2 study showed that TXA for patients in hemorrhagic shock is useful if they present within 3 hours. Now, contrary to that, you do not want to give TXA if the patient presents after the 3-hour mark because there has been shown to be increased risk of fatal hemorrhage. Now, I don't know what penetrating trauma is coming in 3 hours later. Doesn't sound so great, but if they do, don't give them TXA. To quickly touch on disability, again, we kind of said GCS less than 8, you can be a little bit flexible. You don't necessarily need to take that airway. You should be calculating the GCS and monitoring for improvement because, again, a lot of these trauma patients over time are going to improve their GCS without us doing anything. You're going to check pupils, you're going to look for brainstem reflexes, and especially this is really more for blunt trauma and less for penetrating trauma. But if someone has signs of elevated intracranial pressure, you'll move towards giving them 3% hypertonic saline. And if they're not hypotensive, bolus mannitol. What about exposure? This is particularly important in penetrating trauma because remember, bullet wounds, missile wounds, they can go anywhere. They ricochet off adjacent structures, and even though it looks like it's in the chest, it could very well end up in the abdomen. Also, on a bloody trauma patient, wounds can hide. So you need to look everywhere. You need to fully expose that patient. And you need to look at the back. You need to look at the axilla. You need to look at the groin. These things can hide. Also remember that the physical exam in trauma patients is notoriously unreliable. So even though you should evaluate for peritonitis because that is an indication to go to the OR, you cannot fully rely on your physical exam. The other thing about exposure is that when you see a wound, you want to use a radio-opaque marker or a paper clip to mark that wound site so that you can look for things on imaging that might be adjacent to those structures. What about adjuncts? We always call our adjuncts the ultrasound exam, the chest x-ray, and the pelvic x-ray. But I would like to argue that the ultrasound should not be an adjunct. It should 100% be part of your primary survey. The FAST exam should be performed on every trauma patient. Classically, it was reserved for blunt trauma, but it's useful in all forms of trauma, especially penetrating. And you should pull that ultrasound machine up there and use it right away as soon as the patient rolls in, because the pericardial view can show you if that patient has tamponade or fluid around the heart. And the extended ultrasound, the extended FAST, the EFAST, which stands for Extended Focused Assessment with Sonography in Trauma, is useful because you can look for pneumothoraces and look for lung sliding. Remember, watch out for that barcode sign, which will show you that the patient has a pneumothorax. So as soon as your patient comes in, grab the ultrasound, look for pneumothorax, look for tamponade before you take the airway. Because if you identify those, you could presumably save this patient's life as opposed to intubating them and causing cardiopulmonary arrest. Remember, when you're doing your ultrasound, the pericardial view should be first in trauma. Just to quickly mention the secondary survey, just be thorough. You've got to go head to toe. And don't forget to look in the nose, look in the teeth, look at the ears, the axilla, the groin. What about rectal? Well, we have a whole section on that during our trauma conference, but what I'd like to say is that it's pretty useless. Sure, if you look in the rectum and there's gross blood, you have a high suspicion that there's an intra-abdominal injury and that patient might need to go straight to the OR, but generally, the rectal exam in your trauma patients is not useful. All right, so let's get into the fun stuff. Let's talk about a few things that you always wanted to know about trauma. Terminology. Okay, so we should not be calling penetrating trauma wounds entrance and exit wounds. These are forensic terms and they could have legal implications. So you should call them penetrating wounds. When a patient comes into the trauma bay, it is tempting to say, ooh, there's an entrance wound on the left flank and there's an exit wound at the left axilla. The problem with that is it assumes one injury, an entry and an exit. Maybe those are actually two penetrating wounds and the bullet is actually still in the patient. So this can lead us to miss injuries. And again, you should count the number of wounds that you see, report them as penetrating wounds, but don't assume that they're entry or exits. We're also going to talk about whether gunshot wounds are sterile, and we're going to talk about probing the wound. Okay, terminology continued quickly. Ballistic physics. We got to talk about ballistic physics because it is so cool. So this is an area of science that studies projectiles, their velocity, their path, the type of firearm that may have been used. And what we're specifically interested in is terminal ballistics or wound ballistics. And this is an area that addresses the interaction between projectiles and living tissue. So you can see why this is important to us when we're talking about penetrating trauma. Technically, the term ballistic missile or missile is a general term that is used to describe an object that is propelled at a target, usually out of a hand or out of a weapon. So we can think about these injuries in two ways. As the missile or the bullet comes out of the gun, it creates a permanent cavity, represented here by the gray. The permanent cavity or the primary wound tract is caused by the missile moving through tissue, crushing and killing the tissue in its path. And there's a shock wave that radiates outward from that bullet, and that is caused by inflamed tissue. That causes inflamed tissue. Now, surrounding the permanent cavity is a temporary cavity. This is the concussion zone, and it is temporary. This is damage that's caused by stretching, shearing, and the compression size is caused by the missile's velocity. So the higher the velocity, the bigger the cavity. The important thing to remember about these missiles, and remember, it's not gunshot wounds. Technically, we should be calling them missiles. They can go in any direction. When there is a missile coming into your body, it can ricochet off of any sort of adjacent structure, particularly bones, and they can go in any direction. So you should not assume a straight line. Single wounds can traverse multiple paths. And if you have an injury in the chest, chances are it can end up in the abdomen and vice versa. What about whether or not gunshot wounds or missiles are sterile? They are not sterile. And this is a common misconception. We used to think that because gunshot wounds were so hot, because the bullet itself was so hot, that they must be sterile. But actually, as the bullet moves through tissue, it kind of creates a vacuum. And as it moves through, it's pulling in all kinds of things with it: clothing and dirt, flora, pieces of the cartridge, shell, and bone fragments. They all get into the wound and are potential infective sources. So they are not sterile. What about local wound exploration, probing the wound? The first thing I want to point out is that this is another terminology problem. So probing, wound probing, is completely different from local wound exploration. When you probe a wound, it basically implies that you're using your finger or a Q-tip to sort of check the track of the wound. And this is notoriously unreliable and it is not recommended. Local wound exploration, on the other hand, is a totally sterile procedure using sterile instruments. And what you do in a very sterile setting, essentially surgical, but can be done in the emergency room, is you're opening the extent of the wound, opening up the tract of the wound, and trying to define either the base of the wound or the most superficial fascial level, whichever's encountered first. And you should not use any sort of cotton-tipped applicator. These are sterile instruments. It's mostly used for stab wounds because, again, stab wounds sort of have a natural end to them. They're not usually propelling all over the body the way ballistic injuries can. And if the wound is beyond the fascia, then that is a positive local wound exploration. And that patient either needs to go to the operating room or they need to be admitted for serial exams. The important thing about local wound exploration, like why do we do it, is because it can change the disposition of the patient. Again, if it's positive, then that patient needs to go to the operating room or they need to be admitted for abdominal exams because something has potentially violated the peritoneum. Now, if it's negative, that person can have their wound sewed up and go home. So it's actually a big difference for the patient. Another important thing to keep in mind, you should not do this in penetrating chest trauma because if you are doing local wound exploration or probing in that area, you could cause a pneumothorax and poke through into the pleural space. It's really reserved for penetrating abdominal trauma, and even then, it's not super common. So let's talk briefly about ballistic injuries versus stab injuries. The big things I want you to remember: ballistics can ricochet and go anywhere, whereas stab injuries are generally one path. And for stabs, it is important to ask what kind of weapon was used and how long was that weapon. Remember, ballistic injuries, people always think they heard 2 shots, maybe they heard 3 shots, and studies have shown that they're usually wrong. So asking how many shots were heard is not helpful when it comes to ballistic injuries. The other thing about ballistics is they have an increased mortality versus stab injuries. Okay, penetrating trauma of the chest, abdomen, and pelvis. This slide is way too busy, and it's just to show you all the different structures that can be injured when we talk about penetrating trauma in this area. There is no way that we can cover all of this, and that's the point of this slide. We're not going to go through all that. Let's just touch upon a few interesting topics when it comes to chest trauma, abdomen trauma, and penetrating pelvic trauma. Why do we care about penetrating chest trauma? Well, about 20 to 25% of trauma deaths are from thoracic trauma. And approximately 40% of penetrating trauma victims suffer thoracic trauma, but most of those can be managed non-operatively, which is so nice. Remember, in the past, a lot of penetrating trauma went straight to the OR. These days, we can do a lot non-operatively. And up to 20% of patients with penetrating thoracic injuries will have concomitant abdominal injuries. If you remember nothing else, that is the thing I want you to keep in mind. It's probably the most important point. Do not assume that the trauma is just limited to the chest. So when we're thinking about penetrating chest trauma, the big ones I want you to remember, again, a lot of these will be covered later in our trauma lectures, but I want you to remember pneumothorax, which can be associated as tension pneumothorax, open pneumothorax, or hemothorax, and cardiac tamponade, because these are the really big killers that you need to identify even before you take the airway. The quick points about a pneumothorax are that you want to place a chest tube. Do not wait for imaging. If you have a high suspicion, go ahead, do a finger thoracostomy, place that chest tube. And we have a whole discussion in our lectures coming up about chest tubes and chest tube size and pigtails, but generally you're going to use a 28 to 32 French. Please spare your patient. Do not use a 36 French. There is not good evidence to use a 36 French chest tube for anyone, including hemothoraces. The other important thing I want you to remember is that tension pneumothorax is a clinical diagnosis, okay? You're not waiting for imaging. If you suspect tension, if you clinically see tension, you need to go ahead and place a tube or do a finger thoracostomy. When it comes to an open pneumothorax, remember, 3-sided dressing is the way to go. And for a hemopneumothorax, the big thing to remember is indications to go to the operating room. So for a hemopneumothorax, when you place the tube, if you get an immediate return of 1,500 cc's of blood, OR. The other indication would be if the person is putting out more than 200 cc's per hour for 2 to 4 hours after chest tube placement. That means OR. For cardiac tamponade, the thing I want you to remember, that is also a clinical diagnosis, and ultrasound is your friend. You can very quickly diagnose it with ultrasound. If someone has a cardiac tamponade, generally they're going to need to go to the operating room and get a pericardial window placed. But if you're in a place where you can't immediately get that person to the operating room, you can go ahead and do a pericardiocentesis. You just need to make sure you know how to do it and have your supplies ready. I want you to remember the right ventricle is most commonly injured because that is the most anterior, and you're going to assume that that person has injury to the heart or the great vessels if it's anywhere near the cardiac box. So think about this in terms of the nipple line anteriorly and anything above the scapula posteriorly. Don't forget the diaphragm. This is so important. So you need to consider that this person might have a diaphragmatic injury in anyone who has thoraco-abdominal trauma. Remember, chest wounds can easily track to the abdomen and vice versa. And the thing about diaphragmatic injury is that imaging and physical exam is usually unreliable. CT is not super helpful for these. Chest x-ray is definitely not very sensitive, and ultrasound's tough too. A lot of these are diagnosed after observing the patient and kind of having them declare themselves and then taking them to the operating room. Or if they're going to the operating room, these might be diagnosed. But if you have a suspicion for diaphragmatic injury, you should go ahead and admit that patient for serial abdominal exams. Why do we care? Because a missed diaphragmatic injury can lead to viscous herniation and subsequent strangulation years after the original injury. So this actually has a lot of morbidity associated with it. You're going to consider diaphragmatic injury in anyone who has a thoraco-abdominal trauma. So what exactly does that mean? 4th intercostal space anteriorly, 7th intercostal space posteriorly, and the costal margin. Remember that. So when do we go to the operating room in penetrating chest trauma? Anyone who's hemodynamically unstable and has a positive FAST, straight to the OR. Other things, the hemothorax with large output, as we said, greater than 1,500 mLs, or if they put out more than 200 cc's in the first 2 to 4 hours. Someone who has a hemothorax that's complicated by an empyema, so those are usually hemothoraxes that are a little bit older. Anyone who has tamponade, or someone who has a persistent air leak. If they have a persistent air leak, you have a high suspicion that that person has a tracheobronchial injury and they need OR. Let's talk about penetrating abdominal trauma. So why do we care about this? Well, the most commonly injured areas are the small bowel, the colon, and the liver. And importantly, obesity, contrary to popular belief, is not protective and can actually make your exam harder. It can be very hard to detect peritonitis even in a normal BMI patient, and obesity makes it extra hard. Approximately half of our penetrating trauma comes from stab wounds, and for patients who are hypotensive on arrival and have an indication to go to the OR, the risk of death increases 1% for every 3 minutes spent in the ED. Think about that. For 3 minutes in the ED, your risk of death increases by 1%. So 6 minutes in the ED, which is nothing, EMS might still be talking at 6 minutes, your risk of death has already increased by 2%. What this means is your patients need to get to the OR as fast as possible. So you need to know the absolute indications of when a person with abdominal trauma needs to go to the operating room. This slide is a little bit busy. I just want you to remember mostly the thoraco-abdominal region, because this is to remind you that injuries to the chest can easily involve the abdomen and vice versa, and the diaphragm is right in that thoraco-abdominal area. Remember, the diaphragm moves with respirations. So if the person is taking a deep breath, the diaphragm's lower. And if someone is breathing out, the diaphragm's higher, and that can change the level of your injury in that area. It can be abdomen or chest, or it can traverse straight through the diaphragm. So that's just something you should absolutely keep in mind when you're evaluating your patients. Some key points about penetrating abdominal trauma. So the whole goal of radiographic evaluation, essentially our whole goal when we are assessing abdominal trauma is, does this violate the peritoneum is there an intra-abdominal injury? If there's a hollow viscous injury, that patient needs to go to the operating room. Now remember, CT may miss hollow viscous injuries and diaphragmatic injuries. So patients who are pretty stable and you're a little bit unsure if they're not going straight to the operating room, they're great candidates to be admitted for serial abdominal exams, and you should observe them for about 12 to 24 hours. Also remember, and I keep hammering it home, ultrasound is your friend. We love ultrasound, and it has a great specificity for diagnosing intra-abdominal injury. It can show you free fluid. And the specificity on FAST for intra-abdominal injury is about 94 to 100%. So definitely pull that ultrasound over and get that involved to help diagnose whether or not there's an intra-abdominal injury in your penetrating abdominal trauma. All right, so this was a question that came up when I was researching trauma, and I never really questioned it when I was working in the trauma bays, but what's the deal with triple contrast? It just seems so mean to do to our patients, and it ends up delaying care by quite a bit. Triple contrast might be useful for back or flank wounds because it can help us to identify hollow viscous injuries, specifically in the rectum, the sigmoid, or the large bowel. But oral and rectal contrast delays the time to imaging by a lot. You need to administer it and then you need to wait. So you can only use this in patients who don't need to go directly to the operating room. And I would argue if the patient is stable enough that they do not need to go directly to the operating room, perhaps their end-year exam is equivocal. Perhaps that patient is stable enough to be admitted for serial abdominal exams, which is so much nicer than administering triple contrast. Furthermore, studies have shown that CT with IV contrast alone is 98% sensitive and 90% specific. So there's some pretty good evidence that we only need to give IV contrast. And if your patient is pretty stable, you have a kind of equivocal exam and they don't need the OR, maybe consider just admitting that patient and doing serial abdominal exams. What about DPL and antibiotics? I trained in a place where surgeons were still seen doing DPLs, and some of you watching this may work in places where DPLs are still performed, but the use is declining, and I would argue that it's really outdated. So why did we ever do DPLs in the first place? This was for patients who didn't need to go straight to the OR, who had sort of an equivocal exam, and we were trying to figure out if they had a hollow viscous injury and maybe needed to go to the operating room. But DPLs take time to perform. They need to be done in a pretty sterile fashion. A lot of times you need to intubate your patient, you need to give them some sedation, and then you have to send off the studies and wait for them to come back from the lab. This is not a super efficient procedure. These days, we can use CAT scan and ultrasound. We love ultrasound to help us answer these questions. Really, DPL is only useful if you do not have CT imaging or ultrasound. And even in resource poor settings, they generally have ultrasound these days. So for the most part, what we're going to say is DPL is out and it shouldn't really be performed. If you have questions about whether there's free fluid in the abdomen, grab your ultrasound. Again, it's higher than 90% sensitive and specific for free fluid. So you definitely want to grab that and use it to help diagnose this. And if your patient is pretty stable, doesn't need to go straight to the OR, they're probably a good candidate for serial abdominal exams. Okay, what about antibiotics? There's not a ton of evidence on this. There haven't been great research studies done, but there is evidence to show that you should give some antibiotics prior to tube thoracostomy. And if you're going to give antibiotics, it should be in the setting of a hollow viscous injury or someone going straight to the OR, and they should not be continued for greater than 24 hours. Those are the big points on antibiotics. And other than that, there hasn't been a lot of other great research. Okay, so when do we go to the operating room? These are things you absolutely need to know when it comes to penetrating abdominal trauma. Again, hemodynamic and instability and a positive FAST exam, straight to the operating room. Other signs, peritonitis, evisceration, GI perforation. For example, someone has hematemesis or a grossly bloody rectal exam, and impalement or an object in situ. Those are all indications to go to the operating room. A few words on penetrating pelvic trauma. This is a big topic. The big thing I want you to remember is there's a lot of blood vessels in there. So IR, interventional radiology, is going to be your friend in penetrating pelvic trauma. The other kind of good point to remember is that bladder injuries from gunshot wounds or missile injuries have a very high association with intestinal injuries. So if you see a patient with a penetrating injury causing a bladder injury, it is usually not in isolation, and that's the key point. Thanks so much, and enjoy the rest of the conference.
All right. Well, thank you, Jesse. Awesome job. And I particularly like the discussion on the finger thoracostomy. You'll hear me make this argument later, but I wonder if we ever really need to do a needle thoracostomy in the emergency department. I think we can do finger thoracostomies essentially just as quickly, and it's a more definitive management of the issue that we're dealing with. When we're talking about thoracostomies like this, we're talking about the worry for tension pneumothorax. So we're going to intervene. We have to intervene in a definitive fashion. And to me, the finger thoracostomy just makes more sense. I don't personally go through a separate site with the chest tube. I know Jesse talked about doing that, and there's lots of different practices. I don't know of any data that clearly delineates this, and we don't go through separate sites there, but lots of good discussion, and love the finger thoracostomy process. For any of you who argue that you can't do it as quickly as a needle thoracostomy, I've watched you do it over and over and over again. You do it just as quickly, particularly when it's an emergent procedure like this. So lots of great discussion. Thank you, Jesse, for that awesome talk. A couple things have come up. One very good point regarding the excited delirium. And point was made, and it is very true, that this is not a DSM diagnosis, and there have been some real challenges. Some people really struggle with the diagnosis of excited delirium. And it is true also that that has been used in some situations where perhaps medications weren't used in the appropriate manner or the appropriate doses. And so people have gone back and said that this whole concept of excited delirium is really problematic, and the ACEP white paper really needs to change that aspect of it. And I would say is, I do understand that there are concerns with this, and I do understand that that term has been used in perhaps ways that it should not. And if you really don't like the term, I'm less really invested in the term itself, but I don't think anybody can question that the extreme agitation is a very real situation that we face both in the pre-hospital and in the emergency department settings. And it needs to be intervened on, and it needs to be intervened on appropriately and aggressively, and they do get into a cycle that is very difficult to get out of. So whatever we're calling it, I think it's really important to acknowledge that we do face extreme agitation. In some cases, it's rare, but it does happen in the emergency department, and it needs definitive management for the safety of our patients. So I acknowledge that there's a lot of issues that come up with this, and lots of really good discussion going on about how best to take these next steps. But we do need to be ready to manage this, both in the field and in the emergency department when appropriate for our patients. So another discussion that has also come up has been on droperidol. And oh, by the way, on the ketamine issue, I use 3 to 5 milligrams per kilogram, go on the high side for intramuscularly for that extreme agitation. And as had been brought up in the chat, and I think is a very real point, the risk in my mind is going too low in these situations. It's much less of a risk going too high. I'm not saying that you should go way too high. I'm just saying that there is a risk for going too low when you're really dealing with severe agitation. So droperidol, I will say right up front, my favorite drug. I'm old enough to have used it way before the black box warning, and we used it all the time at Denver General. We used it for many indications, but primarily for agitation, and used it for in fairly significant doses, 10, 15, 20 milligrams, and really did find it a very effective medication. So it really became my favorite. I really struggled with the when it came off so many formularies during that initial period after the black box warning. I'm very glad that we have it back on our formulary at San Francisco General. But I know there's a lot of you out there, like Britt, that haven't had a chance to use it yet. And so I want to talk a little bit about just our experiences with it. And since you've already heard mine, I want to hear from Ryan about his experience with droperidol.
Thanks, Chris. Yeah, we luckily over this last year at University of Utah, droperidol is on the formulary. We use it quite a bit, and I think it solves almost, it's helpful for pain, for nausea, vomiting, for headaches, for agitation. So it's great to have it on there. And I was absolutely partially reluctant to take a new job because they did not have droperidol on the formulary. So, Britt, have you ever gotten to use droperidol?
I hear about this wonderful drug and this magic drug that solves everyone's problems in the ER. Unfortunately, I work at places where they are still taking that black box warning pretty seriously. So unfortunately, I haven't had the pleasure of using it, but maybe someday I too can be part of this awesome group that uses this medication to control everything in the ER.
So my challenge to Britt is going to be, one time you're going to need to do a shift, and the only medications you can use are droperidol and ketamine, and I would bet that you're going to have a great shift in doing that. I think it does address a lot of those issues, and just really encourage those of you who have not had a chance to use it, that as it starts to become more common and we're starting to see it in more and more settings, please consider its use. You can start low, you can start in areas that you're comfortable with, but I do think it is a very good medication in the emergency department. So also lots of good questions on the chest tube issues and antibiotics. I will say off the bat, and there was some good discussion in the chat, there are some that are using cephalosporins when they are putting in chest tubes. We don't routinely give antibiotics, particularly before most of our chest tubes are being put in, but I know there's a lot of different practices out there, and Jess had some nice comments in her talk about that as well. So we're now coming up on time for a break. So Britt, take us to that next step.
I will take you to that next step, but Ryan really wants to share something.
I
quickly.
want to trademark dropetamine, and I think it's going to be the best drug ever. You heard it here first. All problems solved instantly. And yeah, just on the antibiotics for chest tube stuff, I tried to type it into the chat, but it wasn't working. But the East guidelines for 2012 are also kind of equivocal on antibiotics for chest tubes. So I think a lot will depend on kind of local practice and the kind of your gut feeling.
Okay, now we are going to go to break because we have had a jam-packed morning session. We've had radiology rounds and covered CT head. We've had an awesome consult corner with Joe and vascular surgery. So I think we all could use a coffee break and a pee. All right, so we'll be back in 10 minutes. Enjoy your break, get some stretches, get some coffee, and we'll see you back soon.
All right, welcome back, everyone. Hopefully you are all coffeeed up and emptied out. And we are moving next. We've been hearing a lot from the doctor's standpoint, but next we're going to hear from a patient standpoint. This really compelling video, and we're going to hear directly from a patient named Albert.
Hi, my name is Vanessa Jackson. I'm a case manager slash social worker associate at San Francisco General Hospital. Today I have with me my patient slash friend client, Albert.
Hi, everybody. My name is Albert Feaster, and I'm a client of the Wraparound Project, and I'm here to tell my experience in a trauma unit.
Can you tell me a little bit about what your trauma experience was like?
My experience going through the trauma unit was like, it was life-changing for me because it was something that you only seen on the movies, or it was only something that you heard people talk about their family members went through. So for it to hit so close to home, for it to actually happen to me and me experience it, it was life-changing.
Wow. Can you give me a little bit of like, what was it like in the ambulance? What was that feeling like?
When I first got shot, it was horrifying, and to wait for the ambulance to come was almost like it was the worst part, because you don't know if the ambulance is on its way in a couple of minutes or if they're gonna take more time than that. So that was like the most horrifying part, waiting on the ambulance to actually arrive. But when the ambulance finally did arrive, they put me up on the gurney to lift me up into the ambulance, and they had to check and see where did I actually have gunshot wounds. So they was checking my whole body, and they had to cut my clothes off so that they can examine my body. But the medic, he made sure that I was coherent and asked me a lot of questions during the ambulance ride.
So once you arrived to the emergency room, how did you feel? What was that feeling like?
When I first arrived to the emergency room, it was, like I said, it was a scary moment for me, because I didn't know how severe my wounds were. And to go into the emergency room, it was kind of like a shock. It was like, I can't believe this is happening to me. Like, I'm here. Like I said, you only see this in the movies. You never expect to be in an emergency room. So like your worst fears is starting to come into reality. Like, is my life gonna end? Like, is this where my life gonna end, in the emergency room? So it was frightening to enter into the emergency room.
Did anyone introduce themselves? They say that they were doctors, nurses.
When I entered into the emergency room, most of the doctors, they did introduce themselves, but mostly they were like concerned about seeing what type of process I needed to go through. You know, they got the typical process that any person that goes in with gunshot wounds, that they follow those procedures, but they needed to make sure what was wrong with me before they can start any of those procedures. But the doctors, they did introduce themselves.
Oh, okay. What were your fears?
I didn't know the severity of my gunshot wounds. I didn't know whether or not my family was going to be notified. I didn't know whether or not I was gonna die or if I was gonna live. I seen my arm because I got shot in my face and in my arm, and my arm was just like dismantled. So I was just having like the worst thoughts in my head that I was gonna have to get my arm cut off, and so it's like every fear that you can possibly have, it overcomes your body.
How do you feel like was there like a difference um, with the men and women staff?
Um, that's a good question. My upbringing, the women were always nurturing and compassionate, and the men were always stern and like providers, protectors. So with that upbringing, me going into the hospital, seeing women, doctors and nurses versus men, doctors and nurses, that's what I identify with. So I recognize that the women doctors were more consoling, like making sure that I'm gonna be okay, telling me that I'm gonna be all right, saying things to me, to keep me calm. Um, the men doctors, they were just as compassionate, but they just showed it in a different way. So they were just more, a little more stern than the women.
My next question I want to ask you may be a little sensitive, but I want you to be very transparent. I want you to really tell me your feeling that you had and how you felt and if you experienced it or not. To me, I think it will be a little emotional maybe for others, but I just want to ask this question. Did you have any interaction with the police in the emergency room?
When I first came into the emergency room, um, the first people I seen was the doctors, of course, but I immediately noticed the police presence inside of the emergency room. Throughout this whole experience in the trauma unit, this was the worst because the police, they didn't treat me like I was a patient. They more or less treated me like I was a suspect to a crime. Um, they were questioning me. Well, I don't want to say questioning. They were more interrogating me, trying to figure out, um, do I have a gun? Do I have gunpowder residue on my hand? They wanted to search my bags. They wanted to go through my phone to see who I had contact with. Everything that they was doing was making me uncomfortable because of the situation that I was currently going through. I felt like I was fighting for my life because I was the victim of gun violence. I didn't know that the police were able to talk to you like this when you can possibly be on your deathbed. So that it was a horrible experience with the police in the emergency room.
Whew, sorry to hear that. Did you feel like the doctors could have secured your privacy or they could have been there to protect you to say, hey, like, is this person a suspect of a crime? We're here trying to work on his wellness, his health, trying to save his life. Could you like back off from the questions right now? Is this really necessary? Did anybody come in or say anything of that nature? Or
The doctors was moving around a lot, dealing with me, dealing with each other, going in and out of other rooms. And as the doctors and the nurses was moving around, the police officers was moving around as well. So I was in a vulnerable position for the police officers to come and approach me while the doctors was attending to other matters. And me being the first time in the emergency room, I didn't know whether or not I had patient rights or not. And I think that the doctors did a great job with helping me out, but I just feel like the doctors could have been there to notify me of my patient rights, so that way I can feel safe in that environment and not feel like I'm being harassed by the police. That's the only thing that I feel like was missing.
You felt totally disrespected at that time because you came in for an injury and you were being interrogated.
After I went through my surgery and was in the recovery room, that's when the paperwork started coming in and the pamphlets started coming in and me being introduced to different people. But that was after the fact that I already felt like I was being harassed by the police.
I guess with this, I want to ask, how do you think it could have been done better, like as a trauma patient? How can the doctors and nurses maybe improve on that part of your patient care?
What I think could have been done better is that there could have been a doctor in place to talk to me about the patient rights, or there to tell the police officers to listen, he's in our care right now. If he's not a immediate suspect of a crime, or if he didn't come in here in the middle of a crime, can you please let us take care of this patient first? People just don't go to the emergency room every day to where they just got all this experience on what should be done and what shouldn't be done. So as somebody, as a patient being the first time here, not knowing what's right or wrong, maybe there could be a doctor there specifically to talk with the police officers or talk with the patients while the other doctors handle all the care.
So this will be our last question, and it's just kind of like a three-parter. So looking back on that day of injury, how does it affect you now mentally?
I'm more vigilant of everything now because of how the situation happened. Every time I go outside, I'm always alert of my surroundings. I'm always suspect of the people that I meet. When it comes to certain conversations, I only give up limited information about my personal life because not knowing who the culprit was to this shooting is just it's open air. I was staying in San Francisco at the time and planned on continuing to live in San Francisco, but I had to move out of San Francisco and relocate to another area. And still, it's like I think about it every day. It's like it was the ending of my life, but the beginning of my life. So mentally, it's kind of like it's hard on me. It's like everything is suspect to you now. So mentally, it's hard. I want to thank everybody that allowed for me to tell my story on this platform, because that is one of the things that affected me the most, because I never had the opportunity to vent. I never had the opportunity to open up and express myself. And the more that I was holding it in, the more I was holding it in, the more and more I was slipping into depression. And I was feeling down. And I was feeling like a dark cloud was hovering over me everywhere that I went. But whenever I had the opportunity to express myself and tell my story, it helps me out. It brightens up my day. It opens up my mind to new things. It allows me to grow as a person, as an individual, as a man. So I appreciate everybody that had a part of me being able to express myself and tell my story, because it makes me feel better about the outcome of a situation that I don't wish on nobody. So thank you.
So thank you, Vanessa, for navigating that, and thank you so much, Albert, for being willing to share that experience. That his experience was in the emergency department that I work at, San Francisco General, and I find it so valuable to hear him talk about what it was like for him. And I know it brings up some really important issues about law enforcement in the emergency department, and there are many different things that come up with this, and lots of tough situations that we face as we are navigating this, particularly now, and probably now more than ever. But I just really find it moving and important to hear his perspective and to hear him talk about what it was like to come in as a patient and feel like his life was in danger, and with the different mixed emotions of his experience there in our emergency department. So thank you again, Albert, for being willing to share that, and I hope that was valuable. I find that really important to listen to. So we're now going to switch gears and go into ultrasound guided blocks. So Britt, what do we have to know about ultrasound guided blocks?
Yes, this next segment is one of my favorites. It's with Arun, and I think, we always have to manage pain in the ER and broken hips, multiple rib fractures. What's the best way to do that? And Arun is going to walk us through some really interesting blocks.
Welcome. My name is Arun Nagdev. I'm the ultrasound director at Highland Hospital in Oakland, California. I'm going to hopefully take you to an interesting journey in how to use ultrasound-guided nerve blocks in trauma. I'm very excited to be part of the Trauma Fundamental Conference, and let's go. So I think emergency medicine has rapidly changed over the last decade that I've been involved in pushing using ultrasound-guided nerve blocks for trauma care. We have really evolved as a specialty, and I think that today, taking care of our sickest patients, doing the optimal pain control is really where we are. And I think the fundamentals of this is multimodal pain therapy. And if that is a fundamental, then ultrasound guided nerve blocks should be a definite part of this. Today we see these patients, and I think everybody here has seen hip fractures, and we see them all the time. And this population is probably our neediest. Injuries in elderly patients when they break their hips, and even in non-elderly patients, a monomodal therapy with opioids is just not there anymore. This population has higher rates of delirium, has higher rates of hypotension and apnea, and we really have to find a way to make this an easier pathway. And I really do believe that an acute management that starts with femoral nerve blocks on these patients makes a huge difference. This is our patient. It's actually one of our residents who actually went hiking up in Yosemite, and you can see this 3 rib fractures anteriorly, actually had 6 large pneumothoraces. This is a great tool for us to implement in these trauma patients. We use the serratus anterior plane block, which I'll talk about today, to offer pain control for rib fractures, specifically anterior and lateral. In patients that are stable with chest tubes before they put the chest tube in. We've done it for zoster. We've done it for thoracic burns. And it makes such a big difference. And along with just the pain control, the patients breathe better, have lower rates of later on atelectasis and maybe infection. And our trauma service now asks us every time we have rib fractures to perform a block. It's done at the bedside, it's done quickly and very safe. And also, I think this is really what we take care of, right? This patient comes in with a huge open femur and knee, and waiting to go to the OR for a washout in a couple hours while they're in severe pain, our ability to manage their pain successfully, multimodal, and with nerve blocks changes the ballgame for these patients. Along with their discomfort, I think it's the right thing to do. And we as emergency physicians are always taking care of the neediest. And this is our population that we really want to take care of. So pain management and trauma is really a three-pronged approach for me. It's always multimodal. NSAIDs, ketamine, whatever you need to make the patient comfortable. It's non-siloed. So that means it's us, our colleagues, our trauma surgeons, our anesthesiologists working together to take care of these patients rather than having one department deal with the pain control. And last, active. And I think that's our responsibility, to be active members in the process of making pain control a part of our job and to really help our patients. And when I say active, I really mean ultrasound guided nerve blocks as a pathway for you to become an active member in this process. Let's start with some basics to get over some real small items. First, let's talk about probe cover and sterility. I think a standard single injection nerve block, you're not placing a catheter and leaving it inside. All you need is either a tegaderm or some type of sterile dressing to protect the probe and the patient. You don't need to be fully sterile. So for all of our blocks, because we're at a teaching institution, we classically have this technique where I have the needle, which is a block needle or blunt tip needle, attached to this syringe and tubing. What this allows is my resident is able to get the needle where he or she wants to be, and I can inject normal saline to both hydrodissect, that's a term they will use, or hydrolocate, which means putting fluid and making a nice window for the needle tip so I know I'm in the right spot. Plus, I can be comfortable with the resident using the normal saline to get the right view they want, and then I can slowly and gently, once I've found that spot, inject anesthetic. When I work as a solo provider in my ER, I also get the nurse to do the pushing of both the normal saline and the anesthetic. For needles, below we have these specialized block needles, or blunt tipped. Really nice because they come with this little catheter. If you don't have that at your center, you can just use your regular spinal needles that you probably have stocked in your ER, the 21 gauge, the 18 gauge, whatever you like. I would recommend not using a sharp regular 25 gauge or 27 or a 21 gauge cutting needle. There's some theory that that could cause damage if you bump into a nerve. So one more term I'm going to talk about is in-plane. This is just for the ultrasound novice people. Again, the idea being that you're visualizing the needle tip or the needle all the way through. And the key point is to always recognize where your needle tip is. That's why adding that normal saline opens a space up, and you'll see in some of my videos, it really allows you to see where you want to go. So what do nerves look like on ultrasound? I mean, this is kind of a question I get asked all the time. And this is a median nerve that we're looking at here. You can see the nerve is just right in this space. And they're like, when I started doing this, do you want to get the needle in the nerve? That seems like a bad idea. I don't want to hit somebody's nerve. And so I'm going to say this, and people are going to argue with me, but I think all nerve blocks are fascial plane blocks. So once you find the fascial plane, you open the fascia and the fluid will track around the nerve. I'll explain what that means. Here's that median nerve again in a still. There is a fascial plane that wraps on the muscle on top and the muscle on bottom, and kind of in between sandwiched is that nerve. The goal of it is to get fluid in between that fascial plane and let it slowly move over. It's a lipophilic anesthetic that will slowly absorb into these nerve bundles and cause numbness or motor weakness, which is essentially a good block. There's no reason to get even closer because you're just kind of adding fluid into the right space. You can see here one of our senior providers. You'll see this is a kind of a space he's opened up, and he's coming in again closer than I like, but you'll see how you'll push fluid and kind of track it to the side. You don't need to have that classic donut. People will talk about this in the anesthesia literature. If you want the block to happen in a minute, yes, it's great to have perfect blocks. Safety is way more important. And again, this is pain control down the line. So be safe Keep the needle in the fascial plane, open the space up, and gently deposit anesthetic. You can see here with my resident, she's coming in. Not a great fascial plane, but she knows that this white line is probably a fascial plane. She comes in and just opens the space up, gently pushing normal saline, and then we're going to dump anesthetic in. This nice anechoic space allows the needle tip to be really clearly visualized. Again, what you don't want to do is come in right into the fascicle and dump in anesthetic, because theoretically this can cause a little kind of like almost like a compartment syndrome in this area and maybe cause damage to the nerve. Ideally, stay away. If you look at the data on this, a lot of anesthesiologists will come into that nerve area, which I don't like. It's probably safe, but I think it's always better to be safer, because our goal is not to have a perfect block right away, but it's a multimodal strategy for pain control. You can see here, my resident by mistake dumps it into the wrong spot. This patient was fine. We followed this patient out. There was no downstream effects, but again, it's better to be safe than to be sorry. For anesthetic choice, I always recommend, if you're an advanced provider, you can use bupivacaine. We have other anesthetics. Ropivacaine is the one we use for longer acting blocks, up to 2 to 6 hours, like bupivacaine. We use ropivacaine because it's theoretically safer than bupivacaine. So if you're a novice provider, I would start with using lidocaine, which can last 2 to 3 hours. With epi, you can make it almost as long as the bupivacaine, and always inject 2 to 3 cc's at a time. The worry is that somebody's going to dump in all 10, 20 cc's of anesthetic into the vasculature. That can cause systemic absorption and a thing we call local anesthetic systemic toxicity. Before you even start that route, you should always use, I think MD Calc does a great job of this. They have an anesthetic calculation. You put in the patient's weight, what medications you're using, and will tell you the max dose of anesthetic. It's a great tool. It's on your phone, really easy to use. What we worry about is if you're going to dump that anesthetic directly into the vasculature, which again, safe, slow, simple, away from the nerve, it's probably not going to happen. I recommend anybody who's going to be doing blocks in their ER buy this simple. You don't have to put it in the refrigerator. We put it in our Pyxis. We have it in our block cart. It's local and it's a intralipid. If, God forbid, somebody has a reaction to the medication, you can administer it. I'm not going to go over the details of this, but you can look at a great website called Lipid Rescue, and we'll tell you exactly dosing, how much to use. Again, knock on wood, in 15 years, we have not had this issue, but it can be something that can happen. So I think that everybody who's going to do blocks should have intralipid somewhere in their ED. So let's start with a femoral nerve block. Let's get to the nitty gritty. And this is something that I think everybody here can walk out, get a couple do a couple hands-on with either a colleague or a simulation and really do it. Our residents do this all the time, and it's become a standard. This is emergency medicine at its best, right? We're taking care of patients that everybody else is going to put in a box, wait for tomorrow morning to get a hip repair, get a bunch of opioids, and see what happens. We, I think, are better than that, and we can use multimodal pain strategies to really make this a reasonable injury that we take care of. Again, the classic anatomy that we all know. Nerve, artery, vein. We all have done femoral lines. So nerves, lateral, artery, and vein. You want to come from a lateral to medial approach. It gives you pretty much anesthesia all the way on the thigh region. You won't get a perfect surgical anesthesia of the hip, but what you will do is you will have some pain control with your other medications such as NSAIDs and acetaminophen. Here you go. So this is the classic hip fracture. This is our classic hip fracture in our institution, but it really works great for any kind of injury all the way down to the knee. We've used it for debridements, for large lacerations, but really ideally is for hip fractures and femur fractures. Again, the probe marker is facing here right on the inguinal ligament. I have the ultrasound screen on the contralateral aspect because I want to have clear visualization of that screen. And you can see here that nerve, artery, vein, repetitive concept I'm kind of reminding you guys of that I'm sure most of you know. You can see here's a schematic that you classically see on anesthesiology websites, and they'll talk about this triangle, and everybody's probably heard this term. And I want to kind of demystify this. I think the key on this, when I started doing this, was I would try to come into the triangle and dump anesthetic, and I've stopped doing that because I realized that that triangle, this is probably adipose up here. This is probably the nerve, and what really is more important to me than that structure is the fascia iliaca. Because if I get my needle underneath the fascia iliaca and drop anesthetic, or even just normal saline, that space will separate, and then I know I'm in the right spot. I can just go ahead and dump in my anesthetic, and I'll show you some videos of this. Let's do some pattern recognition first. So here you can see that femoral artery, boom, 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 right? That femoral artery is right there. There's that triangle, and there's your muscle. And again, some of you really smart people can probably see this fascial plane right here. This is a nice young person with a nice fascial plane. And the idea being not to come here like I did when I started doing this, but to come more lateral and open this space. Same thing on the other side. In that pattern recognition, you'll see that triangle, you'll see that artery. And when you see that, you know exactly where you want to go. And now, one little adjustment, recognizing that fascia iliaca, you can really do a great block. So again, the supplies, our website, highlandultrasound.com, has all these listed for you guys. You can look them up anywhere, but the idea being you want a large volume block, about 20 cc's. I commonly put 20 cc of anesthetic based on the patient's weight. And then I put another 10 cc's and a 10 cc's of normal saline to flush it. And you'll see here, my ultrasound probe is almost parallel, really high, because you want the femoral artery to join. If you come lower, the femoral arteries bifurcate, and you won't see that classic structure. So you want to be as high as possible, right underneath the inguinal ligament, from a lateral to medial approach. So again, here's my schematic for this. The goal is really to get underneath this fascia iliaca and really not sit up here and just dump fluid in this anesthetic or this adipose area, excuse me. The goal is to pop underneath it, and you'll see anesthetic tracking medially. They call it unzippering of the fascial plane. Here's a nice schematic. You can see there's your artery, there's your fascia iliaca. And you can see that the goal is to come underneath, pop, and then dump fluid. I even would recommend even coming a little more lateral, maybe going the muscle. You dump fluid in the muscle, it'll just sit there. As you pull back gently, fluid will track medially, and you'll be in the right spot. Here's some videos. You can see my resident comes a little closer on light. There's the needle. They're coming in, and right now, somebody's pushing some normal saline, opening that space up. You can see how fluid's tracking medially. That's perfect. And then what they do is they open that space up. They have a nice clear window, and now they'll gently place anesthetic. 1 to 2 cc's at a time, aspirate. 1 to 2 cc's at a time, aspirate. And the beauty of this is you have a nice clear window. You have great needle tip visualization, and you know exactly where you are. You can see the nerve is right down here. This is probably all adipose. And so what's nice is you open that space up, and you have a great block. Here's another example. This is a gentleman that came in with a bad, I think a bad femur fracture. My resident and I, the minute they got back from CT, we blocked. And you can see there's this nerve, kind of this weird triangle. Like, that's an odd looking triangle. You can see if it is blind, we'd probably miss it. We come in and pop into that space, push the normal saline. You see his nerves just sitting right next to his artery. This guy got amazing pain relief along with some opioids, along with some NSAIDs, and was really comfortable while he stayed in the ED and went to the floor. So real win for our team. Here's another example, again, lateral to medial coming in. There's that triangle that you're looking at. If you're really smart and you're really great at visuals, this is probably your nerve, this is probably your adipose. You can see they come in, they're pushing anesthetic, actually probably pushing normal saline to open that space up, and then they're just gonna hydro dissect and then dump in the anesthetic gently, slowly, with just so easy that this is a nice block to be able to do at the bedside. So a couple key points. 1, underneath that fascia iliaca, always try to get underneath it. And 2, stay away from the nerve. You'll see from the first video, my resident is above the fascial plane. This is the artery. This is that triangle. And you can see the needle tips here. He'll dump in a little bit of fluid above. You see that right above? And so then I'm like, great, I know exactly where you are. Now just pop underneath that. He gets underneath, and then you can see how now he's underneath the fascia iliaca, gently dumping in probably normal saline and then some anesthetic. Here's another example of really staying away from the nerve. You can see the needles coming from a lateral to medial approach. Here's your femoral artery. This is the fascia iliaca, which I've drawn out for you guys. And he's coming in lateral to medial, And the goal is to get underneath that fascial plane, far away from the nerve. He breaks underneath it, and then I gently inject normal saline, which kind of unzips that space. And then he just goes ahead and keeps the needle there. I put in the anesthetic gently, and this nerve is going to be insensate very soon. So again, femoral nerve blocks are great. I always recommend writing on the patient if you're doing it, and then document the chart. The internist is going to look at the chart, and your orthopedic colleagues are going to look on the patient. So again, this is a high volume, simple planar block, which I think all blocks are. Great for hip fractures, femur fractures. Remember to get underneath that fascia iliaca and stay away from that nerve. The second block I'm going to talk about today is the serratus anterior plane block, which has really revolutionized the way that we take care of our trauma patients. Anybody comes into our department with multiple rib fractures, pre-chest tubes that are stable, chest wall burn, zoster, this block works like magic, and it's such a simple block. This is like basic stuff that you guys can literally take to your shop and be fantastic. You know, like, wow, I can't believe you can do this to patients. This is so amazing because it reduces all the complications or downstream complications of rib fractures, and patients are comfortable. Giving opioids to rib fracture patients, we know doesn't work very well. So again, just some basic anatomy. You guys all know how to do thoracentesis, and again, we know that nerve, artery, vein runs underneath the rib. This is the thoracic intercostal nerves. And when you think about it, like on kind of topographically, this is your latissimus dorsi, this is your serratus anterior muscle, and these are your pec. And that little triangular space in between where you commonly put chest tubes is also an area where you can dump an anesthetic right over or under the serratus muscle, and it gets great pain relief. You can see here, the patient's rolled to the side. I have the probe sitting right on top. And if you kind of peel that away, this is your thoracic spine. You can see the thoracic intercostal nerves coming up on each level. And then what happens is they come out are the lateral cutaneous branches between your latissimus dorsi and your pectoralis muscle. And the goal is to dump anesthetic into this space. And I'll show you a little bit more clearly where that space is. But once you can figure this out, it is such a great tool for you. Again, if the patient's rolled to the side, you can see the mid-axillary line approximately, and you're about the level of the nipple. So just to give you kind of a basic landmark, again, you can do this on any level because once you dump anesthetic into that space, as they breathe, fluid will track in a cephalad and caudad direction. And again, here, what you're looking at, and I'm going to show you a little video. This is the first thing you see is the rib. And then if you've ever done ultrasound before, you'll see that pleural line. This is a serratus anterior muscle. This is latissimus dorsi. And you're going to come in from posterior to anterior and kind of pop fluid into this fascial plane potential space. And what's going to happen is that fluid will cause anesthesia or cause reduction in pain for this patient with bad rib fracture. Again, here's that kind of anatomy with a little bit of video. Now this one, we're a little more lateral or a little more posterior, so you're seeing a little more of the latissimus dorsi. But again, this is that space. Here's that rib. Here's the pleural line sliding back and forth. Again, on our website or any other sources, you want a large volume block, so commonly it's 20 and 20. And again, the goal is to get the needle tip into that fascial space and then just gently push fluid, and fluid will track in that direction. Here's a great schematic, and you can see how the idea being the goal to come from that lateral or posterior to anterior direction and dump in anesthetic. And the beauty of this is that this one level, the fluid will track again to multiple levels. And again, this is the idea. When you look at MRI studies of injected dye, it tracks up. The patient will help you because they will breathe and the fluid will track in that direction. And each level has this thoracic intercostal nerve, so they will work for multiple levels, which is great. You have a zoster patient, you can go a level above or a level below, and it'll still have good pain control. So here's that video again. There's that rib. There's your pleural line that will be sliding. And the goal is to come in from that clearly in-plane visualized needle, pop in. Come on. There you go. They're trying to pop through that, and they're going to open that space up with again, initially just normal saline. Once they open that space, if I know it's tracking, then I'm going to add in the anesthetic. You can see here, this is pre-block, and then here's post-block. And what you're seeing is that fluid tracking in that direction. Again, all blocks to me are fascial plane blocks. For some people, you're not going to be able to see that great fascial plane. So again, the serratus muscle is serrated, so it's finger-like. And if you can, this patient population, we have really elderly patients with rib fractures that can't commonly see these fascial planes. You can just come up and hit the rib and dump it underneath the rib. And that works fine right on top of the surface of the rib. And that will give you the same anesthetic control as going above. So either one works. And in the really, really thin populations with no muscle, this may be more useful. So again, the serratus anterior plane block is a high volume planar block. Rib fractures, zosters, stable chest tubes. This is like perfect for our trauma team. They love it. We block them. They get a little bit of ketamine. They pop a chest tube in. It actually causes less pain later. Remember, above the rib, or above the muscle, whichever one you like, depending on the patient's anatomy. And like all these planar blocks, including the femoral nerve block, it's delayed onset. Walking up to the patient 3 minutes after your block and saying, do you feel better? They're gonna be like, no, and you're gonna think you failed. Come back 30 minutes. I know it's really hard for emergency physicians, but we have to do it. So summary, active pain management in trauma is really important, right? This is our job. We gotta be active about pain control. And emergency medicine 2021, when it comes to trauma, is really a multimodal pain strategy. Again, use your intravenous medications, your oral medications, and really always think about ultrasound-guided nerve blocks. It will change the way you practice medicine and really change the pathway for patient care. Thank you.
All right, that was fantastic. We feel super fortunate to have Rune explain that to us, and I love the idea of this just being commonplace, this just being normal. Blocks instead of relying solely on opioid pain management. Also, for our earlier segment with Albert, a lot of people really enjoyed that, and it's a pretty powerful and compelling segment. There is a longer version of that that's available on EMRAP HD, so we had to, consolidate for the live version, but definitely check out the longer stuff. There's additional kind of information and nuance that I think is important. So next up, Britt, you had a case you wanted to tell us about. I thought it was kind of interesting.
Yeah, I did. We had, it was bad trauma, multiple stab wounds, and you just got a pan scan, right? You just got to scan everything.
Sometimes you just got to pan scan people. You scan them.
You pan scan them. If you pan scan, you're not going to miss anything, right? Just pan.
Yeah.
Scan.
Chris, is that what you guys do? You pan scan people all the time?
Just a big pan scan.
Just pan scan them?
Okay, so we're going to just take a little deviation here and let me rant for just a minute on the term pan scan. I have tried to, full disclosure, I've tried to make this an illegal term at San Francisco General, and I've had moderate success in doing that. And the reason is this. I get it. There are going to be times that absolutely in our major trauma patients that we are going to need to scan virtually the entire body. But to me, the term pan scan is just lazy. And the reason that I'm concerned about it is like when we use the term trauma labs or cardiac labs or whatever, I'm not sure we always understand exactly what we're ordering when we use that term, and we can throw it out and it almost sometimes becomes associated with trauma. Oh, big mechanism, pan scan. And I really think it's important to think about each part of that scan. And do we really need a head, a neck, a chest, an abdomen and pelvis? And if we do, then fine, get them. But at least take the moment to think about each one of those. And I really worry that the term pan scan allows us to just throw that out there and not necessarily think about each and every scan. So I know we're going to do all those scans on some of our patients, maybe on a lot of our patients, but I really hope that we are taking the time to think about each one of those. And do we really need it? And if the answer is yes, great, we'll get it. But I would love to see the term pan scan just go away. So thank you for indulging me on that rant. We do have a minute or two for a couple of questions that would come up. So Britt, what do we have?
Yeah, and just a quick aside though, I'm pretty sure Ryan being Ryan threw in the word pan scan just to boil some blood in a couple of his lectures.
Like 3 or 4 times.
Yeah, so I apologize for that. I don't think he does.
I'm enjoying watching the smoke come out of Chris's ears.
Yeah, so one of our questions that came up was back to the chest tube, and we're going to have debates on chest tube. We have so much more to come on that. But one thing that came up is if somebody is already stabbed in the chest, can we just insert the chest tube through that stab wound?
So my answer to this, first of all, I love the question because I can tell you I have actually had that temptation, that thought, sitting there with a patient with multiple stab wounds to the chest and seeing how, boy, that's right where I would have been tempted to go. Maybe I can just kind of stick a chest tube in there and be done with it. And I have been tempted. I don't know of any, and maybe somebody can correct me if I'm wrong. I don't know of any literature that has actually looked at this, but I got to admit, I haven't done it, and as much as I've found it sometimes to be tempting, I have not been able to take that next step and actually put a chest tube through a stab wound. Again, I don't know of any data that clearly tells us that, but I'm not quite ready to do that myself. I don't know. Britt, Ryan, you guys?
I mean, it sounds so tempting, right? There's already a hole. Just put the tube through the hole that already exists, but I don't.
I would start from scratch.
Yeah.
You don't know where that hole's going. All right. So I think we're going to move on now to our next talk. A lot of the questions in the chat have referred to some stuff that's happening pre-hospital, and we're lucky enough to have Ben Launer and Chris talking about some pre-hospital and EMS issues.
This section is one that I'm particularly excited about. We're going to talk about pre-hospital trauma management and the role of pre-hospital care in the management of the trauma patient. And it's one that I have felt has never really gotten the respect that it deserves, almost the Rodney Dangerfield, I'm aging myself there, of trauma care. A lot of times it gets simplified down into just shorten your scene times and get there quickly and don't worry about it. And yet, much of what we do in the field really can impact our trauma patients, and whether they are short scene times, short transport times, or prolonged ones, we can initiate early interventions that can make a difference in our trauma patients, or we can also do the opposite and get things started in the wrong direction. And so I think pre-hospital is an incredibly important part of trauma care. So we're excited to get a chance to talk some about that here this morning. And with that, we're going to have Ben Launer. So welcome, Ben. Ben, I'm going to introduce you just real quickly. Ben is an assistant professor at the Department of Emergency Medicine at the University of Maryland School of Medicine. He did his residency there and his EMS fellowship there. He's also a paramedic, by the way, and is now serving as medical director for many systems across the Baltimore, Maryland area and extending into Pennsylvania and others, Air Life included, or Air Medical included, is also the EMS, the program director for the EMS fellowship at Allegheny Health. So you wear many, many hats, but I'm going to argue that the most important one is you are the EMS, the section editor for the EMS area of the Corpendium EMRAP textbook, and are doing an awesome job of that. And that is soon to be released as well, thanks to the excellent work of Ben and many of the authors that he has recruited. So welcome, Ben, and thanks for taking some time today to talk what, again, I think is an incredibly important topic.
Well, it takes a village. You talked about aging yourself, so I can probably throw right back at you the multiple layers of saline we used to put into people. We got mask pants, so I'm all about that too. There's probably a couple of EMS dinosaurs bringing back the past. I appreciate the kudos. That is very kind of you.
I want to just throw out there, what about CPR in trauma patients? And the reason I ask that is because, CPR makes a lot of sense to me when we're talking about a cardiovascular arrest and we need to get the pump going again. And although I can conceptualize an idea of, sure, trying to get blood out when the heart has stopped makes some sense even in a trauma patient, but when the heart has stopped because there's no blood and they've run out of blood, I'm not sure what CPR is really doing, or things like epinephrine. So So we'd love to hear your thoughts. You're responsible for a number of different systems, including air medical, which obviously, and some with long transport times, some with not. Does it make sense to do CPR in trauma patients?
So hopefully this is a little bit of a safe space, right? So this is where we can talk about the evidence-based interventions in the ideal world as opposed to what happens. But I think you'd be hard-pressed to say that there's an evidence-based indication for closed chest compressions and cardiac arrest. I mean, what happens in a trauma center, right? The goal is to open the chest and quickly reverse, or perform resuscitative and stabilizing interventions so that we can fix the root of the problem. So it's very difficult to conceptualize, for example, that you're gonna compress on an empty heart, and that in some way is going to go ahead and mitigate a solution. So number one, I think it's very difficult to argue that there is evidence-based utility. But also, given the level of providers we have, given the wide range in training and even facility and capability, the real challenge is how to operationalize an evidence-based trauma arrest protocol, in your own jurisdiction. So I think this is something that deserves a lot of discussion. And quite honestly, we've really been stuck in this paradigm of, load and go versus stay and play. And the truth is, I think that you've alluded to, if you don't have blood and you're away from a hospital and you go into trauma arrest, you can load and go all you want. You can even put a Lucas on a patient. It's not going to help the underlying problem. There's only a couple of things you need to do immediately, which is manage the airway, replete the blood, fix the hemorrhage. And the clinical decision is if you cannot do any of those things and you're farther away from the trauma center, even the trauma system's own guidelines will say, there's really nothing we can do for that patient. And I think that's the disconnect between, rapid bolus of diesel fuel, for example, to the trauma center, and what are we really doing on scene? But that is a very difficult question for the in full disclosure, and that really depends upon the capabilities, the geography of an individual system. But I think to answer your question, which is the most important one, really low utility for closed chest cardiac massage. There's an article we should reference, and even I think it was a seminal article many years ago written by Griff Davies. Hello, and I want a ride on the London HIMSS helicopter because we're referencing you in EMRAP. But he said who are the survivors of traumatic arrest a long time ago, and this was, I believe, pre-deployment of blood. And he said that the people that were surviving trauma arrest, I think it was up to 5 to 7%. That population was suffering from either tamponade, massive hemopneumothorax, or some other degree of blood loss. And last time I looked at the literature, closed chest cardiac massage doesn't solve any of those problems. And that's where I think we've got to bridge that gap between practice and evidence.
No, and I think and your point that you were alluding to in terms of does it distract us from other things? That's my biggest concern. Is it's hard to argue that if there's really nothing else to do that you're causing more harm by that. And I realize that there's always a need to do something, particularly when you've got that critically ill patient. But when it distracts us from doing something else that is going to be valuable and that has some evidence base behind it, then it really does cause harm. And so we need to be sure something like this that we don't see any real clear benefit from is not keeping us from doing something that does have that clear benefit for our trauma patients.
You're absolutely right. And we've got this is where the difficult decision lies, because we also have lots of good data on the other end of that intervention spectrum where, from 2011 and before, you've got very busy trauma systems that are loading people into police cars and rapidly delivering them to level 1 trauma centers capable of definitive care. And that's where we as medical directors, as EMS clinicians, we've got to really take a realistic look at these particular protocols and see within our system, what can we do within the limits of our own geography, scope of practice, and training.
All right, so I do want to talk about TXA because there's been a lot of good literature that has come out over the last several years, and much of it, unlike so much in history, but just has focused on pre-hospital use. And in fact, some recent studies that have suggested, even though they are quote unquote negative studies, have really suggested and are used as a reason to put TXA out in the field. And there's a time element, there's resources and operational elements. What should we be doing? You have a lot of different systems. What are you doing with TXA? What should we be doing in the field? When should we be using it?
Wow. Yes is the answer, actually. Great question.
Okay, good. We can move on.
Okay, next. Good. Well, I know we don't tackle any controversial topics over here at EMRAP, but I think one guiding principle of TXA is that it has a mortality benefit. And this is where we have to kind of restructure how we do things. Like, for example, we have an IV protocol, and the IV protocol enables people to start IVs, but it doesn't allow them to flow anything through that. And so that protocol may be very helpful for assisting the paramedic, but it's not very helpful in getting the patient a therapy that they may need. And with respect to TXA, one could argue that if you are, let's say, if you're located a distance away from a trauma center, but within 3 hours of injury, there's a mortality benefit. And there are not many mortality benefits in EMS, right? I like to think that we do a great job, but you've got getting people to cardiac catheterization, you've got rapid defibrillation, you've got CPR. So TXA is one of those things that in your system, we really should rethink about scope of practice, because if you don't have blood, and if you have a situation in which you're located away from a trauma center, that could be one intervention that, let's say, for example, rural systems, or if you're located in a place 30 minutes outside of a trauma center, you have the potential for giving somebody a mortality benefit. So I think TXA has a place, and the easiest place to start for me is the patients in hemorrhagic shock. They've got that horrific shock index. They're a little bit away from a trauma center. You have an EMS system that is not giving blood. I think the risk-benefit synthesis clearly tips in the way of giving TXA. And we could also get into the weeds in terms of what do we do for traumatic brain injury, but I think there are very few medicines that deserve that level of consideration, because there's not much else we can do, right? If you're located apart from a trauma center and not being able to give blood, I think it represents a realistic option. There's a couple of studies that actually reference this fact. I know the CRASH 2 study is difficult because it didn't really look at urban trauma centers in the United States, and I know there's a lot of disagreement. But I think the variables we have to think about when how do we deal with this TXA synthesis is, how sick is the patient? Where are you in relationship to a trauma center? And what are the therapies that, can you provide? Because the reality is we're not going to know, right? We're not going to know in the field whether somebody is hyperfibrinolytic, right? They're breaking down all the clots and they truly need TXA. But TXA has a long track record. It's a relatively cheap medicine, speaking in terms of other interventions. And the side effects, I think it's pretty clear, are not as severe as one might think. So it kind of, for me, tips the scales. And I think air medical transport programs, patients that are dealing with these massively shocked patients, I think TXA probably represents a good therapeutic tool to consider. In full disclosure, I'm unsure whether you're going to benefit anybody if you're giving TXA within the city limits of a place that is close to 4 trauma centers. That's a different concern. Different question, rather.
No, and to your earlier point, this is where each EMS system, we really do need our EMS medical directors to sit down and look at their system and see when it makes sense. And knowing this data, I totally agree. This is a really exciting next step in trauma care in the right circumstances. And it's not for everybody and it's not for every situation, but it is potentially very beneficial for our trauma patients in the right setting, as you very, very well described.
We got to have a voice, Chris, because I think what happens is, and look, I would never argue with a trauma surgeon. I mean, I would, but you don't want to get your chest slapped or anything else like that. But their synthesis is very different. You're looking at the data that is not applied to EMS systems. And I think our job, much like our emergency physician colleagues, right, we are at the interface of injury and access. And there are a lot of challenges that go into injury access and then subsequent transport. So while it may not make sense looking at one study retrospectively to say, well, we're not likely to benefit anybody that come to this level 1 trauma center, very different question when you've got a lot of sick patients that may be in hemorrhagic shock. And I think that's where we can basically say, look, this is the data, this is the system, and here's where it makes sense within the confines of our operation.
No, absolutely. We have to have a voice, and actually that voice can be very powerful if we use it correctly.
I'm writing that down.
All right, so we wouldn't be, I think we would be remiss if we talked about pre-hospital trauma and didn't bring up a couple of the old stalwarts that were there when I was a resident way back when. And I'm going to, and a couple of things I do want to just touch on are
rotating tourniquets.
Tourniquets, certainly, needle decompression. And I'm going to talk about spinal motion restriction. We don't use the term immobilization anymore because nothing that we do truly immobilizes. But spinal motion restriction, and again, coming from a time, I age myself so often on these discussions, but coming at a time when the training was everybody got immobilized. If you were a trauma patient, could have been a trauma patient, might be a trauma patient in the future, you need to be immobilized. And that was a longboard and collar and all those things. And now we have more and more evidence that suggests that not only is there potentially some significant harm, but there may not be any benefit, particularly in certain situations. When should we be applying spinal motion restriction in our trauma patients? And I distinguish, penetrating and blunt to begin with. And then beyond that, what the spine board, the C-collar, they're torture devices. Are they ever helpful?
I don't know. I've been stealing backboards off of city Medicaid. Oh, I can't say that right now, but I've been trying to decrease the overall supply of these backboards. So, this is another thing where this has gotten a life of its own, and somebody can probably do the Google it search, but ever since 1940s and 50s, when there was that one naval article that talked about spinally immobilizing somebody, we have now created do you remember the KEDS? I remember being extracted out of simulated cars, spun around on backboards. And I think here's where we have to step back and say, what's the perspective? What are we doing? Number one, if the spinal injury is complete and transected, if it's occurred prior to immobilization, it's not very clear what immobilization is doing. Number two, as you mentioned, there are specific harms, pressure sores, lack of comfort. Let's not even mention what it does to airway anatomy. So my paramedics, a lot of times, not mine, because we don't make any mistakes in Baltimore City, but people will say, I can't see the airway, it's too anterior, or I can't open the mouth. Well, we don't have a good glottic opening view because the head is hyperextended, the cervical collar is on, restricting mouth opening. So when we talk about benefits and risks, I think the risks are way up here in terms of spinal immobilization. So in looking at the guidelines, because there's not a lot of good randomized controlled evidence, my take on this is if you have an unconscious patient that needs to be extricated, and you don't know about neurologic deficit, it may make sense, right? I think the backboard is first and foremost an extrication tool. It may have utility as a splint, but really in the absence of a focal neurologic deficit, and even then, I really struggle with the utility of a spine board because not for all of the things we've mentioned, some of the negative side effects, but also the lack of supporting evidence. So in general, I think it's safe to say that a collar and neutral position is probably adequate. Notice that nobody ever stays on a backboard in the hospital, right? That is pretty much well documented. I think neutral position and neutral alignment is something to keep in mind when we're transporting these trauma patients. I completely understand the need for spinal precautions, but I think extrication, trauma arrest, pelvic splinting maybe is the base for a pelvic splint. Those would be some of the utilities for a backboard. In terms of the cervical collar, I think what we're trying to do there is just maintain a neutral alignment of the spine. I think it also may have some utility in preventing migration of an endotracheal tube. But, I completely agree. The days of reflexive immobilization and coming up with new and more creative ways to apply bondage to our patients, I think, are gone. I think the indications are rapidly going away. The real question, which is not going to be resolved in this debate, though I hope we have many more discussions, is what do you do with the trauma patient with a neurologic deficit that you have to transport? That's unresolved. I think my own strategy is one of position of comfort, do no harm, alignment of the spine. So that's where I'm at with some of the spinal motion restriction.
Yeah, it certainly it continues to be an evolving topic, and we've essentially moved away from any restriction in penetrating trauma, including the collar. We still do use it, much to my chagrin, in blunt for the reasons that you mentioned. I think more for our own protection as opposed to truly patient protection, but more debate to come, I suspect, on that area. Ben, I really enjoyed talking about what, again, is such an incredibly important topic. Thank you for taking the time to join us here on Trauma Fundamentals. Awesome work on the EMS section of Corpendium as well, and yeah, really appreciate this great discussion.
Well, thank you for the opportunity. I look forward to more dialogue. This is a great avenue. I think education is so important and something all of us can get behind with. So thanks again for the opportunity. Hope to see you soon. Always a pleasure.
Talk soon, Ben.
All right. So next up, we have our second radiology rounds with Dr. Lee Myers. And I don't know about you, Ryan, but I feel pretty comfortable reading a chest x-ray, but when it comes to the CT scan, I can get a little lost. And sometimes, especially working in the community, when radiology reads don't come in quite as fast, I could be sitting on some pretty serious stuff that needs to be addressed, and I don't know it yet. So I think this segment is really helpful in kind of giving us some perspective and an algorithm of an approach to how to read a CT scan.
Hi, everyone. We are now really fortunate, and something that I am really excited about, that we're going to get a chance to talk about trauma radiology. And we have tracked down throughout the country Lee Myers, who is the director of the Emergency and Trauma Radiology Fellowship at USC LA County, where they obviously see plenty of trauma. And he's going to help us go through an approach to chest CTs and abdominal CTs. And this is probably one of the segments that I am most excited about. So super excited that you're here today, Lee.
Thank you, Ryan, for that kind introduction. It's great to be here.
So Lee, I love placing EJs, but sometimes these bounce back into trauma. Is it okay to do contrast studies through an EJ? Likewise with IOs or with ultrasounds that we put in the lower extremities. Are some of these limitations that we can't overcome when we're needing to do trauma scans?
Ryan, that's a great question. So what IV access can we use? Well, we can use anything that's rated for power injector, because we use power injectors for IV contrast injection, and we can use a power rated triple lumen, power rated port, or power PIC. A 20 gauge is preferred in the right upper extremity if you don't have a central line. And then as far as use of non-standard access will depend on the institution that you're practicing at. EJ access is typically not recommended as there is potential for airway and vascular compromise. IO access is also not recommended, mainly because there's not enough evidence for power injection use. There's potential for fat emboli when you're injecting in the IO. Non-power rated cordis should not be used as they can rupture or dislodge.
So sometimes there's reasons why you might not be able to give contrast to a patient. Maybe they have anaphylaxis. Maybe they don't have good access. Can we still get some of the scans we need to do in trauma and rule out the injuries that we need without IV contrast?
In trauma imaging, there are no absolute contraindications for use of IV contrast, but the risks versus benefits should always be weighed, particularly if a patient has known contrast allergies or acute renal failure. Non-enhanced CT can be performed, but there are severe limitations. If it is deemed necessary to image without IV contrast, we should understand those limitations. Vascular imaging will be non-diagnostic as well as contrast extravasation. All the mediastinal soft tissues, such as the vessels, the heart, are all the same density, and so this can hide things like cancer, enlarged lymph nodes, or even infection. It's also sometimes difficult to distinguish between atelectasis and infection without contrast.
Does the so-called phase of contrast matter when we're doing scans for trauma patients?
It's important to get the timing of the contrast correct, so important structures can be optimally interrogated. The chest should be done in an arterial phase of contrast enhancement. This helps in the diagnosis of vascular injury. Let me show you an example. Here is an image of the upper abdomen in the portal venous phase of contrast enhancement. I have it windowed to evaluate the vasculature, but what I'm not showing you is there's a chance fracture at this level as well. You may be able to make out subtle hypoattenuation within the aorta, but this is very difficult to pick up on. At my institution, we image through the spleen in the arterial phase, so we got a look at this on the arterial phase as well. This is a good case to show how arterial phase of contrast enhancement is necessary for vascular imaging.
Okay, so now that we've heard a little bit about imaging the chest, how do you look at a CT chest in the setting of trauma and rapidly figure out, are there serious injuries that I need to be aware of?
Radiologists have a specific search pattern when evaluating any type of scan or image. In trauma, I start every CT chest the same way, which is an abbreviated search pattern to identify potentially life-threatening injuries quickly, so they can be acted upon in a timely manner. I like to refer to this as a primary imaging survey, which is performed when we are at the scanner reviewing the images in real time. Instead of looking at each structure, I look for specific injuries.
What are the specific injuries that you evaluated in the primary imaging survey?
I look for injuries that cause blood loss, loss of oxygenation of blood, severe decreased blood return to the heart and lungs, or injuries that cause significant morbidity. The first thing I look for is mediastinal hematoma, and then I look for each of these key injuries, which are aortic and branch vessel injury, pericardial effusion, hemo or pneumothorax, lung injury, anatomic flail chest, and spinal injury.
Why would you look for mediastinal hematoma first and foremost? And what is life-threatening about a mediastinal hematoma?
Although mediastinal hematoma is typically a nonspecific finding, it signifies a severe injury to the chest. This not only increases my index of suspicion for injuries to the aorta, major vessels, and spine, but also draws my attention to these structures immediately. It acts as a guide to the region that is injured. Let me show you an example or some examples of mediastinal hematoma. Here we have some examples of mediastinal hematoma depicted by the yellow arrows. We can see on the first image the mediastinal hematoma is small, but there's a pseudoaneurysm and intramural hematoma, depicted by the blue and green arrows. The second image shows subtle compression fractures with a posterior mediastinal hematoma. The images on the right are of the same patient with superior mediastinal hematoma, which is an extension from a carotid artery injury depicted by the blue arrow.
So can you show a case of a mediastinal hematoma that you identified in the primary imaging survey that led to a change in management?
This patient was brought in by ambulance after an MVC. The left image depicts a large mediastinal hemorrhage and a left hemothorax. The middle image shows these areas of hypoattenuation within the aorta, which can be difficult to interpret on the axial images alone. The sagittal image demonstrates the injury much better. At first glance, when reviewing the sagittal images, you may be predominantly looking at the linear hypodensities shown by the green arrows. Although intimomedial flaps and dissection can have similar appearance, this is not an aortic dissection. When evaluating the aorta, typically the aorta will be roughly the same size with tapering larger or smaller depending on the part of the aorta we are reviewing. So I look for an abrupt caliber change first. On the sagittal image, the orange arrows show the normal caliber of the aorta, with the green arrows showing the abrupt enlargement of the contrast column. Once I see an injury that causes external contour deformity of the contrast column, then I know we are dealing with either a pseudoaneurysm or an aortic transection. Pseudoaneurysms typically have a small neck with an outpouching of contrast, while transections may have an appearance of circumferential disruption, like in this case. So to answer your question, the mediastinal hematoma led to the detection of aortic transection, and vascular surgery was immediately consulted.
When looking for aortic injuries during that primary imaging survey, are you looking for every single type of aortic injury?
During my primary imaging survey, I look specifically for aortic transection, pseudoaneurysm, and type A dissection or intramural hematoma. These are injuries that may need surgical intervention soon. Other injuries I will evaluate at the PACS workstation, as they are optimized for better resolution and have better windowing capabilities. Here we have a small outpouching of contrast from the aorta, which is the classic appearance of a pseudoaneurysm. And of course, not all aortic injuries that need repair will be done urgently. This pseudoaneurysm was repaired 3 weeks after the initial injury. Here's a case of intramural hematoma that extends the entire length of the thoracic aorta. Intramural hematomas, as well as dissections, involve the media, which make the intramural hematoma appear encapsulated by an invisible casing.
So I was kind of taught a very stepwise systematic approach to looking at CTs, and wouldn't it be faster and more efficient for me to use that standard CT approach?
Here's a good case that embodies how the primary imaging survey can be used to expedite management. Here we have an axial and sagittal CT. Of the 2,500 images of the PAN scan, these were the only 2 images that showed this injury. This is a cone-down view of the injury. I interpret the injury as contrast extravasation from the subclavian artery, and the patient was taken directly to the OR for repair. Here I have left on the timestamp of the CT and copied the dictated timestamp as well. This was the time that the PGY5 radiology resident dictated the study. This patient had endured many injuries, and reviewing and interpreting polytrauma can take a lot of time. Of all the injuries that the patient had, the subclavian artery injury was the only one that needed urgent OR intervention. Here are the intraoperative images. I had received a call from the ACS trauma fellow letting me know what they found in the OR, and this call came before the report had even been dictated to me.
So sometimes we pick up on pericardial effusions. How do you know if that's a traumatic injury or maybe something that was there prior to their injury?
Pericardial effusions are important to recognize in trauma not only because they can lead to cardiac tamponade, but are linked with cardiac injury. The best way to determine if a pericardial effusion is traumatic is by checking the density of the fluid. This can help exclude simple effusions. In this case, we see that there is a moderate effusion layering along the inferior portion of the heart. This looks like blood, so we can check the density of the fluid using Hounsfield units. Here we see the density of the fluid is 47 Hounsfield units, which is compatible with hemopericardium. Other sources can cause a complex pericardial effusion such as infection, lupus pericarditis, and even malignant effusions. Next steps for this patient are troponin levels, EKG if not already performed, and echocardiogram. Pneumopericardium can also occur in both penetrating and blunt trauma. In this case, it was a stab injury to the chest, and the arrows show pericardial defect. We can also see associated pneumomediastinum.
Is there such a thing as a tension pneumopericardium?
Yes, you can have tension pneumopericardium, as we see here in this case. We can see ballooning of the pericardium and compression of the heart, which can lead to tamponade physiology. Another key injury to identify is a hemothorax. The pleural of space can expand quickly with blood and lead to hypovolemia and hypotension. This image shows the classic hemothorax with layering blood products.
So hemothorax is something that we commonly see on the CT scans or on the x-rays. Is there something specific that we need to be evaluating and taking into account when looking at hemothorax on a CT?
After identifying a hemothorax, I look for specific causes. In this case, there's contrast extravasation from an intercostal artery injury. These may need IR embolization or surgical treatment. The best way to find these injuries are looking for streaks of contrast or layering contrast within the pleural space. We also don't want to confuse an extrapleural hematoma for a hemothorax. This is a case of a large extrapleural hematoma, which looks a lot like a pleural effusion. The way to make the distinction is seeing a subtle fat plane noted by the yellow arrows. If you look closely at the posterior thorax on the sagittal images, we see a linear area of hyperdensity. It resembles a vessel. This is contrast extravasation from an intercostal artery. The next key injury I look for is a pneumothorax. Although lung windows are going to show the pneumothorax, I typically see a tension component first on the mediastinal windows. If you look at the right ventricle, you can see that it is flattened and the heart is shifted to the left. On the lung windows, the large pneumothorax is obvious, but what may not be as obvious is evaluating the anterior junction line depicted by the green arrow. The anterior junction line is formed by the opposition of the visceral and parietal pleura with intervening fat. This structure should be midline, as we see on the image on the right of a different patient. The combination of these findings should be considered a tension pneumothorax, at least radiologically.
So how do you distinguish between different lung injury patterns?
Pulmonary contusions are the most common lung injury, which is caused by compression or shearing forces against the chest wall, causing injury to capillaries leading to hemorrhage into the interstitium and alveoli. Contusions can show up on CT as ground glass opacity seen on the left or consolidation seen on the right. It's important to remember that lung contusions are typically peripherally located and can cross fissures, while aspiration is generally more centrally located and does not cross fissures. Lung lacerations are tears within lung parenchyma, and due to elastic recoil of the lung tissue, lacerations will be oval in appearance. Like the one we see here, lacerations can be filled with gas or fluid. The vast majority of lung lacerations will have associated lung contusion. This is depicted by the green arrow. Lung lacerations can have varying sizes, as we see in this patient with multiple lacerations. The lung laceration in the left lung shows an air fluid level. This patient also has a right tension pneumothorax. During the primary imaging survey, it's also important to make sure that the chest tubes are properly placed. We can see that the right chest tube is kinked and terminating in the right lateral chest wall. The last thing I review on primary imaging survey is spinal injury, and specifically look for unstable injuries, especially as the patient hasn't been moved off the scanner at this time.
So at different shops, I often encounter some confusion when I'm ordering spinal recons. And when I order this, is this a different imaging modality? Are they just reformatting differently? How do I need to order them properly or instruct the radiologist what I'm looking for?
Spinal reconstructions can be requested as long as the data still exists on the scanner. Image data stays on the scanner for 24 to 72 hours depending on the scanner. Getting reconstruction should be as easy as talking to your radiologist.
And if I am concerned about, say, a lumbar fracture, how much am I losing if I just order an abdominal pelvis CT versus an actual CT of the lumbar spine?
That is a great question. And imaging should be based on mechanism of injury. Dedicated spinal imaging uses less radiation, has better resolution, and no contrast administration when compared to the CT chest or abdomen pelvis. That being said, depending on your institution's trauma protocol, spinal imaging of the chest and abdomen and pelvis are adequate to diagnose spinal injuries.
So I think we all know that it's difficult to appreciate spinal cord injuries on the CT, but are there other injuries that are hard to see on CT that we require additional imaging, say like an MRI, to better define?
CT will be sufficient to evaluate all unstable injuries. Ligamentous injuries can be difficult to detect on CT, but secondary signs such as widening of the joints and soft tissue swelling can be helpful in diagnosing injury. CT and MRI are complementary in many ways. CT is great at evaluating fractures and fracture patterns, while MRI can help with subtle fractures, bone contusions, or soft tissue injury.
So pediatric patients always pose a challenge. And what are the risks of radiation exposure in our pediatric patients? And are there specific scans that are more dangerous?
Although all patients should undergo a risk versus benefit analysis for imaging, just like prescribing medications to a patient, pediatric imaging gets the most attention regarding ionizing radiation, as it should. The principle of ALARA should be used in all patient populations, which states using the least amount of ionizing radiation needed to achieve the desired need for imaging. Pediatric imaging is of particular interest because the difference in tissue radiosensitivity between the pediatric and adult population. Tissues that are growing and developing are more radiosensitive than others. When we're discussing radiation risks, we are really talking about development of cancer due to ionizing radiation. The most common cancers that develop from radiation exposure is leukemia, breast cancer, thyroid cancer, and sarcoma. There are non-oncologic manifestations of radiation as well, such as radiation-induced cataracts. In summary, we talked about IV access and what we should use, the reasons for using contrast in the arterial phase for chest imaging. I took you through the primary imaging survey of the chest and talked about radiation exposure in the pediatric trauma patient. Thank you.
All right, that was awesome. We feel so lucky to have Lee Myers joining us to answer these questions, which I've had for a long time, and fantastic to get that information and try to utilize it. So you guys were coming up on lunch. That's going to be up next. I thought before we did that, maybe we'll ask any little pearls or wisdom that you picked up from this morning that you really particularly dug, Britt?
Yeah, I mean, I think nerve blocks and just like controlling patients' pain in the ER is so important. I feel really comfortable with the femoral nerve block, but to be honest, the serratus has always kind of intimidated me, and now I'm really excited after Arun's talk to get out there and use it a lot more.
You are gonna love it.
I'm super excited. Well, Ryan, what was captivating to you this session?
I don't know, there's so much good stuff. I love the content, and I think, hearing Jesse tell us about gunshot wounds and sterility, because I think that's one of the kind of almost myths that's out there.
Right.
And so,
like if it's hot, it should be sterile, right?
Right, it just sterilizes itself.
Burns it. Yeah.
So I thought that was pretty interesting. Chris, what you had some thoughts on this morning as well?
So lots of thoughts and so many great things to take away from today. I love watching. I've seen all of these talks already, and I still learn something new every time I watch them. So thank you, everybody, for those presentations. I teach an old dog new tricks, and I'm a perfect example of that. Every one of these talks has done that. I will take my point as one of the questions that came off the chat. They asked, what about the role of severe anemia in reading head CTs? So I texted Andy Perrin about that, and he said, I hear there's a rumor out there about that, but as near as I can tell, that's really not a thing, and you can still read head bleeds on a head CT, even in cases of severe anemia. So it does appear that, although there is that thought out there, that it doesn't significantly impact your ability to read a head CT. So lots of great points and a good now opportunity to take a little break. Let's head to lunch. All right. Well, welcome back, everybody. I hope you had a chance to take a little bit of a break because we're going to delve right back into it. And next up, we've got Vic Babarda talking about Reboa. So Vic is one of my truly favorite people. We both trained back in Denver a number of years ago. He went on to become a far more interesting person than me. He's done now through the military 4 tours of duty in Iraq, Afghanistan, Syria, and has had just some amazing experience. And he's going to talk about Reboa. And this is resuscitative endovascular balloon occlusion of the aorta, something that I'm really excited about. And Mike and Sanjay are going to go into some of the data on this later. I fully recognize that the data doesn't support my degree of excitement about Reboa, but Vic's going to tell us about his experience with this and where we might see some increased use of this through our in care of our trauma patients. So Vic, what do we need to know about Reboa?
My name is Vic Babarda, and I want to share with you some lessons we have around Reboa, where we are now and where we're going. So I am at the University of Colorado. I'm a professor of emergency medicine and toxicology. I'm also the vice chair of strategy and growth here. And I also direct the Center for Combat Research, which is a campus-wide center focused on creating the solutions for the DoD's toughest problems through innovation and research. I also spent about 14 years active duty with several combat deployments, and I'm also currently now in the Air Force Reserves in a colonel's position with the Office of the Chief Scientist at the 59th Medical Wing. So we'll cover 4 areas today. I'll talk about Reboa, what it is, and where it came from. Then I'll talk about what the clinical data is now. There's lots of preclinical data, but I'll talk about the human studies that have been published. And then I'll share with you a little bit of where some future aspects are, pre-hospital care, new developments in the concept as well, and wrap it up from there. So when you look at non-compressible torso hemorrhage, from a combat perspective, it's the number one salvageable cause of death. Across all of trauma, both military and civilian, there's really no good therapies we have for it. There's a thoracotomy, ED thoracotomy, which we do quite often for thoracoabdominal hemorrhage. There's blood transfusion, which is non-surgical or just other non-surgical therapies to resuscitate the patient. And then there's surgery, which can be done, but it takes some time to get to the operating room to do that. From that came this idea of Reboa, and this actually came out of the Vietnam War, that we've just recently heard about this through the conflicts in Afghanistan and Iraq. 1954, Colonel Hughes published this paper around using a balloon in the aorta to obstruct bleeding after trauma, and did that in patients and was successful, but it never really picked up steam. And it never picked up steam again until just recently, probably about 10 to 12 years ago, during the conflicts in Iraq and Afghanistan. At that time, Dr. Rasmussen, trauma surgeon who I deployed with, I was active duty about 14 years, still in the reserves, and had 4 combat deployments. He came up with this concept idea that is named now as Reboa, resuscitative endovascular balloon occlusion of the aorta for hemorrhagic shock. This is one of his earliest papers looking at using a coda balloon as an example, and then what morphed into what is now called Reboa, or even ER Reboa by the company that sells it now. This was designed through the Air Force and studied heavily in the military and preclinical studies, for example, animal studies. So just to give you an example of what this looks like, if you haven't seen this before, but maybe you've heard about it. So it's a balloon that goes in the aorta, goes in through typically the femoral access. This example of the ER Reboa, one of the earlier versions of it, is a modified version out now. And this image shows how that balloon goes up. There's several spots you can put it in, zone 1, 2, or 3, depending on where the injury is at. Here you can see the 3 different zones people talk about when they talk about putting this balloon in someone's aorta. Zone 1, which is high in the aorta. Zone 2, which is less commonly used, and I'll talk about that. And Zone 3, which is usually used for pelvic hemorrhage. In through either one of the femoral arteries, up into the aorta, and inflate the balloon. On the right, you'll see some examples that we've had from the lab x-rays of the top one is without the balloon inflated. The bottom one, as you can see, the balloon inflated in the aorta as well. So that's the concept. That's what REBOA is. If you haven't heard about it, you've seen it now. You've seen the balloon, kind of what it's used for, mostly thoracoabdominal trauma. Let's talk about some of the clinical data. And I will say it's limited. There's been a lot of studies and preclinical studies that have been done in animals, large animals, that shows good efficacy. The human data has been quite limited, mostly retrospective or observational studies. So there are a number of reports, and there's about 15 or so that are out there, some small, some big, some case reports, and I'm sure there's going to be more published by the time you view this, but there's about 15 or so that are out there. And I won't go through each one. I'll pick a few to highlight so that you kind of know where the data is representing. So there's one U.S. study that's highly commented on by Dr. Moore in 2015, which was 2 centers, 24 cases, one of the earlier studies, and showed a higher ED survival after use. And that one's highly cited, mainly because it's one of the larger ones and it's in the U.S. and it's one of the earlier ones. In Japan, REBOA has been used quite often. It's used a little differently historically than it is in the U.S. This is one of the earlier studies in Japan, 24 cases as well. They did show that acute kidney injury and limb ischemia were a risk. And then they had a large study, one of the largest actually, 452 cases, mostly blunt trauma, which is important to understand. They found that the sicker patients got it and they had lower survival. So there are some differences there between U.S. and Japan. So one, it's mostly blunt trauma. Two, folks feel that the patients got it later in their course when they may have not survived anyway, and that may contribute to the lower survival. Also, their balloon time is longer than the U.S., where at that time, less than 1 hour was acceptable in the U.S., where in Japan they were having it for a longer time. It's not clearly described, but for longer times than the U.S. And also it's used mostly by emergency physicians there at the time, less so much only by surgeons in Japan. Now, there have been some recent studies as well, and these are the two that are referenced. One is in JAMA Surgery in 2019. It's from the American College of Surgeons data, Q-tip, and it showed an increased mortality for REBOA use. But there are some limitations in that data set, to be sure, and they've been published. Those critiques have been published. One that was sort of 2015 practices, and by nature of the data, there's some details lacking. How long was a balloon up for? Who was doing it? Those types of things. But this study, is highly commented on as potentially a reason not to use it. But I think most folks, experts in the field, feel that there's more data to be collected. This was another study that came out of Australia, and it was more on feasibility. And what they represented, this is 2020 by Fitzgerald. So they actually put a big program in place, which I'll talk about pre-education on who should use it, training the providers, resource allocation to have 24-hour availability of teams to put it in. What they found from an implementation feasibility standpoint is that only 2 of 4,300 cases got it and neither one lived. Their take home was that there's a small subset of cases that actually need it, and even in those cases, they didn't live, and is it worth the effort? Now, this just published last year, 2020, so there's more data information to come out and more discussion on how to improve resource allocation and pre-education and education and skill sustainment. What we've all asked for is a randomized trial. And so ones I've shared with you, and there's many others that are case series or observational studies. This is the randomized trial that's being enrolled now. I've taken this from the website and the links at the bottom. This is from the UK REBOA trial. They're looking to collect 120 patients over several sites. They're at about 66 patients when I last took this image. And so they're about halfway through. I think this will have a lot of evidence for us about how effective REBOA is in a randomized trial, which is what the audience and the experts are asking for right now. Now, with those trials of efficacy, there's always some concerns of side effects. And so these adverse effects have been reported. Some of these are specifically called out in some of these citations, and some are just concerns that people have about the REBOA. So in one of the largest studies, there's about 4 to 5% of cases have some adverse effect that's been reported. Some concerns are it takes too much time getting access. So while you're putting the catheter in, they're missing on making sure the team is coordinated to get blood or the right teams in place. Other concerns about vessel injury, been mitigated over time by a small catheter, but there is a concern. Overinflation by the balloon as well. That could rupture the aorta or cause damage. After the balloon is taken down, there's concern of cardiovascular collapse or hypotension after you take it down if you're not in the right setting and when you deflate it. Also, reperfusion injury, as that blood it's been sort of held back for some time or reduced circulation. Now you have what's well known after trauma is reperfusion injury that can cause some damage, and lower limb, spine, organ ischemia, some of which has been reported, like kidney injury, and some of which is a concern, especially in the lower extremities. In addition to the side effects or adverse effects of Reboa, there's some indications we know that aren't helpful. So one, we know it's not useful for pericardial tamponade or pneumothorax. We know it can increase upper extremity hemorrhage. So if you have someone who's hemorrhaging from an arm, you'd want to reconsider doing Reboa or have some balance of tourniquet and hemorrhage control. And it does increase blood pressure above the balloon as well. So that goes up significantly. That may be important for other vessel injuries or brain injury. Now, to put this all together, this joint statement came out. This is actually a 2019 joint statement, and this is a revision from a 2018 statement. I'll tell you the difference. But it's the American College of Surgeons, the American College of Emergency Physicians, and two pre-hospital focused organizations, the most reputable in the field. And it's important because there's a lot of conversation around Reboa for pre-hospital. So when this joint statement came out in 2018, it was revised. They felt that the groups needed some more input from different organizations, in particular ones that were not surgically focused. So this new joint statement that came out in 2019, citations at the bottom by Dr. Bulger and team, both military and civilian. In this newer one, it says, one, they included more emergency medicine and EMS or pre-hospital input into this. They focus on competency over this, of training and skill sustainment over specialty, so not just surgeons, and over several courses, not just one course, but several courses and probably future courses that really address competency of this procedure. In addition, this 2019 statement really focused again on competency and trained physicians, folks who are trained, whether critical care, emergency medicine, or vascular surgeon or trauma surgery, with having some surgeon either nearby or in coordination of care for this, not physically nearby always, but nearby, and it can help manage the patient after this balloon's put up because it's a time-limited matter. You can't put this balloon up for very long. They did address areas that are extremely rare, and they said interfacility transport, so from one hospital, smaller trauma center, to a bigger one, when to use it, and if you need to, and the time is short, you can, and then pre-hospital use, military and civilian, for those folks who have the competency and training to do it and have sustainment of skills. There are roles in military civilian settings for that. It does emphasize that this is for hemorrhagic shock and not traumatic arrest. That may be too late. And so folks who are victims who are have hypotension, that's who you give it to. If they're already in cardiac arrest, a traumatic cardiac arrest may not be valuable. Emphasizes bleeding below the diaphragm, so pelvic, junctional, and potentially even lower extremity bleeding, but not thoracic hemorrhage. Then again, not for thoracic hemorrhage, not for pericardial tamponade, and they actually focus a lot on the military and the specific use cases for them, and I'll talk about some of those exact cases. And their pre-hospital physicians, medics, and providers are a little different than our civilian ones, and they actually may have a broader use and scope for it than civilians. In addition, that statement, they talk about balloon location and times, and we talk about zone 1, zone 3 in general. So zone 1 is effective for abdominal hemorrhage and retroperitoneal bleed. They recommend in this statement for really less than 15 minutes of balloon time, really no more than 30 minutes. The data is not concrete on this, so they give that range. And for pelvic hemorrhage, zone 3, so the balloon's down in a lower space, as you can see in the diagram on the right, for under 30 minutes, but really no more than 60 minutes, but ideally less than 30 minutes there as well. So that joint statement is very helpful. We'll summarize the state-of-the-art of data in there, and I'll add some other color and other studies and data to it as well. But that is the state-of-the-art of where Reboa fits in our community and our systems of care. One thing's important to know for this audience is that emergency physician use is going to be high. And in fact, it's important to get that balloon in early in care, within minutes, within a half an hour, 15 minutes of this. So their involvement in the use, deployment, the training is important. They will be a big user of this. Obviously, if they get into the OR, it's used quite often there as well. It's used in the United States in the emergency department. In Japan, it's actually used quite often. So they're an important opportunity and player. And we also talk about some of the pre-hospital providers on the civilian and military side as well. The training is key, and skill sustainment is key for emergency physicians or surgeons or medics. So there's a couple of courses out there, the Baltimore course called BEST, E-STARS, which is a military one, and I'm sure future courses or ones I'm not aware of are out there as well. But it is important that those courses are well validated and really train the providers up to use this procedure safely and the right indications. And those indications are changing as well. This is a good example from the UK. We talked about the UK Reboa trial. They actually use Reboa in the field with physicians. This is shared with me by Dr. Jim Manning, who spent some time with the UK with the Royal London Hospital. And they actually had one of many cases where they had the Reboa in the ED trauma bay, and they're able to take it out in this vehicle, which is their trauma team vehicle, out to the scene. And actually, they've used it for a Zone 3 patient who had a pelvic crush injury that they've reported before in the media, but other cases as well. So this is another example of pre-hospital use, in this case, by emergency physicians and their teams in the UK. And the military is a special use case for this. Again, I spent many times in the military, and we've used this Reboa or a similar device early on in Iraq and Afghanistan. Dr. Rasmussen, Colonel Rasmussen, is the one who helped devise this with his teams there as well. So it's been used by special operations units currently in different ways and reported in the medical literature. And the special operations units have medics that are specially trained for many things, including the ability to do this. Our en-route care teams as well, who are trained to provide care while being transported, both on the ground in helicopters or during flight. And there's many cases of them using them and casualties being saved by either a physician or a senior advanced medic. So that's one report. This is probably the largest one and discussed a lot in the literature. Dr. Northern, but there's many groups who published this, including Dr. Reagan Lyon, who's a military emergency physician. They actually used 20 Reboas in a mass casualty event at 100% survival. These pictures are from that paper that I've just cited there. And in there, they actually recommended sort of proactive use, meaning cannulating the artery even before they're ready to get the balloon in those cases. And they felt that was important lessons learned after action report of how in the military they used Reboa. Now, there are some innovations in this. It's not a balloon up and done. Many folks like to refer to this, and I believe this, it's more of a concept, not an object. So there's different ways to look at it. So we could modify the ER Reboa or other teacher devices in a way that's smaller bore or easier to place and that type of thing that may not require wire, which the one that's available does not. But there's also other ways to think about occlusion of the aorta to stop bleeding in a non-invasive or less invasive way. So one option is intermittent Reboa, where you blow the balloon up and then deflate it and blow it up. And that may actually allow flow and reduce the issue of reperfusion injury and organ ischemia. Another one is partial Reboa, where the balloon's up and then it's reduced a little bit to keep the flow going, but still maintain the blood pressure. And then even a more different concept called aortic flow manipulation, where it's not just about putting a balloon up, but actually manipulating the flow. And sure, there are others, ways to mitigate that involving some AI as well to know when to bring it up or down based on other parameters. So there's more innovation around this for sure, ways to try and improve how we use the concept, not the object of Reboa. And other folks and companies are working on it. And to sort of summarize some of this, the next couple of slides just kind of want to kind of pull stuff together and about the data and kind of where we're going with the concept. So one, it's changing. And I think it's not even fair to use data from 5 years ago. It's not a fair comparison. The way we use it 5 or 6 years ago is very different than the way we look at it now and the innovation on that device and concept now. So it's changing and modifying. And if you look at it, putting a balloon in anyone, whether it's for an MI or stroke or an aneurysm, it's challenging, right? You got to have the right patient. You got to know the right time to inflation. Think of stroke or heart attacks, and inflation duration. So how long is it up? And that matters for not just for REBOA, for any time we put a balloon in somebody and blow it up in a vessel. So it's important we learn that over time with nice, rigorous data collected in a prospective manner. And also the care is evolving as well. So we're getting more experience on how it's used when you roll it out to a big system, how systems of care matter, how training can be improved and sustainment, not just initial training, but sustainment of training, how we can get a better device, smaller, 7 French, but maybe smaller than that or easier to put in. Select patients, who we put in, and who do we know it doesn't work for, and then ranging of technology. So, devices now you can monitor the aortic pressure. We could potentially even infuse drugs or resuscitation fluids in that same catheter as well, potentially actually saving time versus spending time putting the catheter in. So that care is evolving, it's changing, so it's not one single time point. It's going to get different and hopefully better over the coming years. If I were to summarize some of the data that I just shared with you, a couple things would highlight, and this is summarized including in uptodate.com, where Dr. Cannon is a colleague of mine. We deployed together, summarizes the REBOA data, but also Dr. Borger's summary joint statement as well, with several authors on it. There's no really high quality data supporting REBOA at this time. It's all retrospective in case report and animal data. Hopefully, we're going to see a randomized controlled trial here soon, if not one, but a several, and that there may be a bias toward positive studies being reported at this time as we see more data come out on clinical use in patients. There is benefit in pelvic trauma patients, and maybe an expansion of benefit as well to OBGYN, uterine hemorrhage. It's not for pericardial tamponade, not for thoracic hemorrhage. And that the data has shown that most patients actually will do quite well with resuscitation, and they may not need a balloon. So that goes back to finding the patients that need it and making sure the providers who put it in know how to do it and deal with any complications of it as well. Thank you so much for letting me share some valuable points around REBOA, where we are now, where we're going. Look forward to communicating offline with anybody about these questions. Happy to connect you with our combat center team at University of Colorado or others in the military who understand this procedure very well.
Fantastic. Do you like swag? I think you do, because I've been watching the chat and you've been looking at the jackets and you've been looking at the cups and all the stuff. People love swag. They love free stuff. Do you want some of it? Yes, you do. You know how to get it? I'm going to tell you. Follow EMRAP on Instagram at EMRAP Show, and we are randomly going to choose one person from that and give you a swag bag, a thing full of swag and the suches and stickers and the such. And now let's continue the show. So the next thing we're going to do here is really interesting. It's a global sort of emergency medicine panel of people from across the world, because the global burden of disease now is not infectious disease. It's actually trauma. So let's see what these experts from across the world have to say what's happening in their countries.
Hello, everybody. My name is Ryan Ernst, one of the EMRAP Go faculty, and today we're fortunate enough to be meeting with some of my colleagues from around the world and ask their experiences and opinions on trauma care. So from various spots, we have Dr. Lephok Dai, who is my friend in Ho Chi Minh City, Vietnam, and we'll allow him to introduce himself shortly. He is one of my favorite people because he is one of the only people in the world who can understand the very few phrases in Vietnamese that I know. So I thank him for that. Dr. Ben Wachira is joining us. He is in Nairobi, Kenya. Also a good colleague. We've worked together on training programs, and he is a complete adrenaline junkie. If he gets anywhere near a roller coaster park, he will go bonkers. So it's quite entertaining. And also Dr. Luis Aragon, who is a trauma surgeon down in Guatemala City, Guatemala, and has been instrumental in helping out with the new emergency medicine residency training program there, and has been really instrumental in bridging some of the traditional divides or gaps between surgery and emergency medicine. So let's just allow you to introduce yourself a little bit. Dr. Ben Wachiro, tell us a little bit about yourself.
All right. Thanks, Ryan, for the great intro. So I'm Ben Wachira. I'm an emergency physician based at the Aga Khan University Hospital in Nairobi, Kenya. So the Aga Khan University Hospital is a private academic hospital where I run the emergency medicine program. We currently have a postgraduate training program for doctors here at the hospital. I am the immediate past president of the African Federation for Emergency Medicine, but also currently the executive director of the Emergency Medicine Kenya Foundation, that's involved in looking at strengthening emergency care across Kenya. So in that arm, I'm involved in a lot of projects that we are working with the national government and county government to see how best to develop emergency care systems here in the country. Yes.
Awesome. And Dr. Dai, tell us a little bit about yourself.
My name is Dai. I'm from Ho Chi Minh City. I'm trained in Ho Chi Minh City for 2 grades of emergency medicine. In my hospital, we emergency medicine grade 1, grade 2. In the United States, we studied primary or advanced emergency medicine. So we trained in Ho Chi Minh City and work in Charoen Hospital, the biggest one in South Vietnam, who receive more than 120,000 patients a year. So it's so crowded and they're so busy ED in South Vietnam.
Yeah, Chorai is a very busy, very crowded, very high acuity place. It's and I think maybe half of your patients are trauma patients there. Dai, is that correct?
There's the study with more than 40%. The patient were trauma care. So I worked there for maybe 13 years, and I've met a lot of trauma care, maybe more than 40% of admitted patient.
Yeah, it's a pretty serious place. And then Dr. Aragon, tell us a little bit about yourself.
Thank you. Hi, everyone. My name is Luis Aragon. I'm a trauma surgeon in Guatemala. I work in the Trauma Hospital of Social Security System, CEIVAL. I am trauma surgeon. I am facilitator of emergency medicine program. And in my hospital, I am surgeon lecturer for Universidad Francisco Marroquín. Also, I am founder of Médicos en Libertad. This is an interdisciplinary group trying to improve healthcare system in Guatemala. And I work with a lot of different parties trying to improve our understanding of the system and figure out innovative ways to improve it. So thank you for being here on the invitation.
Yeah, this is a kind of a wealth of experience and broad experience here, which is exciting. Luis, we had talked earlier about some of the types of injuries that you see in Guatemala City. What makes up the kind of the majority of the traumatic injuries, or what type of things are you seeing and dealing with?
Yes, thank you. Well, more than 80% of all our patients are victims of motorcycle accidents. The rest are work-related injuries in my hospital, because my hospital is a social security hospital. So we attend formal laborers and formal workers. But the injuries are usually related with industrial machines, for example, textile industry, construction industry, intoxication with pesticides in agro industry, bites of snakes, for example, in that parts of the country and in that kind of industry. Interpersonal violence related to work, for example, police officers, soldiers, and private police guards are usually our patients. And of course, criminal acts of violence related with gangs and another form of criminal organization, because we are in a very problematic part of the city and the country. Although the majority of our patients have injuries caused by motor vehicle accidents,
and most of them have blunt or close trauma. Almost half of the severely injured patients have penetrating trauma secondary to gunshot wounds or stab wounds. So this is the outline of the kind of injuries and patients that we saw in my hospital.
Yeah, interesting. And I feel like motor vehicle accidents are kind of make up a majority of a lot of these places. Ben, you were telling me about the Twitter feed that shows all the motor vehicle accidents. You can maybe tell us about that. I looked at it briefly, and I never want to get in a car again. I'm terrified.
So I mean, I want to echo what Dr. Aragon was talking about. So, majority, even in our setting, motorcycle accidents are the biggest contributor to road traffic accidents in Kenya. And I think over the years, they've been quite a significant cause of road traffic crashes. So, at my facility, we probably don't see as many because we are more of a private academic hospital. But within the government settings, within the public healthcare system, motorcycle accidents the number one cause of road traffic crashes in Kenya. In fact, in Kenya, we call them borders, and majority of the public hospitals have a border ward. So a ward that's just dedicated to these guys who come in post an accident, crashing with their motorcycles on the road. And I think this has been attributed to the increased number of motorcycles in the roads purely because they're cheap, quick means of transport and can bypass traffic and have become the preferred mode of transport for many people across the country. So our Twitter feed is called Tipsy. So our Twitter feed, the idea behind the Twitter feed was because we have very bad data sets in terms of trauma in our country, especially road traffic crashes, we realize there's a lot of road traffic crashes that are captured on Twitter. So people driving along take a photos on Twitter, on Facebook. So we thought of creating a Twitter feed where we'd be able to collate all the accidents into one feed to be able to actually see if we can actually count the number of road traffic crashes that exist. So be able to identify the common black spot areas, be able to identify the victims of each road traffic crashes, be able to identify the time of day most of these crashes are happening. So we've been collecting data for the last 3 years or so, and so have quite some data and we have analyzed it to some extent and do want to go into a bit more depth analysis. Of course, understanding that the data is probably what can I say, biased because it's only based on data on people actually tweeting about this accident.
Yeah, it's interesting. It's amazing how much information can be gathered though from that. You just glance at it and there's just a ton of stuff going on, which is a little nerve-wracking. And Dr. Dai, it's kind of similar in Vietnam. There's a lot of motorbike crashes, and so in Vietnam they instituted a helmet law, and maybe talk a little bit about that.
Right. So in Vietnam, it's just like your country. We use a lot of motorcycle. We have a motorcycle everywhere. So you can see in Vietnam, we see that more than 80% of motorcycle travel in the street. As the road is no rule in Vietnam, so you just walk slowly or drive slowly, or you had hit by another motorcycle. So most of the trauma accident in Vietnam will be the motorcycle accident. And the day by day, the car is now more popular, and the car accident with the car and the car with the motorcycle is more popular. And with the helmet law, we used the helmet law in 1998, so it's more than 20 years, and it reduced the head trauma, the severe head trauma. So if the patient with the helmet on, they will reduce the mortality of the head trauma. And because my hospital is the largest hospital in South Vietnam, we have a very big center for the surgeon, for the brain surgeon. So most of the head trauma they will send to us, and we subdural, epidural, hematoma. We do it very quickly, and the day by day, and the most beside of the head trauma by the motor accident, we receive a lot of the fall. The patient go to the and go to somewhere high and they just point down and they have the back bend or something like the pressure, and we operate a lot of pressure like this. And just like you guys in the city, we have a lot of something like hit with. We don't use gun in Vietnam. We use knife and the stick. So most of the trauma come to Vietnam. It's just like this knife, just like in Korean, in Japan, there's no gun in Vietnam. So the wound would be like the open wound and something like that. That's in Vietnam like that. Thank you, friend.
Yeah. And Dai, is there when we were out there last, there were development of an ambulance system. Is there an organized ambulance pre-hospital system in Ho Chi Minh City, or how does it work?
It's very good one right now, Brian. We have a 115 system. So in not only in Ho Chi Minh City but all around Vietnam, we can dial 115 for very quick response. So for example, in Ho Chi Minh City, we have 25 districts and we have 25 center for 115. So if the patient have something like the tumor, they will call the nearest trauma center or 115 center, and they came very quickly in 5 or 10 minutes. And after that, we, like the PTC, primary trauma care, they will, the ABCD, and after that, they send to the nearest center. And each district, we have one center for 115 who care about the trauma and we care about the stroke. So if they are not able to do like the trauma, they will send to us, or they will send to some big hospital around Ho Chi Minh City. And they work very well today. Today, we don't just call 115 or 113 or 114. The three number for the ambulance, the three number for the police, and for the fire. So if the patient or the people don't remember anything, they just call 113 is okay, or 112, 114 is okay. So they just one call center only, and they will have them very quickly.
Yeah, excellent. And Ben, how about in Nairobi? Is there an organized ambulance system, and how does it work?
So unfortunately, we don't have a public organized system, ambulance system that is nationwide. What we have periodically in specific counties, we may have some ambulance system organized by the county, by the county health services. But again, so we don't have the central short code number like your 119 or 911. No, we don't have that. What we have is a lot of private ambulance services that provide these services are free, of course, but I know one of the things that we've been working on is to try and get centralized ambulance system that is funded either through the government or through other means like universal healthcare coverage. So for now, across majority of the country, if you are in an emergency, most of the time you'll either use public transport or use your own vehicle to get yourself or your own private means to get yourself to the hospital. So we do not have a reliable public ambulance system.
And Luis, we spoke earlier about some of the limitations of the ambulance system in Guatemala City. Tell us a little bit about that.
Yes. First of all, the majority of injuries of motor vehicle accidents occur inside the cities and towns. And that's a huge challenge because the traffic jam is heavy, incredibly heavy. So we conduct a little research a couple of years ago, and we discovered that the hospital system, the ambulance, and take from 1, 2, or even 4 hours to take the patient to the nearest hospital, to a good hospital, because we have this challenge of organizations, because we have these 3 major systems or 3 major hospitals. I mean, we have this system of public health system, we have social security system, and we have private system. So the private healthcare system are private hospitals and insurance companies. The social security system is for formal workers, and the public system is for the rest of the population. So the public system and the social security are the only systems with hospitals properly equipped to treat trauma patients. But the challenge is that the big hospitals are only inside Guatemala City. If the accident of the trauma occurs outside the city, the patient has this delay in the transportation to a proper hospital. In reality, we have this system of ambulances that are conducted by volunteers. So we have these companies of ambulance, but only for the small proportion of population with access to private services. Social Security is only for 17% of the population because only 17% are formal workers. And the volunteers ambulance system as for the rest of us. So we have this huge challenge in coordination, the attention, the medical care attention in the spot of the accident. We have this challenge of transportation that delay the medical care 2 to 4 hours. And we have this challenge in order to decide what is the hospital for this particular patient. Usually the paramedic is the person who decides to who hospital the patient is transported. So we have this challenge in my country.
Yeah, definitely. If you know, the goal is that golden hour, if they're sitting in traffic for 2 hours, that's a huge challenge. And then in Guatemala City, when, you know, we met because we were both working with the new EM residency. So there's no true formally trained emergency medicine docs in the country. So do most of the trauma patients, they come in, are they seen by surgeons or general practitioners? And then within and outside of the city, what level of training do those people have for trauma specific injuries?
Yes, usually the patients are treated first by general doctors, by generalists. The surgeons are available only in big hospitals. And of course, their primary job is inside operating room. So even if there is a surgeon in the hospital, usually the primary doctor is a generalist. And yet we don't have emergency doctors. We just began this emergency program a couple of years ago. And right now we have senior residents of emergency medicine. So I think this is a huge opportunity because the patients outside the big cities need good medical attention. And these emergency physicians could be the solution because, for example, a vascular surgeon is a huge challenge to try to bring a vascular surgeon to a regional hospital. But emergency physicians are with more training, with integrated training, and I believe in the future they will be this solution for the patients.
Yeah, fantastic. And Ben, you're kind of seeing a similar thing in Nairobi. There's not very many emergency medicine trained physicians. You may be one of the very few, if not the only one in the country. And so trauma patients are generally being seen by generalists or surgeons, or how does it break down in the hospitals?
So if you're lucky in the bigger hospitals and in private hospitals, then you will be seen by a general doctor, kind of a GP kind of practice. But more in the rural areas, you'll probably be seen first by a clinical officer, which is, I guess, equivalent to a physician assistant in your setting, though they work independently, or a nurse. So your first point of contact in majority of the rural hospitals may be a clinical officer or a nurse, but in the bigger facilities, in the big cities and in private, would be a general doctor. Now, unfortunately, majority of this, they do not have necessarily any additional training beyond just basic training, so may not have the additional specialist training to handle emergencies, to handle trauma care, and it's one of the things that's a big significant gap in our setting that we're trying to address.
You're addressing that in kind of multiple ways with the Emergency Medicine Kenya Foundation. I know there's a lot of training available to the clinical officers, to the nurses, as well as physicians. And then you developed the EM diploma program at Aga Khan.
Yeah, so the majority of which, because from our assessment, it would be hard to try and get everyone back to school to do an EM master's program or an EM postgraduate diploma program. So what we are trying to do is targeting specific facilities which handle bulk of the trauma patients and doing additional training for these healthcare providers working in the emergency departments to provide them with the knowledge and skills necessary to handle common emergencies, including trauma care. So that just upscaling them from the existing skills and knowledge. And of course, then on a bigger scale, looking at developing, we have the postgraduate training programs for doctors, nurses, clinical officers also. And down the line, hopefully we'll get a master's program going. But I think our biggest response to this right now is trying to target the already existing healthcare workers who already see these trauma patients and doing short courses for them to be able to upskill them to be able to handle emergencies and trauma patients much better.
Yeah. And Dr. Dai, kind of similar in Vietnam, emergency medicine has been recognized as a specialty, but the training programs are limited in availability. You've been instrumental in helping start the EM diploma program at Chiu Rai Hospital. What type of training are the people getting both at the major trauma center like Chiu Rai, but also out in the regional or provincial hospitals? Do they have much opportunity to get trauma-specific training?
Sure, in Vietnam, not only Vietnam, but some Southeast Asia or East Asia, the salary for EMS is so low. So most of the doctor don't want to do in like the EMS doctor because they travel a lot and they have no time for their family. So in Vietnam, we fit it with the generalist, but not like the very high one, but the generalist, just like the newbie or just like a good one, not very good one, just is acceptable one. So we train them. We train them with the trauma care, the primary trauma care like PTC. That means they just go into the scene and with help with the nurse, one doc and one nurse go into the scene and to elevate what happened and what did you do next. After that, they send the patient to the nearest hospital. It's better than they just in the scene of out of the hospital. They cannot do anything like just like test tube. No, they don't do it. They just stabilize them and send them to the nearest hospital. After that, in hospital we have a surgeon there, and we wait for the patient because they call first that okay, we have something like the CV trauma in the street, and we will send you in 20 minutes. After that, like in Chiu Rai, we receive the information and we prepare for surgeon already. But when we developing the system like this, we just need one generalist and one nurse. And in the rural one, they don't need the generalist too. They just two nurses, but one nurse is trained for trauma care because in rural one we don't have enough doctor in Vietnam. In rural in Vietnam, it's so poor. It's just like in Thailand, in Philippines, some Southeast Asia, so poor. So we just put in the ambulance two nurse. One nurse is just like the general nurse, so they can help for the senior nurse. They can help them to stabilize them. So if they have a trauma, put the seat collar on and bring them to the hospital. And if they have something like the shock situation, get the IV and send them to the hospital. That's all for today. We are building the new system that improving the salary or improving the healthcare or improving for the doctor who go to the EMS, because the doctor go to EMS, they travel a lot with the very small salary. They don't want. They just want to like the surgeon. They don't want to be. They want to be like some doctor work at hospital. That our problem today. But we have the training program for them. It's not very hard. It's just 2 or 3 days. As we send them to hospital in Chiu Rai, and we train them for 2 or 3 days. And after that, they can use that knowledge, the basic knowledge, into the scene and they make sure that the patient is okay, not harm them more, and bring them to the nearest hospital. In the nearest hospital, they will have, the doctor, the surgeon, or something like this, the specific one who care for, the better healthcare, like ATOS or something like thoracic, something like open chest, or something like, more than like operation very quickly. Just like in my hospital, we have UOR in ED. So if you have a chest up, we can operate open chest for 5 minutes. Just put them to the OR and the surgeon come, they just take it and they just suture the wound very quickly. But not all of the hospital in Vietnam can do it. Only the big one. So if you in the rural one, send to the bigger one and they stabilize first, and after that they send to another one. That we work like the French situation because we colonized by French before and after that United States. So our system was, the mix of France and United States. So in EMS just like American, but before that we used like the system of the French. That's what we call that. We do have a lot central, and we receive the patient. It's a French one, but the United States, just like 911, we have the ambulance go around. The ambulance go around. So we miss it. We miss it. And we just like Vietnamese ties. Thank you, Ren.
Yeah. And so, there's obviously, we've kind of talked about some of the various challenges to trauma care, and specifically in Ho Chi Minh City or in Vietnam. What do you think of all of these, challenges, the EMS system, proper training, availability of specialists or resources? If you had your wish, what do you think would make the biggest difference? How can we, help provide better trauma care in Vietnam?
I think if I have a power to change something, I will, like education and get education first. So now they recognize the emergency medicine already, but we need to, improve the knowledge of for the doctor and the nurse and the paramedic. We are building the paramedic system. So not only the doctor, the nurse, and but also the paramedic who come to the ambulance in the ED. And we have, like the something like the yearly, just like the continue CME to practice more about the emergency medicine. I think with this and with the recognition for the emergency medicine, the more people want to be emergency medicine doctor, and of course they must pay more for us. If you have well paid, you will go to emergency medicine very quickly. But if you don't have well paid, you are not paid enough for your life. 1 year, 2 year, 3 years, just and they left. When I was in the conference in China 3 years ago, they had just the same question in China, in Singapore, in something like Malaysia, something like that. They say that the emergency, doctor, ED doctor, is not well paid. So just working for 5, 6 days, 6 years. After that, they quit, and because emergency medicine need, I think that 3 or 4 years for practicing, learning and practice the day by day, and learning for the senior one, and how to practice with the severe trauma is this experience, because it's not right on the book, because when you see the trauma come and you see that you have bleeding a lot, can you see it and you use the ultrasound, you can use it. I think 4 years or 2 years will be good for one generalist to be emergency doctor, and with the training and just like CME in Vietnam, we have CME, and I wish that we have the training program like residency in the United States, with 3 years. With 3 years, everything will be good, but we are building it day by day.
Yeah, well, hopefully DIA will continue to work together and hopefully we can get a residency underway. But yeah, it's a similar, when emergency medicine was new in the United States, they faced a similar problem. The pay was low, the schedule was very difficult, the prestige was very low. And we're lucky now. I feel incredibly fortunate that, emergency medicine is well respected, in the United States. We have a decent schedule, we get decent pay. So we're lucky. And so hopefully we get there as well in Vietnam. Ben, kind of same question to you. If you could wave I know you've been working diligently, both in Kenya and kind of throughout the African continent to improve emergency care, but specifically for trauma care as well. Like, what would you like to see happen to improve trauma care in Nairobi or in Kenya?
I think from our end, access is the one thing that would potentially make a difference in trauma outcomes here in the country. So people being able to access an ambulance service and the ambulance service taking the patient to an appropriate hospital, because many a times also, people will leave an accident scene and go to a facility that potentially doesn't have the capacity to handle trauma cases. So a well-designated access system where patients can quickly be transferred between the scene of the incident to an appropriate facility, I think that would make a significant difference. And investing in an ambulance service that specifically, maybe if we were to start an EMS service that specifically handles or targets road traffic crashes, then a lot of patients would be saved, because we've had so many instances where patients actually just die on the road or on their way to the hospital purely because of the delays in accessing the patients, and also the patients trying to access an appropriate healthcare facility. So well-designated trauma centers and an appropriate ambulance services that's dedicated to road traffic accidents would make a significant difference, because once you get to hospital, then the other steps, of course, it's a whole chain in terms of survival, but I think just sorting out these first steps would go a long way in improving survival along for trauma cases. So majority of the patients in our setting do not do not get to hospital in time, or do not get to an appropriate healthcare facility that's able to even provide that emergency care or even provide that surgical care. So that's the first step that we potentially need to address.
Awesome. And Luis, how about in Guatemala City? If, of all of the challenges that we kind of talked about and the things that are available, how do you think we can best improve care for trauma patients?
I agree with Dr. Lai and Dr. Ben in order to consider that the most important thing to improve is the trauma training to probably all physicians, because our countries are highly violent and our countries have a lot of accidents and a lot of trauma. So virtually all physicians are exposed to treat these kind of patients. And that improvement would, in order to improve the patient's outcomes, because the first decisions have a huge impact in the destiny of that patient. This point is highly related with pre-hospital care. We need to improve our pre-hospital infrastructure or networks to increase the probability of the patients to receive the appropriate treatment in the appropriate time, because it's not the same thing that we make the best procedure out of time. And another thing I believe is critical is the enforcement of helmet use. At least in Guatemala, we have these laws to enforce the helmet use, but in reality, they don't work. So right now, I am working in a multidisciplinary university group, designing innovative ways to increase the use of helmets. We hope we can figure out how to apply behavioral design principles in order to reduce traumatic head injury, because in our context, severe head trauma probably are the most important cause of long-term consequences to the patient. Usually, trauma patients are younger patients that have a lot of living ahead of them, and they are economically active. So we need to really, really reduce the long-term consequences for them.
All right. Well, thanks, everyone. This has been a really fantastic discussion. I feel really fortunate to know all of you. I'm inspired by your work. I'm inspired working with you. It's super interesting to hear your different perspectives. So thanks a lot. Dai, thanks for joining us today.
Thank you. Thank you so much.
Yeah. And Ben, thanks again. It's great to see you.
Always a pleasure, Ryan.
All right. And Luis, again, thank you for all your continued work. And it's great to see you.
I really enjoyed the discussion. I think this conversation is highly valuable for all of us. And thank you for the invitation.
Yeah, you bet. All right. Take care, everybody. Goodbye.
All right. Thanks, Ryan. Bye.
Thanks, Ryan.
Bye-bye.
All right. Welcome back, everyone. So, global panel. That's just such a powerful panel for me, and I've worked with a lot of those guys, so thanks so much for joining us for that segment. We've had a lot of questions coming through on the chat. So I have our experts over here, and I thought we would go through a couple of those. One thing that came up with our nerve block segment was doing that femoral nerve block for a hip fracture, and then having ortho come down and say, we ruined their exam. Any thoughts on that, Chris, Ryan?
So, yeah, lots of thoughts on that. And first and foremost, my immediate impression is there's nothing that you do as emergency physicians that ruin things for ortho. Arun alluded to that earlier, and I completely agree. I think in some cases we do own a good exam before we do the block, and as long as we are doing that, there is no reason that you, from a patient-centered approach, that you wouldn't do these blocks. They really do work, and they are so much more comfortable than the other options that we have. That said, I think we do need to work this out with ortho, and I've been now in a couple of different institutions where we've needed to do this. I would say I don't have a magic answer for this, and by no means do I suggest this is going to work across the board. I think we need to be firm that we are going to do this and set a specific time period that within which, if they can get down and do their exam, maybe we can talk about saying we'll hold off for 10 or 15 minutes if they want to come down and do that exam. Although I still think, we always have to be patient-centered on this, and a miserable patient is not acceptable even for a short period of time. So I would suggest that we try to be as proactive as we can, sit down with our orthopedic colleagues, some of our other consultants where this may come up as well, and talk about how we can do this from a patient-centered standpoint, and knowing that there's nothing that you do that is ruining this for the orthopedic consult or any other consult. So I know this can be a tough issue, and I do believe that being proactive about this can help. In the end, we really do have to do what's right for our patient, and what is right for our patient is making their pain go away as best we can, and this is a good way to do it. I don't know, Ryan, do you have any better answers?
No, I think constant discussion, but I like Arun's approach where this is and like you were saying, this is the standard, this is what we should be doing, and then let other people adjust to what's appropriate patient care.
Yeah, I totally agree. I probably just kind of ask more for forgiveness and just do it. I think we all know how much these hip fractures increase morbidity and mortality for our patients. And like Chris said, we have to be patient-centered. We need to control their pain and do what's right for the patient. And if we document a good neuro exam, that probably means that it's a decent, good neuro exam. All right, another question that came up, this is all the way back from the vascular surgery consult interview, was about fistulas, AV fistulas for dialysis, bleeding, and how we manage that with tourniquets, or any tips and tricks to managing those really bad dialysis bleeds.
Yeah, Britt, that's a great question, and I think probably warrants almost a whole lecture on itself. But using tourniquets, I think, is still totally appropriate. It's bleeding, and you need to stop the bleeding. And if that's life-threatening bleeding, which certainly can happen from an AV fistula, appropriately managing that bleed needs to be your first priority. So, basic principles apply from tourniquets, applying it, as close to the wound as possible. And in this case, above and below, since you have this AV fistula. But I think sometimes we get really nervous about, these fistulas, and we don't want to mess them up, and we're always told to be cautious with them. But in this case, you would need to, just go ahead and be aggressive and treat it like you would any other like serious hemorrhage.
Before you get to the tourniquet, stick your finger on it. Yeah. That is the single best thing. Just put a finger right over the top of it and then talk about what you're going to do next. People so freak out of these because they literally can hit the ceiling and people just lose their minds. Like, just stick direct pressure right over the top of that puppy. Guess what? It stops. It's magic.
Yeah.
And I mean, I think the big concern too is that we're going to put this tourniquet up, we're going to hold pressure, we're going to cause a clot and a thrombosis in their very valuable fistula. But if they don't stop bleeding and bleed out, then that fistula isn't going to really matter anymore.
If no blood, their kidneys aren't going to work anyways.
Exactly.
Kind of like that question of, do I use a fistula if I'm dealing with cardiac arrest? And the answer is, well, the alternative really isn't good. In fact, it's far worse than dealing with a fistula that you now have to replace. So sure, the longer the tourniquet is on, the higher the risk for thrombosis. And so we want to get that off as soon as we can, but we have to stop that bleeding. And I completely agree with Mel. I think direct pressure actually works wonders in a lot of these situations, but every once in a while, it'll be that situation it won't work, and a tourniquet is absolutely appropriate in these settings.
And we do have a good section on stopping the bleeding, tourniquets with Dr. Goolsby tomorrow about midday, so make sure to check that out as well.
All right, so sorry to cut this Twix bit short, but we are got to move on to our next segment. So Ryan, what do we have coming up next?
Well, every now and then you get a boo-boo in your hoo-ha. And we have Dr. Steve Lai that's going to be here to tell us about this.
Hoo-ha?
In your hoo-ha.
No,
it happens.
We don't use that word.
Use your big boy words, Ryan.
And Dr. Lai even manages to make a genitourinary talk without making any pee-pee jokes, which shows that he is much more mature than the rest of us.
Hi, everybody. For the next 20 minutes, we'll be talking about urogenital trauma. We'll start at the top and work our way to the bottom, paying particular attention to the approach, challenges, and pitfalls of urogenital trauma. Urologic trauma is not rare. It includes injuries to the external genitalia, urethra, bladder, ureter, or kidneys, and is observed in approximately 10% of those suffering from abdominal trauma, with higher association in blunt versus penetrating mechanisms. First and foremost, it's important to keep perspective and prioritize life-threatening injuries first, as urogenital injuries are rarely immediately life-threatening. They can be impressive, confer a high morbidity, and are important to catch, but only after all other life-threatening injuries are managed first. Let's start at the top with renal trauma. The kidney is the most commonly injured GU organ. Children under 16 require a higher index of suspicion because of the relatively larger size of the kidney and scant perirenal fat. Gross hematuria is frequently observed in those with renal injuries. However, the degree of hematuria is not indicative of the grade of renal injury. For these patients, look for trauma to the flank, abdomen, or lower chest. Flank ecchymosis or tenderness, low posterior rib fractures, or lumbar transverse process fractures really key you into suspecting traumatic renal injuries. Injuries to the kidneys must be suspected whenever there's penetrating injury to the lower chest, abdomen, or pelvis. The diagnostic and treatment principles for penetrating renal injuries are similar to those for blunt injuries. Let's talk a little bit about diagnostics. When it comes to diagnosing traumatic renal injury, it comes with the caveat that hemodynamically unstable patients often require operative exploration. With that being said, FAST or ultrasound has relatively poor sensitivity when looking at renal parenchymal lacerations, vascular disruptions, or collecting system injuries. However, you could use ultrasound to quickly confirm the presence of bilateral kidneys in patients who are too unstable for further imaging and require immediate surgical intervention. For your stable patients, CT abdomen pelvis with IV contrast, including both an immediate and delayed phase if you can, is your diagnostic tool of choice. Follow-up CT imaging, usually after or at 48 hours, is required in patients with high-grade renal injuries because these injuries are prone to developing complications, such as urinomas or delayed hemorrhage. Also important is outpatient blood pressure measurements, which are necessary following high-grade renal trauma to ensure that there's no development of subsequent hypertension. So how do we characterize renal injuries? Renal injuries are generally characterized by the American Association for the Surgery of Trauma Renal Injury Scale. This ranges from a contusion, which might give you hematuria, but relatively normal urologic studies, all the way up to a grade 5 injury, which is a shattered and devascularized kidney. Ultimately, the management of renal injuries is driven by instability and injury grade. It's also worth noting that most injuries are lower grade, usually grades 1 through 3, and can be managed without operative or interventional repair. CT with active extravasation, pseudoaneurysms, or evidence of arteriovenous fistula, these are usually grades 4 or 5, should undergo renal angiogram really to evaluate for concurrent vascular injuries. Now, as we talked about, while most genital urinary injuries can safely undergo delayed repair once the patient has been stabilized and other injuries dealt with, renal pedicle injuries is the exception. Renal pedicle injuries can lead to life-threatening hemorrhage and renal ischemia, and this injury typically results from rapid deceleration, resulting in the kidney swinging violently on its vascular pedicle. This can then lead to thrombosis or complete detachment of the pedicle, and early surgical repair is needed. We'll continue moving down from the kidneys and take a look at ureteral injuries. Injury to the ureter is uncommon, but occurs more often after penetrating injuries. These are rare injuries overall. They constitute about 1% of all GU injuries, as the ureters are usually well protected in blunt trauma by the pelvis, psoas, and vertebrae. If the ureters are injured, they're typically not alone, and there's usually significant collateral and multi-system injury. There are 3 parts to the ureter. The abdominal portion spans from the ureteral-pelvic junction to the pelvic brim, the pelvic portion from the brim to the bladder, and a short intravesicular portion in the bladder wall. And the most common area in blunt trauma is the ureteral-pelvic junction due to rapid deceleration injury. Of note, children are also at greater risk for blunt ureteral injury due to shearing as their vertebral column is hyperextensible. A potential pitfall to look out for is that hematuria is not a consistent finding in ureteral injuries. Therefore, the absence of blood in the urine does not rule out an injury. Now, the workup of ureteral injuries include a contrast-enhanced CT abdomen pelvis with delayed imaging for stable patients. With acute presentations, you could see contrast extravasation, ipsilateral hydronephrosis, or delayed or absent filling of the ureter. Delayed presentations, often due to disrupted ureteral blood supply and subsequent necrosis, can show urinary ascites or urinoma, and these can then present clinically with flank pain, urinary incontinence, hematuria, or fever. Similar to renal trauma, there's 5 grades of ureteral injury, and surgical management really depends on the grade or severity, site of injury, associated injury, and when the injury is diagnosed, whether it's acute or delayed. If unstable, the patient may receive temporizing or diverting procedures, while surgical repair is eventually indicated for the majority of stable patients with ureteral injuries, and it's really dictated by the factors we just mentioned, as well as the location of the injury along the ureter. So moving on down, we'll talk about some highlights about bladder injuries. Bladder injuries are most commonly caused by blunt trauma, and it's seen in about 1 to 2% of abdominal trauma. Unlike ureteral injuries, the vast majority of bladder injuries are associated with gross hematuria. Importantly, bladder injuries are commonly associated with displaced, comminuted, or open book pelvic fractures. Just to put this in perspective, 60 to 90% of patients with bladder injuries have pelvic fractures, although only 30% of pelvic fractures will have some associated bladder injury, including relatively minor bladder contusions. With that, the takeaway is, if you have gross hematuria plus a pelvic fracture, this should equal bladder injury until proven otherwise. With bladder injuries, there's also the classic teaching and triad of hematuria, suprapubic pain, and inability to void. Keep an eye out for your higher risk patients, which will include your pregnant population and intoxicated patients with full bladders that suffer a blunt abdominal injury. Bladder injuries are broadly categorized as intraperitoneal injuries, which generally require surgical repair, and extraperitoneal injuries, which can be typically managed non-operatively. In contrast to blunt injuries, all penetrating injuries should be explored and repaired, and the ureter should probably be explored as well. Now keep in mind that standard CT scans with immediate and delayed contrast phases, typically obtained for trauma patients, cannot accurately diagnose bladder injuries. The passive distension of the bladder with the excreted contrast does not allow for really a sufficient volume or pressure to reliably diagnose bladder injuries, even with clamping the urinary catheter if you have one in. So the two most common imaging modalities for diagnosing bladder injuries are the CT cystogram or a plain film 2-view stress cystogram. These imaging modalities have equivalent sensitivities and specificities, about 95% and 100% respectively, for detecting and characterizing bladder injuries. As both CT cystogram and plain film cystogram require the use of a urinary catheter to instill contrast into the bladder prior to CT scan, urethral injury should be ruled out first by a retrograde urethrogram. However, because bladder injuries themselves are rarely life-threatening, we recommend performing CT cystograms as second-line imaging after all other life-threatening injuries have been detected and managed. Similar to the other injuries we've mentioned, bladder injuries are also graded on a 1 through 5 scale, but more practically categorized as a contusion or hematoma, an intraperitoneal rupture, or an extraperitoneal rupture. The bladder dome is intraperitoneal, and generally this is the weakest area of the bladder. Below this, the bladder is protected by the pubic symphysis, and it isn't really covered by the peritoneum. And this is important, and location matters as management differs. So if you have a bladder contusion, these tend to be mild. They don't really have contracture stravasation on any studies, and treatment is usually conservative with a Foley for a handful of days. If you have an intraperitoneal injury, these will exhibit contrast outlining loops of small bowel within the peritoneal cavity on your imaging, and these type of injuries are associated with blunt abdominal pelvic trauma, usually with a full and distended bladder. With intraperitoneal injuries, these generally require operative repair and are unlikely to heal spontaneously. On the other hand, if you have an extraperitoneal bladder injury, these typically have a sunburst or flame-shaped appearance on both CT and plain film cystography, which is really the contrast extravasating into the perivesicular tissue. These are usually associated with fractures of the superior and inferior pubic rami, and they tend to be more common than intraperitoneal injuries. Extraperitoneal injuries tend to be non-operative and typically respond well to urinary catheter drainage and close follow-up. We'll keep moving down to urethral injuries, and this constitutes about 4% of GU trauma. 65% of these are complete disruptions, while 35% are partial tears, and they're almost exclusively in males due to their anatomy. Urethral injuries are also graded on a 1 through 5 scale, but this includes everything from contusion to stretching to partial or complete disruption. Your physical exam might show blood at the urethral meatus, perineal or penile hematoma, a high-riding prostate, or inability to void. And these are really associated with pelvic fractures and straddle injuries that might be due to a direct blow to the perineum, which really compresses the urethra against the pubic symphysis. Now, it's important to perform a retrograde urethrogram prior to attempting catheterization in those patients with a high suspicion for urethral injury. But of course, as we talked about earlier, delay this until after the possibility of major pelvic bleeding has been excluded, as any contrast extravasation you might get from your retrograde urethrogram might impact the clarity of potentially life-saving imaging. So how do you perform a retrograde urethrogram? The technique is simple. All you really need is contrast, a little bit of KY jelly if you have it, 50 to 60 cc Toomey syringe, and a fluoroscopy suite. So you start off by pouring 25 cc's of contrast, and you mix this with 25 cc's of KY jelly in the specimen cup, and mix this up well. You draw the contrast jelly up in the syringe, and under fluoroscopy, insert the tip of the syringe into the penis, and pull it towards yourself, pinching the meatus around the tip of the syringe. Slowly inject all the contrast, and watch the contrast column on the fluoro screen. Once you have easy flow into the bladder, you could stop the study. If you see a disconnect or extravasation into the soft tissues, stop the study and call urology. The advantage of using this technique is the contrast and jelly mixture creates a gel that's less likely to leak from the meatus when you're injecting it, and the jelly also makes it easier to insert a catheter if you don't see a urethral injury. Alternatively, the classic approach is under sterile conditions, insert a 12 French Foley a couple centimeters into the penile meatus, fill the catheter balloon with a couple cc's of sterile water, and slowly inject about 20 to 30 cc's of undiluted water-soluble contrast, and get serial imaging as in 10 cc contrast intervals to again look for any disconnects or imperfections. Urethral injuries is really diagnosed, again, by retrograde urethrogram, and as we talked about, is managed based on location, whether it's anterior or posterior. And as you can see here, positive findings really include extravasation of contrast or failure of contrast to reach the bladder. With anterior urethral injuries, these are commonly associated with straddle injuries, and they're less common than posterior injuries. In blunt trauma, the bladder is usually drained with a suprapubic or urethral catheter with continued drainage for a handful of weeks to allow time for healing and delayed definitive treatment if necessary. While in penetrating trauma, these patients usually go for urgent surgical repair with end-to-end anastomoses. If you have a posterior urethral injury, these are most commonly caused by pelvic fractures, and these are 4 times more common than anterior urethral injuries in the setting of trauma. The disruption of the pelvic ring really causes shearing of the urethra, and treat these with urinary drainage, and if stable after a couple days, they're often realigned through endoscopy. If there's concern for urethral injury, the classic teaching is not to place a transurethral Foley, as it can convert a partial tear into a complete disruption. Of course, in the critical patient, a single attempt with a well-lubricated catheter still may be attempted. If you're unable to place a catheter, it's also important to know how to place a suprapubic catheter. To show us how, let's turn it over to Dr. Mason.
This video demonstrates placement of a suprapubic catheter using a Bonanno kit. This is a trocar system where you have a needle and a catheter that goes over the needle. There's also a peel-away style catheter, and the technique is very similar. Site selection should be fairly easy. You look right over the bladder and you should confirm with ultrasound this should be a very large target, otherwise the procedure is not indicated. Once your spot is marked, cleanse the skin and inject a local anesthetic. You want to numb up a nice wide area since this is going to be sutured in place. Also, you want to numb up the tract. So advance the needle into the subcutaneous tissue and inject as you withdraw. This kit comes with the metal trocar, the catheter, an adapter, and a plastic sheath that goes around the outside of the catheter. Use the plastic sheath to straighten out the pigtail end of the catheter, and now you could advance the metal trocar through the straightened out catheter. This prevents the trocar from piercing through the sidewall of the catheter. Remove the plastic sheath and grab a syringe to attach to the proximal end of the catheter. Clamp the adapter and make a small incision with an 11-blade scalpel where you're going to introduce the catheter. Now you insert the needle pretty much straight in. You go just slightly off of perpendicular, about 10 to 20 degrees caudally. Once you're through the skin, pull back on the plunger of the syringe as you advance the trocar. This way you know when you get urine back in the syringe that you're in the bladder. Here you can see we're getting urine back in the syringe. Now advance the catheter just a little bit more. Now's the part for steady hands. With your non-dominant hand, you're going to brace the trocar so it does not advance, while your dominant hand slides that catheter into the bladder. Remove the metal trocar and attach the clamped adapter. Connect the drainage bag to the adapter, unclamp it, and you can see it's going to start to slowly drain urine. It's not going to go very fast because it's going through a pretty small bore catheter. And you can see that nice straw-colored urine starting to drain. Ultrasound can be used to confirm that the catheter is within the bladder. You will likely need to inject more local anesthetic before you suture the catheter in place. And here's what the final product looks like.
To finish up, we'll talk a bit about genitalial trauma. Trauma to the external genitalia is managed based on the mechanism of injury, with penetrating trauma often mandating scrotal or penile expiration. These are often not life-threatening, but has obvious long-term sexual, reproductive, and psychological implications. Penile traumatic injuries usually fall into three main patterns. Penile amputation are generally rare, and most cases are due to self-injury. The primary goal of successful penile reimplantation includes minimizing ischemia time, proper transport of the distal penile segment, and this usually includes taking the distal segment, wrapping it in saline-soaked gauze, and placing this in a plastic bag. This bag will then be placed in a second plastic bag, which should be filled with ice, but really avoiding direct contact with ice. You can apply direct pressure to a bleeding stump, but of course avoid a tourniquet, and ultimately get your patient and the fragment to a microvascular surgeon for reimplantation. For lacerations, penetrating injuries, and bites, note that concomitant urethral injuries occur at a pretty high rate, about 11 to 29% of the time. Penetrating trauma to the penis are usually due to stabs or lacerations and usually will need urethral workup. Only clearly superficial wounds can be managed with local wound care. All other injuries require local wound exploration in the operating room to either debride devitalized tissue and really assess for violation of the tunica albuginea, which requires immediate surgical repair. With penile fractures, these are usually due to rupture of the tunica albuginea, which is a fibrous covering that envelops the corpora cavernosa. This is usually associated with a sudden cracking or popping sound during intercourse, associated with a sudden detumescence, and pain with manipulation of the penis. Similar to penetrating injuries, the rates of urethral injuries are similar, about 10 to 22%. If the diagnosis of a penile fracture is uncertain, further workup can include a penile ultrasound, which tends to be first line, or an MRI. And again, the rupture of a tunica really mandates repair to avoid contractures and downstream dysfunction. Lastly, we'll talk about scrotal injuries. And for scrotal injuries, the feared injury is testicular rupture. This again results from a tear in the tunica albuginea, resulting in really extrusion of testicular contents, and these patients often present with significant scrotal ecchymosis, pain, and swelling. This is often due to blunt trauma, and clinical examination is often insufficient to accurately determine the severity of injury because the ecchymosis and degree of hematoma do not accurately correlate with the severity of testicular injury. So diagnosis is generally made in conjunction with scrotal ultrasound. And here you could see maybe heterogeneous parenchyma and loss of contour. And ultrasound has close to 100% sensitivity and 93% specificity for the diagnosis of testicular rupture. Minor intratesticular hematomas without evidence of tunica rupture can be usually safely managed non-operatively, while surgical repair is really indicated for testicular rupture, hematocele, non-reducible testicular dislocation, or scrotal degloving. And surgical exploration should really be performed to avoid potential complications such as ischemic atrophy and infection. And if done promptly, testicular salvage really approaches 90%. So let's conclude with some takeaways as we wrap up. Hematuria is the hallmark of urologic injury. However, significant urologic injury can still occur in the absence of hematuria. Even severe injuries such as renal artery injury or ureteropelvic disruption can present with hematuria. Remember the skeletal injuries that are associated with genital urinary trauma. If you have pelvic fractures, think about posterior urethral injury and bladder injuries. Perineal stratal injuries are associated with anterior urethral injury, and fractures of the lower posterior ribs, the lower thoracic, or lumbar vertebrae can be associated with renal or ureteral injuries. Finally, for the stable patients, CT with IV contrast is the gold standard in assessing renal and GU trauma. However, know your pitfalls, as you could still miss significant injuries to the renal pelvis collecting system and ureter if the CT is obtained before contrast is excreted in the urine. Note that CT abdomen pelvis with IV contrast is not sensitive for bladder rupture, and these typically require subsequent imaging with a CT cystography. Thank you.
All right, that was awesome, Dr. Lai. Thanks for filling us in. We're going to move on to our next lecture, but first, Britt, you have gained yourself a bow tie.
Yeah, I mean, it just looked so good on you. I wanted one for myself.
Before you go on, I've got to ask a question. Did you get your question answered about getting kicked in the hoo-ha?
I feel like I did.
Okay,
it makes me even less anxious about getting kicked in the hoo-ha, but
yeah,
I'm
sure it would really be painful for you.
Yeah. All right, so moving on, our next talk is another consult corner, and we're going to be talking to OMFS. And these are from a couple of my fellow Fresnites.
Fresnosians?
Fresnonians? A couple of my fellow Fresnonians. I think that's the proper term.
Fresno.
So Jess Mason and Robert Julian up at UCSF Fresno are going to talk about OMFS.
Hi, I'm Jessica Mason. I am an assistant clinical professor of emergency medicine, and I get the pleasure of speaking today with an OMFS consultant, Dr. Robert Julian. He is both DDS and MD, and the chairman and residency director of the Oral and Maxillofacial Surgery Program here at UCSF Fresno. Thank you so much for taking the time to speak with me. I have so many questions for you about facial trauma. I appreciate your time being here.
Thank you for having me.
Okay, my first question for you before we get into cases is just mainly about the scope of practice of OMFS. And I feel like sometimes I'm not really sure who to call because there is a lot of overlap at times between OMFS, plastic surgery, ENT, ophthalmology, dental. So can you give me just a little bit of overview and guidance about what is your scope of practice, your training, and how do I know who to call?
Okay, that's it. So my personal training experience is, in an oral maxillofacial surgery. I also did a head and neck fellowship and have been practicing in a level 1 trauma center for 30 years, basically. So, I'd be someone who's very experienced in facial trauma. And then that can vary all the way to an oral maxillofacial surgeon that really doesn't go to the ER. And I think you could kind of extrapolate that out a little bit to plastic surgeons or otolaryngologists or ophthalmologists, oculoplastic surgeons, where some of them are very experienced in facial trauma and have a huge breadth of knowledge and could definitely benefit the patients in your emergency room. And I don't think you could just say in one fell swoop who you should call. I think you have to know that locally and regionally and get to know people and what they're and actually ask them what they're comfortable, consulting on. So I don't know if that specifically answers the question, but I think different practitioners from different specialties have varying comfort levels. And I think some of the other doctors try to simplify it at times down to, well, if I have a mandible fracture, I'm going to call oral surgery. And if I have an orbital fracture, I'm calling plastics. And if I have a nasal fracture, I'm calling ENT. And kind of like that, where that might be a little too simplistic. That would work as long as you've got a competent consultant.
Right. And there's a lot of overlap, it seems, in your skill set. So I know, at least here in Fresno, I can lean on OMFS for a lot of different issues that come up in the emergency department in the setting of facial trauma. So we appreciate your specialty and your amazing residents here. Okay. I was hoping that we could go through some cases and then I could ask you some of the big questions that I have about management of those cases. Is that all right?
That'd be great.
Okay, so you have a case here. Tell me about what we're seeing on the screen here. Who is this patient and what happened to him?
So this is a 15-year-old male that was got an elbow to the left eye or left orbit area. No loss of consciousness, no other injuries. Comes to the emergency room with pretty significant eye pain, and the eye checks out. Basically, there's no intraocular pressures are fine, visual acuity's fine, but he cannot look up. And this is the picture is basically showing, you could say, left-sided entrapment, and then of course the CT image to the right of that shows kind of the level of the injury itself, a so-called blowout fracture of the left orbit.
Yeah, so when I look at these images on that CT scan of the left eye, I'm seeing some air around the orbit. I'm seeing what looks like a fracture inferiorly. And then in the photo of the patient, it looks like he's trying to look upward. Someone's having him look up, and his right eye is looking up. The left eye looks like it cannot track as well. It's not going upwards as it should. And so is it fair to call this an entrapment? Is this an orbital blowout fracture?
Well, I think first of all, the findings on the CT scan are relatively subtle compared to the clinical finding, which I think you have summarized pretty well, is that he cannot look up, has restricted gaze, I think would be the right terminology, rather than just flat out calling it entrapment, only because the entrapment could technically be the lack of movement in that left eye could be neuromuscular and not just mechanical. But the CT scan is kind of classic for a wide-eyed blowout fracture in an adolescent, where in combination with that, he's got some autonomic signs and symptoms. He's nauseated, bouts of bradycardia, severe pain, throwing up, those kind of things. So he's probably not looking that great in the ER as far as how he feels. And the X-ray is very classic. It's kind of subtle, shows the inferior rectus muscle kind of being caught up in a trapdoor, quote unquote, fracture. And that's so I think your assessment of what's going on is good. I mean, obviously he got an ophthalmologic exam in terms of everything with the eye itself, the ocular injury, so to speak. There's no evidence of ocular injury.
Right. When I hear you describe this case, I'm also very concerned about an intracranial injury, the fact that he's nauseous and vomiting, and he was hit to the head. I'm probably going to get a head CT on him and make sure that there isn't something else going on, that it's just isolated to his orbit. And when you mentioned the nausea, and I believe you said autonomic symptoms, how does that change the picture? How does that change management for him? What is that telling us about what's going on with him systemically?
I mean, of course, there's the oculocardiac reflex that one can get either from operating on the eye or even having an injury around the eye. Some people are so sensitive to it, just pressing on their eye, relatively hard can cause it. And it's, we see a few cases a year of this, so it's not like it's real common, but it definitely happens. And he's got kind of classic oculocardiac reflex autonomic symptoms, although his symptoms are essentially intermittent bradycardia, nausea, vomiting, maybe a little bit of hypotension. We have seen cases where patients actually go asystolic for a moment, and that would be rare and obviously get everyone's attention. But to us, it suggests this is not someone that obviously the emergency department can send home or for an outpatient consultation.
Right, that's concerning. It sounds like he needs to be on a monitor. We're doing symptomatic management for his nausea. And would you say it's correct that we can't expect that those autonomic symptoms to improve until his eye injury improves, or might that get better on its own?
That I don't know that we kind of know that, if you will, scientifically or evidence-based, but most of these patients will sit around waiting for surgery, 24, 48 hours, get admitted. And I have never really seen them resolve. I don't remember seeing literature that would tell me that answer, but I think most of us consider this a surgical indication, relatively urgent. I don't like the word emergent, but 24, 48 hours. And you could differentiate, we kind of were kind of splitting hairs on restriction of the muscle versus entrapment. And technically you could put local anesthetic in the eye and do a force duction test to see if that eye really is mechanically restricted. Now, we don't do that often because in this case it probably wouldn't change our management, and furthermore that test can be harder than one thinks to interpret, where you're actually grabbing the sclera of the eye with a couple of forceps and seeing what your ocular motility is like, whether it's restricted or not. So that's what it says in all the books, that you could do a force duction test to differentiate between those two things. I think from a practical standpoint, we don't go around typically putting tetracaine in the eye and grabbing the sclera on patients that are perfectly awake. And in this case, it probably wouldn't change our mind about what needs to be done.
Yeah, that doesn't sound pleasant. If he hadn't had these autonomic findings, if it was just the fracture with the presumed entrapment of the muscle, could he potentially go home and have this repaired outpatient? In other words, is it just those autonomic systemic findings that are pushing us towards admitting him for close monitoring and a more urgent repair?
Yeah, I think, you know, the science of this particular injury, a quote unquote wide-eyed orbital blowout fracture, where you have kind of minimal evidence of injury, and they're really, for all practical purposes, they are entrapped. You can see what we would refer to as a trapdoor fracture on CT scan. And I think the general consensus, this needs to be repaired within a day or two. Although there are some prospective studies that actually show that it's probably the outcomes are more based on the level of experience of the surgeon that takes care of them than it is actually on the timing. And I don't want, you know, obviously we don't have time to go into all the exact evidence there, but we're not in a real rush. I think because the patient gets hospitalized and they have autonomic symptoms, from a practical standpoint, we're going to start moving towards the door in terms of, you know, get them to the operating room, probably not emergently, but within a day or two.
I see.
I wouldn't think that you'd send this patient home.
Yeah, not with those symptoms, I think. Let's move on down the face a little bit. Let's move down to the mid face and some of the injury patterns that we might see with these mid face fractures. So you have a couple of interesting images here, things that we really don't see very often. This first one is an orbital dystopia. Would you just remind our audience what is an orbital dystopia, and could you describe what you're seeing here in these images?
So if you look at the right, you know, the clinical view there, the eye position itself, you kind of get the feeling when you first look at that wow, that's a ruptured globe or something. And really what it is just a fairly displaced orbital fracture. In this case, it's part of a Lefort 3 pattern of fracture, but it could be a badly displaced strictly orbital fracture or a zygomaculomaxillary complex fracture. But what you really are looking at there is the orbital volume has been so increased in that from the injury that the eye is inferior in position. So we would refer to that as inferior dystopia. So, you know, but it gives you just some words to help describe what you're seeing. And this isn't terribly uncommon in a significant orbital or midfacial injury.
Mm-hmm. So the eye itself is intact. There's no globe rupture. The eye is okay. It's just inferiorly displaced. Is that an accurate way?
That is very accurate. Of course, you have to determine that. I can't just look at him, you know, and
sure.
None of us can just briefly glance at him and go, "Your eye's okay." But, you know,
no, it looks terrible.
It looks things, and even if they're not, even if they're head injured, obviously we have pressures we can do. We can look at the shape of the pupil. We can, you know, do an exam. It's always nice to have visual acuity, of course, but.
And so this would also indicate then that there is an injury to the inferior orbit. Otherwise, how could it get pushed down and displaced inferiorly?
Yeah, I mean, this is severe enough that you're typically not going to see this level of inferior dystopia, but for a significant orbital fracture, not just a blowout fracture, but probably either a bad zygomaculomaxillary complex fracture or a pretty significantly displaced Lefort 3 fracture, something like that.
Mm-hmm. And in the next slide here, in the next image, is something called an enophthalmos. It's a bit subtle, but you could see that the eyes don't seem to be quite lining up.
So we refer to enophthalmos pretty commonly because you could see it acutely at times, but in many acute injuries, because obviously this isn't an acutely injured patient, this is actually showing you the sequelae or problem with some of the badly displaced orbital fractures. In fact, that is the same patient. That patient was inferiorly dystopic upon injury, and that was repaired, but we ended up with pretty significant enophthalmos, which need to be repaired further. But really what that means in English is the eye is back in an anterior posterior direction compared to the other eye. And you can see that acutely. I didn't show you a picture of that, but it's probably more for a terminology. But if you saw either of those signs in an acute injury of the face, it's pretty much going to tell you they're going to need surgery.
You mentioned that this could be a sign of a Lefort 3 fracture. And I want to bring up this illustration here as a reminder of the different types of Lefort fractures. Could you go through the three different types and their clinical relevance?
Sure. I think whenever we refer to Lefort level fractures, I think what we're really talking about, and this might be, hopefully I can get it down to something a little bit simpler, I think, than some people think of it. We're always referring to a maxillary fracture. So it's just a question of, is it the maxilla only? Does it include the central element, meaning the nose and part of the ethmoids and a little bit of the orbit? Or does it involve really a craniofacial disjunction like Lefort 3? But the way to think about it, all three of those categories have a mobile or displaced, or at least fractured maxilla. So Lefort 1 would be the easy way to look at it. Lefort 1 would be, I wiggle the maxilla that's broken and the maxilla alone wiggles. A Lefort 2 would be the nose wiggles with it. And Lefort 3 would be the orbits wiggle with it.
And these are pretty severe facial fractures, it seems, at any level. And of course, we're getting a consultant involved in a case with a Lefort fracture. Is there anything else other than kind of picking up the phone and calling you guys that we need to be particularly aware of? You know, of course, we're thinking about the trauma patient as a whole and head injury and all of the other things that we go through. But with specific regard to this fracture pattern, is there anything else that we need to know as we're making that phone call to you?
Yeah, I think that's a good question. Look, I mean, mid-facial level fractures, and you could probably throw in, a frontal sinus fracture and a zygomatic maxillary complex fracture and a really bad nasal fracture. You could throw a number of those type of injuries. And I think what we would want to know, which are things that you guys are the best at, is just, first of all, airway bleeding, basically their overall disposition, and you usually have that taken care of. And then there's kind of the question of, okay, so if it's an upper level mid-face or frontal sinus, orbital fracture, that kind of thing, how are their eyes? And typically you guys have that as well already handled. So then we're kind of down to, okay, could they be outpatient? What really happens in many of these mid-facial, severe mid-facial injuries is they already have other injuries. So they're typically being admitted through the trauma service and being taken care of that direction. But we do see some patients who are outpatient worthy, I would say, as long as they don't have too significant of a nasal bleeding and they're able to swallow, be able to take in PO intake, because that's something sometimes they don't have bleeding, they don't have an airway problem, but they can't swallow either. Right. Some of these cases, we see a few Lefort 3s and things here that are minimally displaced that we don't even treat. So just by label, there's no necessary, just by the label of the fracture doesn't necessarily indicate the, severity of the injury. And I think, most of you already realize that. So it's really gauging each one, each patient individually. Sure. We do see some outpatient Lefort 2s and 3s that we treat. So
there's sort of that golden time window where right off the bat, the first couple days, you're not excited about operating right away. You want the swelling to go down, but if you wait too long, then it becomes a difficult repair. So what's the ideal, you get to choose the ideal time where, let's say this patient here with this severely displaced nasal bone fracture, I saw him in the ER, I'm sending him to you. What's your ideal follow-up time?
I mean, ideal follow-up time would be like we see him 5 days later, and this is really being spoiled, but if we saw him 5 days later and we decided we're going to either reduce it in the office environment or sedation, or we're going to do it in the operating room outpatient, but it allows us to make those decisions and have a week or so we could still schedule, and it's still uncomplicated. It's not really a septorrhinoplasty. It's not a real, probably even a closed reduction would cut it. So, I would say if the patient could be seen in the office in 7 to 14 days, that would be, 7 would be ideal. 14 is getting a little bit far out. But that's kind of what we'd prefer to see.
Great. Now I'm looking again at this patient here, one of your patients with this displaced nasal bone fracture. And if he came into the ER, one question that would be running through my head, is it ever indicated or a good idea to attempt to reduce that in the emergency department when it is just, it's so displaced? I feel like maybe I could do some good here.
You could.
Or harm,
I think
or
the
harm.
variables, that you run into with with a nasal fracture, most of the time don't come back to bite us, but then there are times where they do, where we decide that it's a relatively simple procedure. We're going to go ahead and take care of it. And then what we find is that one of the variables is usually a nasal fracture that's that displaced is going to have significant nasal septal deflection. And to make that part of the nose anesthetic in the in the ER or in my office environment or the ER environment, it's going to be relatively difficult. So what ends up happening in some cases is you get kind of an inadequate treatment that you could have done a better job if they were completely under a general anesthetic, and you get to manage the bleeding a little bit better, and you get to manage the position of the nasal septum. So tempting, and it actually, it would do some good. It's just the question is, are you going to do it? Really, I think what we expect in our system is for someone to kind of fulfill the, I hate to use the standard of care terminology, but regurgitating it back, but the standard of care here is to get the nasal bones and the nasal septum back where it belongs the best we can with the patient comfortable. And that's just really hard to do in the emergency room environment.
I do want to throw a little wrench here in this case. Let's say when he came in with this injury that it was complicated by a difficult to control epistaxis. Now, I feel, are very comfortable managing epistaxis in general, and it's more often not trauma related. We've got a lot of tools that we can use and medications. But in the setting of a nasal fracture or other facial fractures with severe epistaxis, how does that change how you recommend we manage the epistaxis?
Well, I think with if it's an isolated nasal fracture, which this was a radiographic, this patient that we're showing was a radiographically proven isolated nasal fracture. I'm not really concerned about nasal packings one way or another, whether we start down our hierarchy of anterior agents and tampons and light packings all the way to a posterior anterior balloon all the way to IR if you really want to I try to avoid that, but that's a discussion maybe for a different day. But if it's an isolated nasal fracture, that's not a problem. You just it's going to be more uncomfortable for the patient because their nasal bones are broken, and you're probably going to have to worry about their comfort level and that kind of thing that you have to do anyway with manipulation of of the nose with intranasal packings and that kind of thing. I think where the issue would come in more is if you have a skull-based fracture, a nasal orbital ethmoid fracture, even a Lefort 3 or Lefort 2 fracture, where theoretically the skull base is involved and you get into packing a bunch of things in the nose. And I'm not talking about the anterior, packings and tampons and different agents and sponges that we have. I think what I'm getting more out of, if you're getting into a posterior anterior pack, it's probably time for a consultant to take care of that in the face of a complex, mid-facial fracture. I think it's probably the line where you'd want to have them come in and help you.
Yeah, I'd probably be reaching for some TXA soaked gauze and see if a packing, which is a little bit less aggressive than a balloon or nasal tampon, I'd probably be reaching for that first. And if that failed, then you're really headed towards some types of packing. And I think, like you said, getting a consultant involved, because that can be a bit scary. Any other comments on the nasal bone fracture? Because I do have one more case that I want to go through with you.
I'm not sure. I think you do need to talk to mid-facial orbital fracture patients about nose blowing, because there have been reported cases of air emphysema, from basically nasal pressure to sinus to orbital cavity to orbital apex compression and compression syndrome in the orbit from air. That's kind of scary, but.
So tell me, what is that advice that you're giving patients about nose blowing?
So we just tell them, if there's an orbital injury, and again, like I said, that involves the sinus, which is a myriad. It's not just an orbital blowout fracture. It's all those other fractures we talked about. a Lafort 2, a Lafort 3, a zygomatic fracture, a blowout fracture, a blow-in fracture. I challenge you to find one that doesn't involve a sinus. It's not possible. So those patients are told not to blow their nose to avoid an orbital emphysema, which in most cases is benign, but not always. And we tell them 2-3 weeks. So whether it's after the injury or after repair, we kind of start that clock over again. But I think it's pretty well fibrosed in after a couple of weeks. I think 3 weeks is definitely safe.
That sounds brutal. Tell someone they
What,
can't.
not being able to blow your nose after you
Yeah.
just had an injury or surgery on it?
Are they allowed to sneeze?
Well, yeah, I think the recommendation is sneeze with your mouth open.
Okay.
Which, that gets interesting in today's era.
Sneeze into your mask.
But I think real quickly, there was a time maybe 15, 20 years ago, where we were trying to say that orbital emphysema is not really a problem. So if you sneeze after you've had an orbital blowout fracture and you've got this big air emphysema around the eye, that it wasn't going to be a problem. And I think the oculoplastic surgeons published some literature showing some cases of blindness and try to talk about the incidence of blindness and that it can be a serious issue. Don't just blow it off. And there was also some cases of infection. So orbital emphysema in itself, meaning you're feeling kind of air bubbles around the orbit, in the soft tissue emphysema, may increase your likelihood to want to put someone on antibiotics as well.
Mm-hmm. Mm-hmm. Yeah.
And to kind of finish that discussion, you get into mandible fractures.
Yes. And that's the last case here. There is an
So-
image that you have here moving down the face. We're looking at a mandible fracture. And could you describe for me what are you seeing there? How displaced is it?
So we're looking at a midline. I think that we're looking at the same image, a midline injury of the mandible, so-called symphyseal fracture. And I think we would consider that moderate displacement. It's definitely obvious. You can move those segments a little bit. Obviously it's an open fracture because it's between teeth, but it's not necessarily an indication to do anything, strangely.
Right. Most patients that we see with mandible fractures are, if that's an isolated injury, we send so many of them home. So when should there be a red flag for us that it's severe enough that the patient would need to be admitted and have a more urgent repair?
Yeah, it's a great, and you guys send many of these out to the outpatient environment appropriately. So, the indications would be more severe displacement to the point of, one is uncontrolled pain that we do see sometimes. Just every time they move their jaw, these fracture segments, which can be multiple, are wobbling around. And yeah, they don't have an airway or they don't have an airway problem or a bleeding problem, but they're having a little trouble like drinking water. And their pain's uncontrolled and the segments are moving around. And so my own term for that is traumatic dysphagia, but I don't think anybody else really looks at it that way. But basically you can have a facial injury, a mouth, tongue, jaw injury bad enough that you're really not going to do well at home, even though there's not any particular indication to admit you from the classic standpoint.
It just looks brutal, like this next photo that you have, another mandible fracture, but more severely displaced. And it looks very painful. I can't see someone like that being able to really talk without severe pain or eat. That looks like someone who really needs to be admitted and have a more urgent repair. Would you agree with that?
I would agree. This patient did have, as you outlined already, uncontrolled pain with just moving their mouth, trying to talk, trying to do anything. And when I say uncontrolled, I am speaking about they've gotten narcotics, they've gotten Toradol, they've gotten Tylenol. We're not trying to just go, you can't have any narcotics because you had a head injury yesterday or something. We're really trying to control it. And they're calling us, and some of these patients get sent home and they're not cutting it, or they come in the office the next day. And that's a scenario we try to avoid, which is a patient with a mandible fracture who's seen in the emergency room, who's not in very good shape in terms of some of those things we talked about. They don't have bleeding or airway, but they've got, they're not in very good shape. So they show up in the office the next morning and we take one look at them and I'm like, well, looks like we're going to be admitting them. And, and then we just head for the door in terms of this is, obviously both of these injuries we're showing need to be repaired. Otherwise, they're likely to end up in a non-union infection, malunion, loss of teeth, osteomyelitis. I could keep going, but it needs to be treated.
Yeah.
And this particular injury that we're looking at now is, I would say, severely displaced. Patient has a lot of pain, can't swallow well. It needs to be taken care of.
Mm-hmm. In some mandible fractures where it's, I guess, minimally or moderately displaced, is there ever an indication for doing splinting of the teeth or the mandible in the emergency department?
Yeah, I think splinting is kind of not controversial. I think in the old days, before we had good rigid fixation devices, sometimes we would do splinting, in the emergency room with methyl methacrylate and this kind of thing. I think that day has passed. I don't think we do that anymore. And I don't think our otolaryngology colleagues or plastic surgery colleagues ever did that really. But I think what can be helpful is what we would call a bridle wire, which is a way to put a 24 relatively heavy wire around two of the teeth. And that could be done in this case we're looking at here, where under local anesthesia in the emergency room, we put a wire around the two teeth in the back, two in the front, and just bring it together while having the patient bite down. It's not going to be definitive treatment, but it may get them home in terms of that fracture just wobbling around. And we do that fairly often in the emergency room environment.
Well, I think we should probably wrap up here because we've been going for quite a while now, and there's just been so many great teaching points and so much that I've learned. Is there anything else that we haven't touched on that you feel like you got to tell us, or any other final teaching points you could share with us?
I think I would probably close with the antibiotic situation, because we see it all over the place in the emergency medicine community, and I'm not sure there is, the evidence base that you could try to lock onto is lacking, I will admit. And the way I look at it, I think is what I wanted to kind of say is, especially for mandible fractures where they're between teeth, open to the oral cavity, if they're immunocompromised, if they're older, if they're methamphetamine addicted, they're smokers, if you can just kind of add a couple things up that go, I think this patient might get an infection, I would say that's the patient to put on antibiotics. Can I back that up with perfect evidence base? No, because a lot of those variables aren't taken care of that well in the studies. But I would say mandible fractures is an area to put patients on antibiotics because a lot of your patients have those variables that we already discussed,
right?
Diabetes, etc. But then the question is, every patient with a closed zygomatic or maxillary complex fracture or a closed nasal fracture, they probably don't need antibiotics.
Thank you so much. This has been a really great review. I feel like there's so much more here we could potentially talk about, but really, really appreciate your time and your expertise.
You're welcome. I appreciate you having me, and hello to all your viewers, and thanks for taking the time to learn a little more about facial trauma.
A patient with an anterior dislocation of their temporomandibular joint will have their jaw fixed in this open position, which looks very uncomfortable. You can reduce it externally with this maneuver demonstrated by Dr. Riccoboni. Now watch carefully. With his right hand, he is pulling the mandibular ramus forward, and with his left hand, his thumb is pushing the coronoid process posteriorly. This twists the mandible, and then the right side pops back in, and the left side then spontaneously reduces back.
Oh. Thank you.
Feel better?
Yes, way better.
So that's pretty confusing. Let's see it one more time. Let's break down those movements a little bit more clearly. What he's doing with his right hand, and you can do this with either side first, you're pulling the mandibular ramus forward. And with the left hand, you've got your thumb on the coronoid process, and you're pushing that posteriorly. So this twists one condyle into the TMJ first, and then the other side just pops back in. For many patients, you can attempt this with either no sedation or just a little bit of benzodiazepine, which is what they've done here, and it's worked very well.
So that was a great session, and that was a great reduction, but I want to show you another one because I found that if that doesn't work, and Billy Mallon actually showed me this, and so Chris here has got a dislocated jaw, boom! If you come in from behind, if you're above the patient and you stick your fingers into their mouth along that teeth line posteriorly, and you do this maneuver like this, you have a lot of power here with these muscles. and you can generate a significant amount of force. So that's another way to do it. Obviously, you're going to wrap your thumbs up. I actually used to put tongue depressors on both sides and some wrap, and you use just lots of wrapping, and then pop it in like that. It's fantastic. All right, just another way to do it. So these videos by Jess are all up on the HD site, and she's now got, I think, hundreds of these procedure videos there. Spectacular. Do you like my bow tie?
Mel, I like your bow tie.
I tied it myself. Let's take a 10-minute break, do your poos and your wheeze, and we'll be back in 10.
More coffee.
More coffee.
traumatic arrest. Even if you've been doing this a long time, that's got to get your heart rate going just a little bit. And if it doesn't, I wonder if maybe this is the right specialty. But it certainly gets my attention, and I struggle with some issues here. When do we do a thoracotomy? When it's up to me and I've got maybe a surgeon on their way in? Do I do a left lateral thoracotomy? Do I do a clamshell? Lots of questions come up. And again, even 25 years into this, I'm still not crystal clear the right answers to some of these. So here comes Kenji Inaba, one of my favorite surgeons, to tell us. He and Ryan are going to really answer all the questions we have about this. So Kenji, Ryan, what should we do?
Hello, everyone. So we are really lucky today to have time to spend with Kenji Inaba. He is the Chief of Trauma Surgery at USC LA County. Very knowledgeable. Almost everyone probably already knows him. And we're going to be talking about traumatic arrest and thoracotomies in our trauma patients. So welcome, Kenji.
Yeah, thank you so much. It's truly an honor to be here hanging out with you. And talking about friends we have in common. It's awesome. So thank you for having me.
Yeah, this is great. I am very excited. I'm personally very excited.
Awesome.
So we'll just get right into the questions.
Yeah, for sure.
When we're thinking ED thoracotomy, who are good candidates? Who are we performing this procedure on?
Yeah, I think that really is the $1 million question. And I got to tell you that the data is not great. So I'll give you my 2 cents worth. I think if just to keep it super practical and pragmatic, I would say that there's probably 2 or 3 things that I really think about when I decide who is a good candidate. And those be the people, the injury itself that they've sustained, and then, of course, time. And so I think, looking at people, and I know there's really no science behind it, but I think there clearly is a difference between that 21-year-old male that came in arresting after a stab wound compared to a 97-year-old with like metastatic cancer who fell, sustained blunt trauma, and arrested. So there's no question that the person or the patient that comes in has got to factor into your decision making. But probably even more important than that is the actual mechanism. And we know, for example, that if you arrest from a stab wound to the heart, upwards of 20% of those folks can be brought back as compared to patients who sustain blunt trauma. So I think mechanism is perhaps one of the most important things. And I would say that stab wounds do better than gunshot wounds. Stab wounds to the thoracic area will do better than those to the abdominal area. And of course, at the very end are the blunt trauma patients. With that said, though, I think there still is some yield in blunt trauma patients. And not only are there blunt trauma patients that make it back, but we know that there are blunt trauma patients that go on to become organ donors. So I think there is no absolute mechanism that should be a contraindication, but we know that some definitely do better than others. And then the final thing, of course, is time. And for sure, we were chatting earlier this week about the 15-minute rule or the 10-minute rule. And I think if you look at that Western Trauma Association multi-institutional trial, if CPR has been ongoing for more than 15 minutes for penetrating and 9, so if we round up to 10 for blunt trauma patients, the likelihood of survival is super low. So I think the take-home message is, I know it's not a super accurate, how long have they been doing CPR for? It's not a super accurate metric, but the longer it's been, the less likely it's going to be, which then gets us to the final thing. And I think it kind of depends on where you work and what kind of resources you have around you, and what access to, human resources, surgeons, operating rooms, all of that sort of stuff. At LA County, where we work, last year we did 82 ED thoracotomies or resuscitative thoracotomies. And at a place like that, it's super easy for us. It just doesn't mess with our patient flow at all. It all gets taken into stride. It gets done. There's a resolution one way or another, and we just move on to the next patient. So I think in a setting like ours, it's really easy to get it done logistically. But if you work in a place where it really will disrupt patient flow, for example, I think that's another practical thing that you just have got to take into consideration. So I think, the people that come in, the patient themselves, the injury mechanism and the location how long it's been, and then are you capable of doing it logistically? I think those would be the things that I would think about. And I know there's not a lot of science to it, but those would be the practical things I would think of.
And what about like if you're out, you're a doc and maybe a freestanding or somewhere where there's not surgery in house? Is it ever appropriate to do the ED thoracotomy? I know we asked you this a few years ago, and I was just curious if you've changed your mind or had any new epiphany on this.
I honestly, I can't remember what we said, so I apologize if I say something the opposite of what I said before. But here. Okay, this is what I would say. So, number one, I think that it is absolutely critical that every emergency medicine physician that works in a place that can potentially see trauma has a basic understanding of how to do a thoracotomy. And I say that because I really do believe that if you're going to do whatever procedure, like a thoracotomy, for example, for someone that's arrested, the reality is in the vast majority of cases, it is a temporizing procedure that basically is designed to stop blood loss and to get the heart restarted so that you can move to definitive care and fix whatever it is, continue resuscitation, and get that chest closed. So temporizing, stop blood bleeding and get the heart going. We know that that's a goal. And yet, I think that even if you work in a place where there is no surgeon in-house, and in fact, maybe the surgeon's, I don't know, an hour away, or maybe they're even further away, but I happen to be walking around in that town and I get stabbed in the heart, and I arrest and I roll into that emergency department. I would really want whoever is on that day to open my left chest, pop the heart out, and just do something to stop that hole from bleeding. That can be life-saving in seconds. And if you look at all of the component skills required to get that hole closed, they're all within the realm of whoever happens to be on that day in that emergency department, even if the surgeon's an hour away. And so I think I would agree with what you're saying, that, when you do a procedure, you kind of have to think about what are the goals of that procedure and where we're trying to get them to. And you kind of have to have a surgeon at the end for almost everything. The reality is there are some things that warrant an ED thoracotomy where everything, the life-saving part of it all, can be done in the emergency department without the presence of a surgeon. And I personally would want that done to me.
So a lot of what we've been talking about is kind of who to do it on, when to do it. Let's talk about the kind of nuts and bolts of what we're doing. First question would be left lateral versus clamshell.
That's a great question. You know what? If you asked me this question a couple years ago, I would have said 100%. You just do left anterolateral thoracotomy. That's the way to go. And I will tell you how we do it at LA County. But interestingly, I want to say, I can't remember exactly when, but like a little while ago, Joe DeBose, who I think you had on this segment recently,
he's talking about vascular surgery.
He's going to be talking about vascular surgery. So he's one of our former fellows. He's in the U.S. Air Force. Great guy. And he put out a really interesting paper looking specifically at our aortic occlusion database that is a very nice repository of data looking specifically at clamshell thoracotomies versus left anterolateral thoracotomy. Now, we know that this is a look at a database that was accrued for something else. And we also know that we actually don't have the data as to, was that clamshell done up front specifically for that indication, or was it a left added to a right with a line that came across? So we don't know those things, but what we do know is that the complication burden, when you compare those two, was shockingly similar, which kind of went against what we all used to say before. So I will say that now, since you're asking me that question, I'll say that it is definitely a viable option to go straight to clamshell. And I would also say that it gives you a wicked view of everything in there. So for any procedures or things that you have to do, your ability to actually access the structures is really awesome. So I'll say that for sure. Now, at LA County, where we're still a little bit old-fashioned, the way that we do things, if someone comes in arrest, is we will immediately start with a left anterolateral thoracotomy. That's our working side, and we're going to get going on getting that heart up. We're going to be working on getting a cross-clamp across the aorta. We're going to stop any bleeding that's in the thoracic cavity. Now, on the right side, our emergency medicine colleagues are going to immediately get a chest tube into that right chest. And there's another team at the head working that airway, getting that going, and someone's working on the resuscitation, getting access and getting blood in as quick as possible. So those are the four sort of things that are happening concurrently. Now, if the emergency medicine team, the resident that's on the right side, taps into that chest and a bunch of blood comes out, then they're going to immediately cut into that chest and open that right thoracotomy. And in virtually all cases, if we're going to do that, whoever gets done first is going to come across sternum, because that'll afford us the perfect view of everything. And we can work together much easier to kind of figure out what's going on. Is the blood starting on my side and coming across the mediastinum to that side, or vice versa? So we can really figure out what's happening, and we can work together to stop that bleeding, cross-clamp the aorta, and start to get that heart resuscitated, and to a point where it's perfusing something. So that's what we do. But if there are listeners out there that are considering moving straight to clamshell for the next time a patient arrests in their emergency department, I think there's more data now to suggest that the view is excellent and the complication burden is probably not as bad as we thought it was going to be. So yeah, that's a great question though.
Yeah,
I mean, it's a nice practical thing. The kind of, I think my thinking on it certainly has evolved. I wasn't sure what was going to come out of that research project, and it wasn't what I thought, to be perfectly honest. So yeah, it's a great question.
So you mentioned, like, if you came in and you had a stab wound to the heart, you would want them to like repair that. You see references to putting a finger on it, putting a Foley in it, putting a staple in it, putting a suture in it. And you kind of always hear, this is the advantage to this and this is the disadvantage to this technique. Any preferences on your end? How to
Great points.
proceed?
Yeah. So of all the things that we do, that's probably the single most high yield life-saving thing. And so as soon as that pericardium gets open, and that pericardium can be super tight. So I think it's important to, you can do a bunch of different things, but if you try to do it just with scissors, you're gonna be super frustrated because it's actually fairly thick, especially in a young patient. You want to be able to grab it with some pickups. So there should be some pickups that can help you do that. You can make a little stab nick with your scalpel, but you just have to be careful because it's hopefully it's still beating a little bit. And so that motion can pop into the heart, which is not a huge deal, but it's preferable to pick it up and make a little pinch so that there's a little fold of pericardium. You can snip it and then you can open it, running parallel to the phrenic. Once you do that, you can pop the heart out, and you really do hope that you see a little hole there, because that really is ideal. And if you see that hole, you can just stick your finger on it. That'll be the first move. So of all the four things that you said, first thing, you should calmly put your finger on that hole. And even if your finger doesn't completely occlude it, you're gonna be able to slow the bleeding down a ton without hurting the heart at all. And it doesn't have to be forcefully placed on it. You just gently put it on, and you're not trying to really like cover it up. You just need a single finger, and just by holding it there, and you'll just move with the heart, it'll decrease the amount of blood flow. And then at that point, I think you have two options. And I would say that the ideal situation is to use a suture. So all of our residents, you've probably seen them walk around if you've ever been to LA County. They always have, because they're hard to find in the emergency department, one or maybe a couple 2O prolines. And so the ideal suture, I think, is something that's not too thin, because it'll just snap because you're under a lot of pressure. Everyone's watching you, and you just like it'd be a drag if you just snap it. So like a 2O, I think, is a good sort of weight of suture. We use a proline because it'll go through nice and smoothly. And the biggest tapered needle you can find is the way to go. So like a tiny little needle is really going to make it awkward, and you're not going to look super smooth. So a large tapered needle with a 2O proline is probably the ideal situation. And honestly, up front, just doing a super simple stitch or figure eight or any mattress, anything that'll hold that open and close is the way to go. Now, if you happen to not be super comfortable with that, people often ask, can you use a regular skin staple? And the answer is yes. And I think, again, in this situation, the most important thing is you get your finger on it just to calm everything down. And for most people, if you're right hand dominant and you're there at the patient's left side, you can just put your finger on it, like an index finger would be, I think, the natural thing that most people that we would gravitate towards. And you bought yourself some time. So someone's pouring blood in, someone's dealing with the airway. Someone may have been putting a right chest tube in, but now you know what it is. This is the culprit. So you've got your finger on, you've got a few seconds while the resuscitation is going in, and you're really decreasing the amount of blood that's coming out. If you feel comfortable with staple, I think it's totally fine. You want to be careful whether you're suturing or stapling. It's probably easiest for one operator, whoever it is, to be doing the whole thing. And I think for most people, if you switch over and you grab the heart like this and use your thumb now, no matter where that hole is, you can almost always, for most people with normal sized hands, occlude that hole with your thumb. And then you can come in with your dominant hand with the stapler, or the suture for that matter. And, as the incision is under your thumb, if you draw your thumb back a little bit, it just opens up a little bit of that opening, and you can just bring your stapler down and very slowly and in a confident way staple that shut. And you can just run the staples down. Now, I think ideally it would be a suture that's placed once and we don't have to replace it. But if you're comfortable with a stapler and you can get that bleeding stopped, then I would say that that's the right thing to do. Now, the last thing that you mentioned, which is the Foley catheter, that can work, but I haven't had great success with it. I love to use balloons all over the body to stop bleeding. I think they're super effective. They're ubiquitous, and they're just like super easy to use. I just find in the heart that it's so much easier to just put your finger on it and then just deal with it. If you don't have a stapler and you're not comfortable suturing and all you have is a Foley that you want to clamp, if you can blow it up and clamp it off and get it to hold, and then I think that that's great. The bottom line is whatever it takes to get that bleeding stopped temporarily will save that person's life.
Mm-hmm. Everybody, thanks for joining us for this happy hour with Kenji. Kenji, it's been awesome to talk to you. It's been an honor. It's been a privilege. I feel like I am 10 times smarter than I was an hour ago. So thanks for taking time to join us
100%.
today. It's been
Thanks
awesome
for having me. Like, honestly, it truly is an honor to be here. So thank you so much. And thank you everybody for listening. So
awesome.
Excellent. All right. Cheers. Cheers. Thank you.
So I want to be honest with you about a couple of things. First of all, I've known Kenji for over 20 years and I hate him. Not only is he a fantastic surgeon and he's a great guy and he's an amazing educator, he's also a cop and he also works on the SWAT team. There's nothing this guy can't do. I find it very upsetting. It makes me feel bad about myself. So F you, Kenji. Now let's talk about thoracotomy. So I want to just set this up because this video was shot over 20 years ago and it is truly remarkable. You will probably never see anything like this again because there was a confluence of things happening. First of all, you had Deeku Mandavia there who is an ER attending who liked to do a lot of videos. And the second attending was just coming on. And then this patient came in, and this was back in a time when you could do videos like this and then get consent after the fact from the family or from the patients themselves. So you'll never probably see a video like this again, or very unlikely, and it is extraordinarily useful about how to do a thoracotomy in the real world. So let's watch this extraordinary video.
Pause, secure that airway.
Okay, combi tubes in. Transfer the patient off the pauses at the head of the bed to airway.
Okay, I got your instrument. Good. For the betadine. Betadine splash. Okay. Okay, your knife is here. I can't confirm it. Can I get the oxygen? No. Okay, I see it. Okay, from here down back.
Yes, it is. The line is down.
Okay. Keep going. Good job. Okay, here's your scissors. Get in there.
For me, baby. He has no line.
I'm doing it right.
There's chest blood. Got lots of blood.
Pneumothorax.
Okay.
Open the chest. Yep. Go, 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 go. Go, 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 go. Okay, take. All right, man.
So you're going to have to get across the hilum of this lung.
Okay.
Good. Keep it going.
So Craig started by...
Break that rib here. Here. Break that rib with this. Here. Get around it. Yep. Good. Crack it. Get closer. Get close. Yeah.
Just be careful, Tom. You got blood pressure.
He's got blood coming out of his mediastinum too.
Someone working on a line?
Yeah, it's right down here. We got a camera.
Just
Open anteriorly. Holding this anteriorly.
You can have something. Just kind of get in between here and just try and don't push yourself on that rib. Careful.
Diaphragm.
Alright, is pericardium full?
Okay, let me get. Okay.
Open pericardium.
Okay.
This is diaphragm here, right?
No, that's heart. This is heart here, right? I think this is actually the heart. You can actually open this up. Yeah, no, that's the pericardium. Here. Open that up.
You may be in already. Squeeze that thing.
Yep, pinch and cut and extend it. Bring it in there like that. Okay, go and extend. Don't cut me. Don't cut yourself. Okay, let's see if we can find an injury.
Here, he blood.
Is that all clot? That's all clot. Blood in the heart is clotted. See if we can find an injury anywhere.
Did you got the one on his leg too? Yeah, I got him.
It's got a big hole there. It's okay. You want to suture that up? Load your needles up. Close this up. Little injury to the right ventricle. See what you got? Left ventricle, sorry. Here and coming out here. Okay. Okay, there's no way.
You want to staple that?
No cardiac activity. Now go ahead and suture it up with that. Suture it up with the proline. Proline? To a proline.
Two needle proline.
We got.
Gunshot went to the left ventricle, through and through.
Heart's empty.
Yeah, no, it's completely empty. Okay, just suture that up.
Take it easy.
Sorry, man. Yeah, there's a finger on the other side.
Oh, no, I wanted a TTA. I just want to tell you what was going on. Definitely.
Tie that up, that's enough.
Yeah, it's diaphragm.
His belly's full, his chest was full, his knee is full.
It's not done yet.
Want the needle up? Yep. Let's see if we can get one posteriorly.
Wow, that's quite a rent. Alright.
So you have to go from above, up in the corner,
There?
Yep. Uh-huh.
Good stuff, guys. Yeah, take your time.
How are we doing with that line? Good?
You got a femoral line here.
Yeah, can't see.
You got fluids running in the femoral.
Yeah, try doing two.
No.
Looks like Shiley.
Keep it going. 4.
Got a 4 Shiley.
You guys want to...
Positive.
You guys fight them? Yeah. They come in with a combi too. Watch your finger.
Watch your needle right there. Yeah, stop there, right in between. What do we call it?
When we, and also, you want to cross clamp that aorta?
Sure, we can do that.
Can you stop the repair there and go over where the clamp is? That's probably a good idea. Okay, let me see where you're doing those D-cell lights and shine it in there. Okay, you corner at the aorta?
Aorta, it's fine. Just open up under there, cut.
No matter.
Yep. Make it your right angle and poke in through there. Get your right angle, that's enough.
Right angle.
Yeah, perfect. Yep. Get it around. Poke to the other side.
Hey, Doc.
And clap it off.
Okay, so putting it around, it just got spinal column there.
Yeah, you're posterior to it. You want to get it on top here like that.
I thought critical was more that. Oh, okay.
Yeah, like that. Just get one end under. There you go. Sorry, I'm not being very clear.
Okay, got it. You see?
That's
you
it.
see?
You got
demonstrate that?
Aorta's cross clamped.
Aorta is cross clamp.
Okay.
Lungs are ventilated.
Continue to CPR.
Massage the heart.
You see?
That's all through his LV. Yeah.
You see that guy had a... Doesn't matter.
I'll show it again.
Yeah, 30 seconds.
That's pouring out. Give it another squeeze, Dustin. Dustin, give it another squeeze. There we go.
Yes, every time
he blows, it just comes shooting out.
Is that in? Dustin, is that in?
Yeah, he got it.
You got it.
All right, so that's a really intense video, really amazing that the family allowed us to share that for educational purposes. Next, we're going to shift gears and talk about pelvic trauma. We've made it pretty far through this conference without really addressing pelvic trauma, so I think it's time for that. And you know, one thing that's really important is that these pelvic binders can be a little tricky to put on, and some people just don't really get it on correctly. So I think we should really focus on that.
Britt, help.
What are you doing?
Is it right?
No, it isn't. So shall we talk about pelvic trauma?
Absolutely. I can't imagine a trauma course without some discussion about pelvic trauma. I mean, we have to talk about it. It's really important.
All right. So I got a case for you. A case I just had.
All right, let's hear it.
And it's a lot. I think pelvic trauma is so complicated. We see it often. So let's talk about how to manage it. All right. So we have a case. I'm working a busy shift and I get a call that a trauma patient's coming in. It was a motorcyclist, hit on the freeway, high speed. Don't know much more than that. ETA 2 minutes. Get the trauma bay all set up, ready to go. Airway stuff, chest tube, cordis, all ready. And EMS brings this guy in. We got an initial set of vital signs that, you know, look okay off the bat. Little tachycardic, 120. And basically the story is that he was on his motorcycle wearing a helmet, hit on the back of the motorcycle, went flying probably 20 feet over the handlebars, complaining about low back pain, pelvic pain. What's your initial just off the bat approach to how you would do the primary survey in this type of patient?
Well, I was going to say, I think he's got a broken pelvis.
I think we're going there.
I think, no, but that there's a couple of really important points here. The first thing is that I'm not so sure that his vital signs are okay, because I'm thinking to myself, if I was sitting there in the trauma bay after, you know, breaking a lot of bones on a motorcycle, I would probably be a lot more hypertensive than that. I might even be, I think I'd be more tachycardic than that too. I'm just saying, I'm just putting it out there that to take a person with this mechanism of injuries complaining about pelvic pain and back pain, and to think those vitals represent stability would be a big mistake. And so I'm suspicious to begin with. And let me tell you something else, is that this is almost easy, this case, because he's coming in saying, I've got a pelvic fracture, which is what we're all worried about. We're worried about that in these motorcycle accidents, right? But you should be thinking about it when the altered patient comes in, right? It's like, oh, they're bringing in someone who's altered after a motorcycle accident. Everyone's thinking, oh, we got a bad head injury coming, we've got a bad head injury coming in. It's like, guys, we've got a bad pelvic fracture bleeding to death coming in. That's the way I want to think about it. So these things go together. Pelvic fracture goes together with major head injury. And so you gotta remember that.
So initially, right off the bat, I know that you like to flip that C and B. How are you just going after the primary survey here?
Well, you know, in most things, not just in trauma, we don't rush to intubate patients before we resuscitate them. But I would say that nowhere more than in trauma management with pelvic fractures was it so disastrous.
Right.
And this is what we used to do. And I was just talking to Chris Colwell just before we started. And we're kind of horrified when we think back to the way that when these patients came in, we never got past A. We would rush to paralyze them and intubate them. And then it was kind of an afterthought that their pressure had just disappeared. They were in pulseless arrest. And it was because they were hemorrhaging from these pelvic fractures. Yeah. And so there's two really critical reasons why you shouldn't rush to intubate these potential pelvic fracture patients. The first one is what we just said, which is that, it doesn't work well to paralyze and intubate anyone who's not got anything in the tank, right? I mean,
You gotta fill it.
You got to fill the tank. I mean, so that's
you drop their sympathetic tone,
right.
they're gonna code.
It doesn't matter we're talking about DKA or
Right.
whether we're talking
Totally.
about trauma, right? I mean, that's the first thing that we think. But this is especially dangerous when it comes to trauma, pelvic trauma, because when you paralyze a patient and you relax that, that pelvic girdle, remember the bleeding in these cases, the hemorrhage that they die from is coming maybe 70, 75, 80% from veins.
Venous, yeah.
And they really dependent on that tone. And so if you don't get that pelvis bound, and we're gonna do a little demo here. You guys are gonna embarrass me, I think, about this, what you've got prepared, right? Then that has to happen before the patient is paralyzed.
So it sounds like we really want to focus on circulation here before the airway, and give this guy blood.
And that's it. And let's go to the blood slide.
Yep.
Show me the blood, because
blood.
That was the other because I only have really two things to say. And it took a long time to learn these things. But the other major thing is that it used to be. And I don't know if this is just in my practice or I think this is most of us, is that there used to be like a pause before we would give blood to a patient like this. And we would pause because, what is the hemoglobin? Oh, look, the vitals, it's still, the patient's 120 over.
Yeah.
At the point when you knew that patient has an unstable pelvic fracture, like, you feel something there, or you're seeing expanding hematoma, or the vitals drop and there's pain there, just anything there.
So much.
You start with blood. With blood. And I think that we lost the battle in a lot of these cases because we were going through some sort of stepwise algorithm when we should have been starting with blood.
I think if anything, maybe we could stop yelling out the hemoglobin in the trauma bay because it is useless. It's not going to tell you if this person needs blood. Their vital signs, their unstable pelvis, that needs blood. All right, so for our patient, we did a primary survey, obviously. Strong distal pulses, airway was intact, breath sounds bilaterally. He was totally with it, GCS 15, answering all questions appropriately. And then when you go to expose him, he's just clearly got a good amount of blood in his meatus. And he also has this pretty impressive expanding hematoma in the right groin area. I mean, it's impressive.
So he has physical findings of a pelvic fracture, right?
bleeding.
I mean, that's what you're discussing here. I mean, you have blood from the meatus, you've got pain there, and you've got an expanding hematoma.
Yeah.
I mean, you're done, okay?
And right off the bat, I hang 2 units of whole blood. And I did get some looks from residents.
You're lucky to have that, by the way, that you've got the whole blood. Not everyone's got that. Yeah, so that's cool.
And we can use it in our male trauma patients.
Right.
So hang 2 units. I did get some looks like, but his blood pressure's okay. And I mean, even if he didn't have that expanding hematoma, he's tachycardic. He's got a bunch of pelvic trauma. You see signs of it. He needs blood.
Yeah, because the other option is you do wait, and then the nurse turns around and tells you, "I've got a 40 on palp."
Yeah.
It's invariable.
Yeah.
It's invariable. So you don't want to get behind the 8 ball on these.
Right. So next we do a quick fast. That's happening simultaneously, and it's negative. How do you feel about a negative fast in this person?
I was kind of hoping it was going to be positive because because let's just say that. If this is going the way I think it's going, and this guy's bleeding and going to become unstable, a positive fast in a way gives me a direction.
Mm-hmm.
I know that I've got a dispo. I know this patient's need to go to the operating room. I'm not so sure that that's a great thing if he has a positive fast, but at least it tells you
what direction,
a direction you're
going
going. Yeah. So fair enough.
I think, though, with a patient with a positive fast, and I know that would be a little bit more helpful in determining where he's inevitably going. But a positive fast doesn't quite answer all of my questions, because you can get a positive fast from, a big liver lac. You could get a positive fast from a rupture to the bladder, and then it's just urine. And if the patient's hemodynamically unstable with obvious pelvic injury and a positive fast, I can't rule out that he's hemodynamically unstable because he has this huge retroperitoneal bleed that I actually don't see. So a positive fast is helpful in trying to get his dispo, but I'm not sure that's really answering my question of where this bleeding is coming from.
That's exactly right. Yeah. So the positive fast, and it basically, this is the way that we go through things, and we do go through things algorithmically. I mean, and this is the way the surgeons think about it as well. First, if we've got blood in the belly, everyone agrees that we're going in that belly first. And we know that some of them are going to be, wow, there's not that much bleeding coming from the liver or the spleen. This is really all genuinely coming from the pelvis. Maybe some of it's even rupturing through, but you've kind of got to go through that stepwise fashion. And that's what everyone is expecting. So, you know, it's not a perfect diagnostic test.
Yeah.
It's a perfect algorithmic test, if you want to think of it that way.
But it doesn't give you the full story of why this patient might be hemodynamically unstable. Because it might not be from the belly bleed. It might actually be from the pelvic bleed. Okay, so we move down, we're finishing our secondary survey, and obviously I'm going down and I'm checking this pelvis, right? And I'm feeling for instability. I know I'm not gonna just rock the pelvis. I don't wanna cause more shearing force and make a bleed worse, but I'm palpating his pelvis, and you know, he actually had a very, physical physique was very similar. He's buff, he's 300 pounds, really muscular, kind of,
And you can't
like
tell,
you,
and you can't tell. Kind of like me.
Very similar.
Buff, 300 pounds,
super
six-pack.
buff. And to be honest, I don't feel much instability. He has tenderness.
Okay,
Do you
so
ever
there's
get
there's
that,
no
that you just don't feel
yes,
it?
yes.
Because
okay, there's no question about it. I mean, there's no question about it. There are times where I was convinced that there wasn't going to be a pelvic fracture when there was in a big person, and you just can't tell.
So we get a pelvic X-ray on this patient, and I didn't feel much, but oh boy, does he have quite an impressive open book fracture.
Are you sure that that's not just a gentleman who's had many, many children? That he just got a wide? Oh, I guess it's that synthesis is a bit. I guess that synthesis is a bit too wide. That's a bit too wide. Right.
So this is what he looked like, and obviously we're gonna bind this pelvis. We put on a pelvic binder, and I think this is a good point just to kind of just quickly review some of the really unstable, obvious pelvic fractures that we see. So obviously open book, that's usually that mechanism where you're in a car, there's this big anterior force on your pelvis and you get this open book fracture. Very unstable, posterior arc of the pelvis is kind of thrashed. Lateral compression, this is when I think like that T-bone injury, straight into your side. Again, very unstable. And then the vertical shear, which honestly,
doing gymnastics.
Yeah, this is after it.
It's like, well, one, like, you jump off of a building and sort of one foot finds the ground and the other one doesn't.
Yeah. And I think in practice, there's a combination of a lot of these fracture patterns, but these are the obvious ones. And for good reason, these bleed significantly.
Yeah.
So I know you want to talk pubic fractures.
Yeah, pubic. And I would say that I would argue, because we're going to talk about this in a second, that it's kind of nice to know that a patient has those massive fractures that you just showed. Like, I'd like to know that, especially if I'm in a small place. But one of the things that I always was confused about, that I want to admit to everyone and I want to tell everyone about, is the difference between the pubic ring and the pelvic ring, which is that, the pelvis has these two kind of like rings looking at you. Those are the pubic rings. And I used to think that was the pelvic ring, but the pelvic ring isn't just those small pubic rings there. It's that whole big circle. And so, there you go. I said it. But basically, when they talk about an open ring fracture, right, that pubic ring is fractured on both sides, but you're looking to see if on the other side of that pelvic ring, on the right side where that iliac crest is and the SI joint, you're looking to see if there's an opening there,
right?
Because that's the corresponding part of the ring. And so that's just something that if you didn't, someone doesn't explicitly tell you, or if you're me, you would know that.
Thank you for admitting.
The bottom line is that the reason why this is so important is that the way I was taught was that you really only had to worry about life-threatening hemorrhage when the whole pelvic ring was open, right? Not so much if it was just, but it's wrong. It's wrong. And it's wrong for a lot of reasons. One of the reasons is that you can have an injury to the pubic ring there that can lacerate a vessel and you can bleed to death from that. Okay, that's
this
one thing.
This shouldn't be reassuring.
Okay, the second thing is that these X-rays are inaccurate, and that these patients that look like they just have injuries, like a fracture of their inferior and superior pubic ramus, they look like they just have that, when in fact what's hiding, and what you can only see on CT sometimes, is a major disruption of that ring that can lead to this terrible hemorrhage.
So this is something I've been thinking a lot about lately. I'm a new attending. I'm just trying to follow the algorithms, but you got to break out of those algorithms sometimes. And I I kind of think the pelvic x-ray can be a waste of time in a lot of situations. And maybe I'm crazy, so tell me if I'm wrong.
I knew we were going to get to this. No one ever wants to do an x-ray anymore.
Well, hold on. Let me. So where I practice, we've got CT scan readily available. And you just said that these x-rays aren't that good and they can miss a lot that you only see on CT scan. So for me, if I have this patient and say he's quasi-stable enough to go through the scanner, why would I waste time getting an x-ray when I can just put him through the scanner? Because what am I going to do with a negative x-ray? I'm not going to rule out a significant pelvic, injury. He might still have that, and I'm not going to know till I scan him.
Well, you're right.
Am I wrong?
Well, no, you're right.
Okay.
I mean, that's the thing, is that you're right. But that's the situation now, of course. Yep. And that's the situation, in our level 1 trauma centers now. I mean, we don't really need that. And we don't necessarily need to have a C-spine film. Mm-hmm. Kenji's certainly not big on them. And we're going to argue about chest x-rays even, and we can use ultrasounds immediately and then we can have them scanned. I mean, but the thing here is that if you don't have a scanner, or if you're trying to work in a smaller place where you need to transfer someone, I think it's critical to have these basic trauma series x-rays, because it can totally change the direction that you're going. I mean, do you really want to have a patient, if you're in a smaller community, and you've got sort of the basic lab, basic x-ray stuff, do you really want to transfer a patient with an unstable, mid C-spine fracture without any inkling of it, without any images, without any, to me, it starts to change the way you manage the patient once you start getting those initial films. That's the way I did it for years. So I think it really is important to get them when you're remote. Totally. When it's going to change things.
But if you have access to a CT scanner, I feel like I'm just kind of wasting a little time.
Yeah, it's a different story. Yeah.
So now we bind this guy's pelvis. So should we bind your pelvis?
I'm trying to stall because this is the part. Do I have to lie on this table? What am I going to do here?
All right. So in this case, we have this started down. I love to put this down before the patient even arrives. Mm-hmm. Problem with that is when they arrive on a spine board, long board, which is another reason why we should just get rid of all those. But
I know you really like that board that everyone comes in on.
Oh my goodness. We could truly, it was designed as an extrication device, use it as that, then leave it there.
Yeah.
So if they're not on the board, we can do this ahead of time. If not, we're going to have to maneuver it around. Right. But this is basically how we're going to set it up. And
the placement is super important, right? You might think iliac crest, hip. That's actually going to make the bleeding potentially worse and not going to stabilize the pelvis. So we want to make sure that we're on the level of the greater trochanter.
Because it is a trochanteric binder, really, not a pelvic binder. So we have a commercial device here. You can use a sheet to do this, and I have many times. This particular commercial device is big, and it's made for big people. And so our model, unfortunately, is not big enough. So we're going to have to fold this. In fact, in real life, you would cut this so that you can actually get a really good seal. But we're going to fold, and we're going to do about 6 inches apart.
All right. Then we're going to take the binding piece, and these orange dots on the side, you're going to line those up on the edge of your fold. All right. And then you're going to take the tab, you're going to pull, not too tight, and then you're going to start to lock this binding down, across, and over.
So we also have the feet in the wrong position here. Some people do the knees. I actually prefer the ankles, the feet, so that that is actually going to close the pelvis and help actually accomplish what we are trying to do, which is close that book and limit the amount of space that they have.
Tamponade. We're going to tamponade. And you're going to put some tape around these ankles and make it so Stuart can't walk away. All right, so to kind of wrap this up, he goes straight to IR. They embolize, I swear, like half the vessels in his pelvis. And he does have a little bit of a prolonged hospital course, and there's some post-op infections, and he definitely goes home with a Foley catheter, but he walks out of the hospital a couple weeks later. One thing that I think it's important to talk about in this kind of case is, what if he didn't stay quasi-hemodynamically stable in the ER? What if he really starts to crash? Like you are given blood, you're doing massive transfusion, you're giving TXA. This is not a place where we can just apply pressure and hold. Is this when are you thinking about Reboa?
Yeah, we need a tourniquet.
Yeah.
We need a tourniquet for this
For the
this area of
aorta.
the body, and and now I think we have one, and we've been playing with it for a while. But I don't think we have I don't think we quite have the data. I want to hear Chris weigh in on his optimism now, but
Chris loves
to me, to me, honestly, how could you let someone bleed to death when you know that you can occlude to me, it has to work. It's like it's just a mechanical thing. And my feeling is, to the extent that we've got some negative data and some not so exciting data, and is that we're not doing it right. We're not doing it right.
I think we're waiting too long. They're too sick by the point we actually decide to do it because we're not comfortable with it.
Yeah, I just think that it's the sort of bleeding theory of death, and the stopping it theory of life, and I just think that it's going to work out for us when we get it technically right.
Chris is coming. Chris has opinions. Let's hear him.
I do. You're going to be surprised to hear. I do. So anyway, awesome talk, and thank you. This is such a great topic for any of us managing trauma for all the reasons you have already said. So a couple things. He went to IR, and that's great. I honestly worry about sending a quasi-stable and even more so an unstable patient to IR. And it's not to take away from our interventional colleagues. It's just simply to say that we know that most of this bleeding is going to be from that posterior venous plexus, and 85% of this bleeding is venous. And there's not a lot you can do about that in the IR suite. And so if you've got a hybrid suite and you've got a surgeon there as well, great. Otherwise, we were doing this a lot in Denver, and some certainly still in San Francisco, where preperitoneal packing for pelvic bleeding will work, certainly as a temporizing measure. Yeah. But you're right. I love Reboa, and I will also admit I don't have the data to be anywhere near as enthusiastic as I am, but I am, and particularly now that we are talking about Zone 3. So, again, quick reminder, Zone 1 is above the renal, the celiac. Celiac to the renal vessels is Zone 2, and then Zone 3 is between the renal vessels and the bifurcation. And so you've got more time when you go into Zone 3. It's not, you're on the clock, but it's not the same degree as you are when you're in Zone 1. And in fact, in some cases, you can even get a couple of hours out if you need it. And as a temporizing measure, as you say, it just doesn't make any sense. If I can't bring that patient to the operating room, which I can't, and I've got to wait for somebody who can, it doesn't make any sense to me. So we're going to do this. And in fact, we can do it with a binder. And if the binder is appropriately placed, you've still got plenty of good access to the femoral vessels. And we're going to put a 7 French sheath in there. We can move it up if we have to, but once you get the sheath in, it's actually a very easy thing to maneuver. And with a very quick X-ray, can confirm it. Some people are doing this by ultrasound, but X-ray is probably more definitive confirmation. And you've got a way to stop that bleeding. And so
it's our tourniquet. It's our tourniquet that we were looking for the pelvis.
Exactly. And it just makes sense. And, Mel was talking earlier, the early data on ECMO was not very good either. Right. And so I'm really hoping that this is turning out to be that, where the early data is not that exciting. But to me, this is the next step.
Zone 1 is dangerous because you have about 30 minutes of warm ischemia to you begin to have visceral ischemic events. Furthermore, if you place that high Zone 1, you run the risk of paraplegia. We learned that with cross-clamping a long time ago. So we try to avoid Zone 1 if we can. The beauty of Zone 3 is that you have virtually endless time. And we've had Zone 3s up for 3 hours and have no difficulty. Now, that being said, as you may know, there's a new partial Reboa device that's being introduced. In fact, we're going to be one of the pilot centers for this partial Reboa. Probably going to start it within the month. That gives us a little more flexibility in Zone 1, but still in this patient in whom you're reasonably convinced the bleeding's in the pelvis, I agree a Zone 3 would be ideal. And I think it's important that we put contrast in the balloon and we confirm by plain X-ray that we're below those renal arteries. Lots of people talk about using ultrasound, look at the metal detectors on the catheter. I don't believe in that. I think we need to have an X-ray with that balloon full to ensure that A, it's in the right position, and B, we've got it inflated appropriately.
And now we have a guest in the studio with us. Stuart has decided to join us, and as you can tell, he is dressed up, and we got the food off of his T-shirt, so he is ready to go. And our next section now, we're going to take just a few minutes and go into some pet peeves of trauma. So, Britt, get us started on this.
Yeah, I mean, we have a healthy number of rants and opinions in this conference, and so I think we should just take a second to kind of go around and say what kind of irks us, our pet peeves in trauma. Chris, what's yours?
Okay, so I have many, and we've talked about some of them already. I was going to talk about how when people report a blood pressure as something over palp and how it's by palpation, but that probably is a little bit too simplistic. So I'm going to talk about the EMS report. And this is something that we heard about earlier and is really important. I think that actually does give us some critical information, even and perhaps most so in our sickest trauma patients. And so I really think it's important to have an organized approach to this. It doesn't take much, a little bit of proactive maybe planning to get a way that you approach the EMS report. And they can come in. The EMS folks are really good at this, and they can give you all the information you need, particularly for sick patients, in about 15 seconds, maybe 20 at the most, and we can give them that time to give us the report. Now, if they're going to go on for 2 or 3 minutes, can't have it. Can't have people coming in the middle of the report and having them repeat or start over. And we really should be listening to this report. Everybody who's going to take care of this patient should have this critical information. It doesn't take long. So let's have an organized approach to it and listen to that EMS report. I think it really is important, and it changes our management in some of these patients. So that's probably my pet peeve, is when we don't give EMS enough time for their report. And then on the other side, when they take way too long to give the report. But again, those are all manageable. Just plan it.
Right. And I think that, you know, even in that 15 seconds, they give you the most important information. And then you say, can you just stay and wait for a second? Because sometimes they have photos or images of what the accident, the scene actually looked like, which can be really valuable in taking care of these sick patients. Okay, Ryan. Pet peeve. Rant.
Man, I have
what
to,
is
it's
it?
so hard to choose. There's
You're
so
on
many.
the spot.
But I agree with that. And this is one of the reasons why I like to get I like to get primary survey done before taking a report. And then you can kind of get things in the right direction and then give them your full attention.
I like that.
For other pet peeves, I think one is not getting manual blood pressures when people first arrive. Getting a machine-driven blood pressure has been studied. It's inaccurate, especially at the extremes of blood pressure. And I think getting an accurate, and then you're waiting and cycling, 4 minutes in, you don't have a blood pressure. And so getting a good, accurate manual blood pressure as your initial blood pressure, I think, is very helpful, because that really helps direct, the course of what's going on.
Good point.
Can I get a second?
Okay, fine.
Okay. One other is I when patients come in and they get gowned immediately, and you're trying to do your primary survey, they're unstable or whatever's going on, you're trying to resuscitate them, and maybe on one half of the bed someone's cutting off on the clothes, and on the other half of the bed someone's slipping their arm into a gown, and then you're like trying to do your exam, you're trying to put a probe on the chest, and just all this stuff is getting in the way. Right. People do that with the monitors too. I don't really care initially with the monitors. They just get in the way. They get clipped from your like your scalpel, your shears. So just getting the patient naked, getting your stuff done, and then putting some nice warm blankets on top of them after.
It seems like a gown kind of goes against the whole expose the patient and look in the armpits and the,
you're fighting against your team to do your thing.
Get it out of there. Okay, Stuart.
Well, I was gonna be the one that said that let's turn this around, and I think that trauma is awesome. What's wrong with non-trauma? Because trauma is the juicy thing that it's really circumscribed. It brings us together as a team, and it's just the most awesome thing that we get to do. But then listening to you guys start to bitch and moan and go on and on, I started to get agitated and start thinking about, that bugs me, and that bugs me, and that bugs me. I'll tell you something that really bugs me. Stable vitals. Vitals are stable. There's no such thing as stability at a point in time. And so I don't like it when people, you heard me allude to that in the pelvic trauma talk, but I don't like the word stable unless it's really accurate. And what is stability? It means that over points in time that we've measured something and we have seen that it's stable. And just because it's stable doesn't mean that it's stably good either, right? It could be kind of stable, but not really good. So that's my little pet peeve.
Asystole is stable.
Yeah, right, exactly. All
Stably terrible.
Right, exactly, right.
How about you,
Do you have one?
Yeah, well, that initial hemoglobin that gets yelled out and it interferes with like everything. You're trying to intubate, you're trying to plan for something, you're resuscitating, and then they yell that the hemoglobin's 14, and you're like, okay,
I don't care.
Thank you. Or mostly when just people are yelling out a bunch of normal things like no nasal septal hematoma, and you're like, okay.
Well, that's just a good point, right? Because if they call out hemoglobin 9 or
that's
hemoglobin
important.
8, then you're okay because that's really but it could only really harm you in the pelvic fractures that we were talking about. I mean, that's really it's dangerous. And we had some other good questions as well.
So there were a couple questions that are coming in on the chat. Actually, a lot of great questions. One was about those pubic ring fractures, and if you just see a pubic ring fracture that doesn't look too displaced, not too bad, do you actually have to get a CT scan on top of that?
Yeah, so that's a great question. And I think that we're generally all on the same page when it comes to the major mechanism. That motorcycle patient, they need CT scans, right? And especially if you see something on the pelvic fracture at all, they need CT scans. Because what we talked about, right, that just might be the tip of the iceberg. It's a screening test for the person in the smaller center that's transferring the big accident, right? That's for sure. Now, when it comes to someone who has a minor mechanism, an osteoporotic individual that falls and they have a fracture, they're not going to get triaged in the same way. It's a whole different ball game. There's going to be time built into that story by definition, right? And you're going to have to, you might actually see stable vitals in that sign. And so if you've got one of those types of fractures in that type of context, I think it would be really doing our audience a disservice for the so many people out there that can't manage all those patients with CT scans and don't have to. Right. And I think it's quite okay. So that's my take on that.
All right, so I'm going to turn it back to Mel because I think he has a trivia giveaway for us.
Indeed, I do, Britt. But let me just tell you this. It's a great giveaway, but sometimes we can't export things to some countries. So if you're in a country that we can't export to, I'm sorry. But we're going to give away some AirPods Pro. That's a good one. AirPods Pro. And here's the question. And you've got to play right. You've got to play fair. No Googling. You can Google anything. So don't. Okay? In which country, I say it in air quotes, did Freddie Mercury grow up? Which country did Freddie Mercury grow up? All right, next up, airway panel. We got some smart people talking about airway stuff. Go.
All right, whoop whoop, ladies and gentlemen, we have the trauma airway panel. We've got 3 absolute fantastic experts. I'm going to introduce them, and then we're going to get into some questions that are a little bit pre-planned, but we might end up going in different directions. I'm Swami. I get to be the moderator, the host, which means I don't have to know anything except be able to read from the sheet that I was given. But we have some fantastic panelists. We have Sarah Krager from UCLA. You guys all know her already, EM Critical Care. We've got Ben Lantzman, who is an assistant clinical professor, trauma and acute care surgery, anesthesia fellowship director up at UCSF. And then finally, we have Matt Richard from Antelope Valley Hospital, also an assistant clinical professor at UCLA. Now, you guys, we have some fantastic questions to get into, specifically about trauma airways. And we're not going to bridge out of trauma. We're going to try and stick there. And we had a little bit of a heated discussion to lead off about problems with ATLS and things like GCS, less than 8, you must intubate. I feel like the rhyme itself is why we say it. And we're going to actually get into if there's any evidence of why we should actually be doing that. So ATLS does give us some guidelines, but it's not necessarily built for the experts. It's not built for places that do a lot of trauma resuscitation. And there is that mantra in place. Why do we have this dogma? And is the dogma sound? Matt, why don't we start with you?
Yeah, so I don't view ATLS as dogma. I view it as actually a really valuable tool for laying a foundation, primarily for 2 groups of people. When you're first starting out, learning, training, just to establish a framework for thinking about trauma patients. And then also for settings where you're not going to see a lot of trauma volume, a community setting, and you need to have a basic fallback position algorithm to go to. But as you pointed out, in a place where there's more volume, you can diverge and customize your care to particular situations. So it has value as long as you don't view it as dogma, you view it as a framework and a starting point.
So let's get to that specific dogma then of the GCS level prompting our intubation. What's wrong with that logic?
So, again, as a basic starting point, it's good, but I think we can all imagine, have seen patients who come in as traumas who are kind of grimacing, eyes are tightly shut, they won't talk to you, but you give them a little nasal stimulation and they yank away in withdrawal. Now, technically, that patient may be a GCS 6, but it'd probably be a bad idea to just RSI that patient and intubate them. That's one reason you have that sort of patient. The other reason is, of course, is that the issue isn't the GCS. The issue is airway protection. And we know GCS is really just a rough guide there. It doesn't accurately predict whether or not you're protecting your airway. So my approach is to assess what matters, which is airway protection. And there's a lot of different ways you can go about that to try to figure out whether you think the patient needs airway protection right away or not. And the GCS is only one small piece of that.
Okay, that makes a lot of sense. And that last thing you said is really important because we're not talking about the patients who are failing ventilation and oxygenation. We all agree if they're failing oxygenation and ventilation, we might move towards intubation. This is specifically for airway protection. Ben, do you have as much of a problem with this as Matt does?
Look, I think that it's an oversimplification to turn around and say, you get some single number on a single test and that mandates a particular action. I think it's helpful, as Matt said, that this is a foundational sort of springboard in which to sort of anchor some basic thinking and concepts that, if somebody's GCS is 6 or 8, it should be a discussion that's had around triggering, are they protecting their airway? Is this something that requires us to intervene? But, I think that like a lot of these things, we are seeing patients at a snapshot in time, a single point in time, and trajectory is very, very important. I'm much more concerned about somebody who came in with a GCS of 14 with a suspected potential mechanism for a head injury and is now a GCS of 11 or 10 than I am about somebody who came in intoxicated that's maybe got a tiny bump and they've been ruled in as a trauma because that's what the EMS system in your local jurisdiction does. And they're otherwise doing sort of things as Matt described, where they're clearly not having airway compromise issues. And so I think that getting that point in time and seeing the trajectory of a patient is really helpful to understand which of these patients are we worried about. And the other thing I think is really helpful is what are you doing with them? Where are they going? What are your local resources? And how does that impact the timeliness in which you intervene? If you're a single provider, single physician provider, the only one with airway expertise in a setting where you need to attend to other things and you're going to have to potentially move away or that patient's going to have to go to scan without your immediate availability, that may change your thresholds on when you're going to intervene, because if they were to deteriorate, it helps them immediately there. Whereas, if it's something in a level 1 center, you've got resources, as long as your arm, you might turn around and say, you know what, we can sit and watch and observe and gather more data and make a decision there.
So both of you guys are giving me really nuance to this GCS 8. Not to consider it or that it can't be a good starting point, but there's a lot of nuance to add in there. Sarah, let me ask you this question. What's the big deal? I have a patient, got a bump on their head, their GCS is 8. I go ahead and tube them. We get our scans done. They go up to the unit and then you extubate them. What's the big deal about intubating that patient just to kind of move things along and say, well, maybe they do have an airway issue. Maybe they're not protecting. I'm just going to tube if they have a low GCS.
Totally. I think that there's this sort of short-term issues and the long-term issues. The first one is that, especially in blunt trauma, it may not be obvious what other injuries you have. It may not be obvious. They maybe are starting to have a tamponade we didn't figure out. They have a pneumothorax that, hasn't turned into a tension pneumothorax until, oh wait, we intubate them, put them on positive pressure, and there we go. So I think that one is just, if you don't know what you're dealing with right off the bat, intubating them may make everything significantly worse, especially hemodynamically, because the first thing you're doing hemodynamically that's going to make things worse is you're cutting out their sympathetic drive, right? So all these trauma patients come in, they're tachycardic, they're hypertensive, and that's because their endogenous little epidrip is going like mad. And so the minute that we intubate them, we cut out that sympathetic drive, possibly before we've adequately resuscitated them to have them tolerate us cutting out that sympathetic drive. And two, once you put them on positive pressure ventilation, this changes their hemodynamics entirely and can prevent a pretty acute decompensation. So that's the sort of short-term things. In addition, if you haven't sort of assessed them thoroughly before you do this, you don't know what other injuries in the neck, in the upper chest, so forth and so on, you may be uncovering by doing this. Then in the longer term, you now send them up to the SICU, or, if they're super full, like we may be at the moment, you now have them in the ED, and now you have this intubated patient that in certain ways can be harder for us to manage. It just takes more resources. We have to make more attention to them, and we can't get a neuro exam. It's much harder to clinically assess for other injuries like, oh, by the way, we didn't notice this developing compartment syndrome because the patient can tell me they're in pain. So all those little injuries that are really important to pick up in that period when we sort of have a little lull, they're up in the SICU, we've sort of taken care of the life threats, but things may be evolving, whether it's a head bleed that's evolving, we need a neuro exam, whether it's other things that may be evolving that I would love to be able to talk to the patient to figure it out. I think all those things cause problems. I think the other thing is that even though this isn't explicitly stated in ACLS, people have this idea that if we're saying intubated GCS of 8, mostly because it rhymes well, the converse is also true, that if their GCS is more than 8, you don't need to intubate. And I think that there's a lot of really good reasons you may need to intubate early outside of just airway compromise with a GCS of 11. And I actually find that often if I have a GCS of 8, but it's somebody they're clearly protecting their airway, and I suspect the reason their GCS is 8 is not because they have horrible head trauma and they may turn into a GCS of 8 halfway through my CT scan. That's one thing. But if I'm like, I think this patient is really, really, really drunk and they're protecting their airway, I anticipate, like you guys were saying, the trajectory going in a good direction, as opposed to somebody who maybe has a GCS of 14, trajectory's bad, now they have a GCS of 11, they're combative, they're freaking out, and I cannot safely do what needs to be done in an efficient way to that patient. I'm often more likely to intubate somebody who's protecting their airway, but who has a GCS of 11 as opposed to a GCS of 8, because they're exactly at the wrong state of activation and consciousness.
Yeah, there's a lot of really great points in all of what you guys have said. And I think, again, it's adding the nuance there. GCS 8 is a good place to start, but just because they're higher than that doesn't mean you don't need to take that airway. And just because they're lower than that doesn't mean you have to take the airway. Now, of course, we didn't even talk about the harms of the actual intubation if you don't do it well, but we're kind of putting that aside and jumping to, well, I can deliver the tube easily, but there are a lot of downstream effects of this. And one of the things, Sarah, that you talked about at the beginning part of that is the physiologic concerns. Maybe we don't have a great grasp on what injuries this patient has, what injuries might make our intubation more challenging. And over the last couple of years, I think we've focused much more on resuscitate prior to intubation, but there are some places where maybe our hand is forced, or maybe our hand should be forced, and we shouldn't be waiting. We shouldn't be prioritizing other things above airway. Let's talk about what those situations are. Sarah, let's start with you. What are situations that you see in trauma where you say, it doesn't matter that the patient's hypotensive, it doesn't matter they're tachycardic, it doesn't mean that I haven't done a full evaluation. We have to intubate this patient immediately.
Mm-hmm. I don't think that there are actually all that many where I would say you don't have a minute to think about this. You don't have a minute to plan. I mean, in general, in airways, I feel like it's pretty rare where truly, you don't have a second to think about this. One of them I would say is when the patient is aspirating. And, whether it is they're massively vomiting and you can't control it just by turning them on their side, whether it is they're just aspirating lots and lots of blood, that is one situation that I feel like you don't really have time here. Both because immediately they're going to desat and so forth, but especially later in the SICU, those are often the patients where if they don't have a lot of other injuries, their other DUI is doing fine, but they massively aspirated, especially if they massively aspirated stomach contents, then we're in trouble, because some of the worst ARDS and lung injury I've seen just in general is patients who massively aspirate. So to me, that is certainly one of the situations in both the short and the sort of intermediate term in their course where I would be like, guys, we don't have time. We just need to do this. But I would say that if you are going to do that, it is much easier if you have other providers in the room, because I'll usually say something like, guys, we don't have time to think about this. We don't have time to further assess. We're going to take the airway now. But will everybody else please be prepared that if everything falls apart, because this is how we discover that they actually are having an attention pneumo that's evolving, let's have the other members of the team ready to act rather than, oh, let's intubate, see what, oh, I guess now everything is falling apart. Okay, now let's get ready for it.
It's definitely one of the dangers, Sarah. Is like you say, I'm going to take the airway, then everybody's attention comes to the airway. Now, in good functioning trauma teams, that doesn't happen, but you can distract from other things that need to be done.
Totally. And if I'm the team leader, I am now out for the count for the moment, especially if I'm taking this airway emergently. I haven't had time to fully assess and prepare. This may or may not become difficult. So if I'm the only one, I'm out for the count. And I would try, and make sure that I have another member of my team and I sort of tap in, tap out. You are running this now. Priorities are this. Please just focus on this. I got the airway. I want you to be focusing on X, Y, and Z, preparing for an emergent chest tube if we need to. Preparing for, did we just reveal tamponade? Can somebody be doing the fast as I'm doing this? And if you see tamponade, prepare to open the chest because that may become an issue.
Right. There's that parallel management. And one of the reasons why the team leader might get taken out is because no matter how high your level of trust is, sometimes you really want to see. You want to see that tube go in. You want to make sure it's being done. If you're in a training institution, make sure that your resident has support. Ben, I guess this brings us to our next question. And I want a simple, straightforward, easy answer. No hemming and hawing. Video or direct laryngoscopy? Once I've decided to do the tube, video or direct?
Well, that depends. No, I'm kidding.
No, Ben, come on, man. You're killing me here. I said direct.
So,
all right,
so,
I'm gonna give you the leeway to add nuance. But what are you reaching for? What should we be reaching for?
This is a very easy question for me to answer. It's video all the way. I think that So I'll divide into two columns. One is the practical task of delivering the tube through the cords. But the second thing, which I think is more important and really underappreciated, is the group situational awareness, the group dynamics that video laryngoscopy enhances. The ability for not just the laryngoscopist, but the entire team to be present for the procedure of laryngoscopy and to be able to provide timely assistance, but also to understand where cognitively they can move on. Like, great, the tube's delivered. Like, we can move mentally on to the next task that needs to happen, rather than everyone's frozen waiting for the yellow humps to pop up on the end title or whatever it is, the color that you've got at your institution. So I think that that's one thing. In terms of actually delivery, I think that, the question about whether you're going to use a hyperangulated blade versus a standard MAC type blade, I think is a discussion that you can have. I personally, in the trauma context, default to a Macintosh shaped video blade. That's my go-to sort of reach for.
Well, that's where we have to go next, Ben. So maybe there's a little bit of a false dichotomy in saying video versus direct, because we have to get the nuance, which is hyperangulated blade or a standard geometry blade. And you've kind of alluded to this already, that your preference is a standard geometry Mac 4. Is that right?
Mm-hmm. Yeah, Mac 4 would be my reach for in majority of adult patients.
And why are you going with a standard geometry over a hyperangulated?
Well, what it does is it provides you with flexibility. So, you're going into an airway which you are uncertain of degree of contamination. You want to maximize your first pass success. I mean, that's really the objective, is to minimize. Intubation is not a therapeutic. It's not a cure to anything. It is a bridge to getting somebody the support they need, the physiological support they need, so you can treat their underlying injuries or conditions. And so, really, I want to maximize my first pass success by doing this. Using a blade that has the flexibility to be used as a VL or a DL enables me to, just lift a little bit more firmly, or if I need to, if they get soiling on the blade, and convert to a DL look without having to swap the blade out. My backup would be the hyperangulated blade, but if you go in primary with a hyperangulated blade, you get a bit of sputum, bit of vomit, bit of blood on it, and then you're taken out. You're coming out, you're having to clean the blade, you're having to start again. And I think that delay, while not common, is still enough that it defaults to the standard geometry.
Matt, I think we all know, if we put 20 emergency physicians, traumatologists, however you want to get that group together, and ask them what's the best approach to airway, you're going to get 20 different opinions. What's your approach? What is your preference? You have a trauma patient that comes in, you're at the head of the bed. Are you reaching for hyperangulated? Are you reaching for a standard geometry blade? Or are you going back to the old school and going straight up direct laryngoscopy?
So I think the best technique is the one you're best at. And I think, the science on this is I don't think is terribly clear. There is some science to suggest that video is superior, although I think that ends up when I've looked at these papers, they're often in settings where video is a technique that has been used for years and is the preferred training technique. So I think the best technique is the one that you are most comfortable with, that you have the most experience with, and that you're going to have the most confidence going to that airway with. So my own personal experience, 20 years, over 1,000 intubations myself. There have been 3 or 4 times over 1,000 intubations where I have not been able to intubate with DL and or bougie. And of those 3 or 4 where I had to go to an alternate technique, got the airway. 2 were crikes. 1 I actually went really old school and did retrograde. It was like 15 years ago. And then the most recent case, interestingly, was one I had with Sarah. It was a laryngeal fungating mass. And she was right there at the bedside, had the video, and used her expertise to get that done. So yeah, that's my approach. The technique that you're best at. And I think in many EDs across the country and around the world where community providers are experienced and expert with DL, that's the way to go. It may be that 10 years from now, because residents are being trained in VL, that no one's going to be talking about DL anymore. But for now, right now, in real time, use the technique you're best at.
All right, Matt, you mentioned something there that we're going to get to next, which is the bougie, because you're saying 20 years experience. That means you probably didn't train using a bougie, but you're saying that it's part of your standard approach. Should it be part of all of our standard approach to go bougie first? Almost like a Seldinger technique, right? Deliver the bougie, deliver the tube over the bougie.
So what I do is what's fastest. So my approach, if I'm going RSI, so I'm going to paralyze, I'm doing the fastest approach. So that for me is DL. I take a quick look. If I see wide open, easy chords, I put the tube in. I don't use the bougie. Wide open, easy. If I take a quick look, immediately, I don't see precisely, clearly wide open, I'm going bougie, tube over bougie. So because that just gives me the fastest access. Sometimes it is faster just to pop the tube right in. And frankly, that's probably 80%, 90% of the time. It's 1 in 10 that I'm grabbing the bougie because I don't have just the perfect ideal view. And then the bougie just finishes the job right there.
Now, Ben, you're training residents, I'm training residents. Many of us are in that situation where maybe we're going to be teaching something different than what we might always do. Let's talk about the bougie. Many of our listeners are not training. They're not training others. Should they be learning to use the bougie if they're not doing it already? If it wasn't something they trained with originally, does it really improve our performance in trauma situations?
Well, I think it's a very, very useful device that's, I think it sits in that nice sweet spot with getting you out of a lot of trouble, being flexible to use in a lot of different clinical scenarios, and being very cheap, relatively cheap and cost effective. So the barrier to actually deploying that in pretty much any institution, I think, is very, very low. With that in mind, I think it's I don't know what tool you would use that would replace it for the grade 3, grade 4 view where you're trying to get past and you don't have a view of the chords and you're not. So I'm not sure what you might try outside of a surgical front of neck airway, which, look, it's a legitimate solution. If, as Matt said appropriately, you should work within your skill set. And this is not the time to play around. This is not the time to try something new or different. This is something you got to go with the tried and true. So if you get a view that you can't intubate and for you, the best thing is to cut the neck, go for it. The important thing is to get that airway and get that alveolar oxygenation going. But in terms of training residents, I've had some sort of interesting philosophical discussions. Obviously, I train the anesthesia residents, but I also the EM residents rotate through our department at our hospital. And, a big discussion of like, should they be investing their limited time in the ORs, getting an opportunity to do airways in a controlled sort of elective context? Should they dedicate their clinical exposure to learning a couple of techniques over and over again and developing some degree of expertise or proficiency in, let's say, 2 or 3 techniques that would cover 99% of the clinical scenarios in which they're going to come across? As Matt said, almost all the airways are basically DL, and the bougie has basically sorted everything out. Or should they go and have a go at everything so they have the breadth and spectrum? And I think it's a philosophical discussion that's not yet settled yet about what the right approach to serving patients in your future next. Like, what's that patient 10 years from now going to be served best? By you getting an extra go at doing some weird thing, intubating through some light wand or something like that crazy stuff that people doing a blind digital intubation, ridiculous stuff that probably has no place in routine clinical practice these days, but is interesting history book stuff? Or should they be going and making sure they get an extra glide intubation, or to do a bougie, or to do an extra manual inline stabilization, to do something with poor visualization and making things a little bit more difficult?
Some really good points in there. I'm sorry, Matt. Some really good points I just want to reiterate because, Matt said he's got 1,000 tubes over 20 years, which I think makes him an expert in emergency airway management. And we are experts in our situation, but 1,000 tubes in a year is what a lot of anesthesiologists are looking for, or even more, depending on your volume of practice. And so, yeah, I think that's a really good point, Ben, of we have to stress to get maybe a couple of techniques that we are really, really, really good at so we can bring those options to our patient. And I'm sorry, Matt, go ahead.
I just going to make the point distinguishing how you approach the airway in a residency training situation versus a personal practice situation. So at our institution, we are the primary community training site for UCLA residents. They come to us to get the majority of their procedural training. And so we'll have a resident, I think the record was she did 30 intubations in 1 month. What I noticed is years ago, as I would see the residents with a bougie in their back pocket, and I'd say, I see you have the bougie as your backup, that's great. How many times have you used that? And the answer was, well, I haven't had to yet. It's like, well, let's stop that now. So from a training perspective, I have the residents do bougie first every time. I have them use the bougie as the first pass. I don't use the approach that I use in my personal practice, which is tube when it's clear and wide open, because I want that resident, when they do have a difficult airway, or if they choose to go bougie first in their personal practice, I want them to absolutely have that down pat, 100% confident. And so I train them differently than my personal practice.
That's such a great point. If the first time you're reaching for a bougie is when you have a tough airway, you're going to be in a bad place. You got to get used to using that device. And Sarah, I have a question for you about the bougie before we move on. We got some great cases to get into, but let's talk about the bougie. In trauma, is there any place where I shouldn't be using a bougie?
I think that if you have no idea what you're getting into here, and you're having trouble with visualization, you're not sure what you're looking at, and if it's a blunt traumatic airway, if it's a penetrating traumatic airway, and I'm going in blind-ish, in a way, blind bougie, I mean, that's what it's made for. That's what we're trying to do with it. That being said, if I have no idea what I'm looking at here, I'm a little bit worried that the bougie may get into something I don't want to get into necessarily, may create a false passage. So, what I will sometimes do if I really don't know what's happening here is actually do a finger first. Like I've gotten pretty comfortable, and I started doing this when I did a ENT rotation when I was a fellow, and just all of those very complicated, you have tumors, you have who knows what, and feeling what I'm doing, because I'm not going to accidentally get into something that I don't know with my fingers. I can sort of feel what I'm doing, and sometimes I'll go that way first pass. So I would be a little bit concerned about it that way. I have to say, for me, I'm sort of with Ben. I like having the option of video. I personally prefer the CBAC because then I can, switch back and forth. I can do whatever I need to do in a maximal flexibility. But, I think the other thing that's helpful about that is that for the scariest trauma airways, the one where the anatomy is distorted, we don't know what we're looking at, I might use video first pass after suctioning to sort of clear all that stuff so I can actually see, because it gives you just a bigger picture scope view of the anatomy. And I find that it can be easier to orient myself if I can step back, so to speak, have a bigger picture view. And in a way, it's like the same as ultrasound. Find something I know, latch onto it, and then go from there. So I find in those situations, I'm more likely to use the bougie, even with some airway distortion potentially, when I'm doing VL, because I can feel much more secure that I'm not accidentally threading that bougie into or through something that I don't want to be.
Yeah, that's an excellent point. And, I think one of the other points you brought up in there that almost might get lost, and let's just reiterate it, is if you have a soiled airway, lead with your suction first before putting that laryngoscope in and getting that camera soiled. And, Jim DeCanto talks about this often, the salad technique of intubation. And I love this because I always do it now. I can't remember the last time I had a soiled camera because I'm leading with my suction first, and, having a large bore suction catheter helps. I'm sorry, say that one more time.
As long as you got a big enough suction catheter.
Yeah, so you got to have that large bore, right?
Yeah.
If you got a Yankauer suction, you're not clearing anything out of that.
For you.
That's a great point. And, Jim has this great story about how one of his impetus for doing this was EMTs telling him about how they picked up a patient who had a cardiac arrest after eating beef stroganoff. And let's just say it was very difficult to navigate that airway with a Yankauer suction, which ain't doing anything. So you're right. If you have a large bore suction catheter, that can really help you to clear the airway as you bring in either your direct laryngoscope or your video laryngoscope. your standard geometry or your hyperangulated. Leading with suction makes a lot of sense. Now, I do want to get to these cases because we put together some interesting cases to dive into where, again, I think there's going to be a little bit of some differences between the experts of what they want to do. Let's get into the first one. And Sarah, we're going to start with you on this one, and then we'll move through, and then we're going to go the other way with the next case. We've got a patient who's got a stab wound to the chest. You've already ultrasounded them and you identify the patient has a large pericardial effusion. There does seem to be some signs of tamponade, including the blood pressure of 72/40, the tachycardia of 130. The patient clearly needs to be intubated. This isn't where we're trying to hem and haw. Maybe I don't have to, maybe I can. We have to intubate them. Here's the question. If this is a trauma patient, are you going to do a thoracotomy while you're intubating them, do the thoracotomy and relieve the tamponade, then intubate them? What's your order? And are you waiting to do the thoracotomy until the tube is delivered? There's a lot of questions in there, but let me just ask you, what's your approach when you have a tamponade and you know the airway has to be controlled?
Yeah, so this is one of those situations I think you have to have a parallel approach. Now, the nice thing is that if you're in a single shop and you don't have any support at all, and there's not a trauma surgeon there even, then it's questionable whether you're doing a thoracotomy, period. So I'm kind of making an assumption here that you have at least one other provider at the bedside to be helping you out. And I think you got to do a parallel approach here that's coordinated between the two different teams. So if I can, I have one person focusing on the hemodynamics, and I'm just like, go nuts with the blood, rapid transfuser, fluids, because that's going to buy me this little window of time where we can be working in parallel, if not completely synchronized. So I have one team just move on opening that chest. Then I have the resuscitation team going nuts with the volume, just get as much volume in there as soon as you can, as fast as you can. Then I have the airway person, and ideally, because you know that the minute that tube is in with positive pressure, you're going to be in trouble. That being said, what I will often do is it's the positive pressure ventilation that's going to kill you with the tamponade, literally and figuratively, I suppose. It's not the putting in of the airway itself. So I get started on taking that airway, protecting the airway, getting that patient induced and paralyzed and sedated so that they can do that. Then what I will sometimes do is get that tube in. And if they're not sort of getting into the chest right this second, and I have room with my oxygenation, sort of hook up the bag, get ready to start bagging. But if I have an oxygenation moment, try not to start aggressively bagging until they're getting into the chest. And so sometimes if I need to control that airway, get the tube in right this second. And then if their CO2 goes a little up while I'm not bagging, okay, better than having an arrest. So coordinating with, they're now in the chest, now I start bagging. If they're not in the chest yet and you've intubated, you have the tube in, you don't have room with your oxygenation to not start bagging aggressively immediately. Try and be a little bit gentle here. A PEEP fab is maybe not the best way to do this. And bagging at 75 a minute is probably not helping you at all with your hemodynamics. And so just being thoughtful and really focusing on the fact that it's not the actual putting the tube in the trachea that's causing you a problem. It's the positive pressure ventilation that's causing you a problem. And I think between recognizing and being thoughtful about the timing of the positive pressure ventilation, with having somebody who's aggressively volume resuscitating, you can buy yourself a window of time where you and the team who's opening the chest are working in parallel without having the situation completely hemodynamically deteriorate.
So that coordination from teams is clearly important. Ben, here are the things that kind of pop up in my mind as I'm thinking about this. It's going to be hard to do a thoracotomy with a non-paralyzed patient. If the patient's paralyzed, I got to protect their airway. I got that. And I like the idea of pounding in the blood products, trying to get that blood pressure up, but we're kind of assuming that there's some kind of a defect in the heart. And so I'm just pumping the blood in and it's just pouring out. At some point, you get that vicious cycle of, I got to take care of that heart. Do you have a preference of how you approach this or what you're doing hemodynamically? Would you ever reach for vasopressors instead or in addition to blood in these circumstances? What is the best approach here?
Well, a couple of things just to build on what Sarah said is, obviously with a little bit of an anesthesia hat on, we're all interested in definitive care, getting the patient to the place where we can do the most definitive care for them. And so I try to avoid intubating these patients for as long as humanly possible, and almost until they literally arrest, because as Sarah eloquently explained, it's as soon as you do that, you're basically creating that, you're lighting a fuse on them about to code. And so the most successful resuscitations I've done with patients with traumatic tamponade have been the ones where we've got them to the OR or even in the ED, but actually just done under sedation, essentially like a subxiphoid pericardial window, evacuated some of the blood, or at least decompressed it a little bit to give us enough time, give us enough buffer to then get the tube in a bit more safely, to not be able to flood them. Because the whole issue with volume and vasopressors is that you're dealing with an obstructive shock picture. So it's not necessarily a hemorrhagic shock. Now, if you've got a hole in the heart, it'll very quickly turn into a hemorrhagic shock picture once you decompress that. The case I'm thinking of before had a nice hole in his LV right through his diagonal. And so it was a mess. There was arrhythmias. It was a big challenge, but we got him through. 18-year-old guys tend to do very well with these sort of cases if you can get to them in time. And so, my priorities are you do what you need to do, volume, but then I tend to do small titrated doses of epi as my first line pressor in these contexts. So, you want your increased contractility, you want your improved vascular tone. And so I'm looking at 10 to 40 mic boluses of epi. So really quite small aliquoted doses. And the minimum amount you need, once again, we're not trying to aim for normal physiology in these acute resuscitations of trauma. We don't want to get these people back to 120 on 80. I'm happy if their maps are 45 or 50. If that's where we're at, that's fine for this window while we're acutely resuscitating them, getting them to the place where they're definitive, getting the better access, getting the massive transfusion blood arriving and started, and really doing all those things. It's really this hyperacute sort of first 10, 15 minutes is buying you time to get the resources mobilized, to get the lines where they need to be, and to get the patient to the place they can get definitive care.
Now, Ben, I just want to clarify here. You're running that epi while you're running blood, or you're running that epi because you're waiting for blood to come?
No. So this is in, so sometimes despite your, because at the end of the day, like you said, you're assuming in this context, it's either a significant blunt trauma or a penetrating trauma to the heart. And often these ones are penetrating traumas to the heart. So you're pumping blood into the patient. Well, the more blood you pump into them, the more leaks out into the pericardium. And so you're still on a watch. The tamponade is eventually going to get to the point where they will just not be able to pump anymore. And so you can't just keep doing blood ad infinitum. But once I'm finding that my responsiveness to the blood is not keeping me in my sort of hemodynamics where I want them to be, I'll start introducing presses. Also, obviously, around peri-induction, I tend to also do presses as well for that. These are the patients where they're very hard to get back once they code. And so the objective is to not let them code in the first place.
Ben, I've asked this question of other trauma surgeons before. I'm going to have to ask it again, and I'm hoping I'm going to get a different answer, or maybe I won't, but I think it's a good one to address. You've got that patient who's soft blood pressure, very tachycardic. You're setting up to take the airway. You are thinking you're going to get to a thoracotomy. Is there any role for doing a pericardiocentesis while you're waiting to get those things done, or is that just a waste of time?
So I think that it's all around, you want to keep your eye on the prize. You want to do nothing. You want nothing to get in the way of definitive care. So if it's going to slow you down, it's like the whole thing of, I'm to the point where sometimes, if putting the monitors on the patient is going to delay us getting to the OR to give them the laparotomy or the definitive care, I don't care. I just put a finger on the pulse and let's go. That's not the thing that's going to save their life. Whether we get 3 lead EKG on for the transport, somebody hold the pulse, let's go. So I think that anything you can do to decompress that tamponade to some extent, that's not going to delay all of the other interventions that are actually the life-saving interventions, because that pericardiocentesis in the context of trauma is probably not going to be life-saving. It's just going to be time buying. I wouldn't do. But if you've got I'm waiting for the trauma surgeon to come in from home, or, I'm waiting for somebody to get the OR opened or whatever else. Or you're like Sarah said, you're in a single provider shop and you're waiting for all the cavalry to come in, it'll buy you time for sure. The concern you have is that if you do have a major chamber injury, you are just taking a pressurized, low flow bleeding situation and basically running a tap to the outside world. And so it's not just you put a drain in, it's like out it comes until the whole cardiac, the whole circulating volume's on the floor. So
Yeah, and of course, one of the challenges here is, I don't know about everybody else, of course, I can get a pericardiocentesis done in about 13 seconds. Very easy to deliver that catheter into the right spot. And I think that's one of the challenges. We can say a pericardiocentesis might help, but the amount of time that it takes is never as little as you might think in your mind. Matt, we've kind of addressed a lot of the problems around here, but what are other things that you might be thinking of or you are thinking of when you go into a situation like this? Pericardial tamponade, patient needs an airway.
Sure, a couple other thoughts. I think Ben and Sarah really covered the issues nicely. One point is the difference between medical and traumatic pericardial effusion or blood. In a medical pericardial tamponade, very different situation. In that setting, pericardiocentesis can be much more effective, right? Because you're going to take the fluid off, it's not going to reaccumulate immediately, and you're not going to be dealing with clots. That's the other issue. Clots can often impair your ability to aspirate. So that's one consideration. Take home is that very different situation, medical versus traumatic tamponade. To me, the biggest mistake that can be made, and I think Ben and Sarah covered this nicely, is not falling prey to the momentum and the impetus to intubate this patient on arrival. And I can tell you, in the community setting, in a real life situation, this patient comes in, they look like crap, they look like they're going to die because they are, and there will be a tremendous amount of pressure from your trauma team, potentially, everyone involved, to intubate the patient. And in fact, they will look at you incredulous as to why you're not intubating the patient, what's wrong with you. You've got to get the airway, and it's hard. You've got to stand back and recognize you've got to optimize the hemodynamics first. If you don't, you're going to be doing CPR sooner than you would have otherwise, although that may be coming anyways. So that's the key point here really is one of psychology, is just resisting that temptation and the pressure and doing everything that Sarah and Ben pointed out.
That's such an important point, because we're saying, I gave you the setup of this is a pericardial tamponade, but we have patients who come in hypotensive and tachycardic, look like crap, and it's tension pneumo. And if you identify that and decompress, you might not have to intubate the patient at all, right? And if you intubate them while they have a tension pneumo, you can cause some bad outcomes, as you alluded to. So yes, you're right. Sometimes we got to slow down. You know, we've heard it many times on EMRAP before. Slow is fast, and fast is smooth. And is that the right? Maybe that's not the right one, but the point is slow is smooth and smooth is fast. That's what it is. So we sometimes have to slow down and take our time. It might just be a couple of seconds to really think through the case. I want to thank all of you guys. This is a great trauma panel. I wish we could do it live and in person, but we're going to get there eventually. I'm looking forward to meeting all you guys and doing this at some point all together. But Ben and Matt, thank you guys so much for joining us. Sarah, thank you for joining us too. And I think that's it. That's going to wrap up our trauma panel for the trauma conference. Thank you guys very much.
That was great. Thanks.
Thank you guys. Take care.
All right. Another quick video, and then we're going to go into happy hour, and we have a lot more discussion in happy hour in a little bit more laid-back environment with some other faculty. But this video is very much like the thoracotomy video, very rare. So let me give you the story here. So large trauma center, over 20 years ago. I am coming off shift, but I am hanging out for a while, doing some videography and doing some patient interviews. And then we get the call, patient's coming in, gunshot wound to the face, and then he presents, and they start to do their assessment. They decided they're going to take his airway. Gets paralyzed, and then the fun starts, because the extent of the wound is then revealed. And basically his jaw falls off and his face falls apart. And as you'll see, they have a very difficult time getting the airway, which then leads into a crake in real time, videoed, and not as pretty as you'd like, but that's how it goes sometimes. So let's show this quite amazing video.
Hold my neck. Got it. All right. Yep. You want 150? I need a bag. Yeah, 150 sucks.
He hasn't gotten his paralytic yet.
I know. All right. I can't hold Craig. Somebody's got to hold Craig. Pulse socks. Look up the pulse socks.
Giving Craig pressure.
Okay, give me the tubes.
There's the 8 right here.
you grab the corner?
Great, you're in the high 90s.
No.
Put this in.
Need more blood on the
Okay, bag them up.
I gotta suck them on. Dave, just bag my blood.
Okay.
Pour it in there and I lost it. Do me a favor, Dave.
Stop bagging up too.
Call 7202.
You might not get it. You got 100% O2 set.
Bagging's not too good.
Okay.
Just do it. Just do it.
That's right. All right. 100% still. You see the...
You want burp?
Burp, please. Oh, now I lost him again. Now I'm burping.
O2 sat is 90.
There it is. Okay. Okay. You do see the cords?
I do see the cords.
The button all the way on the left. I mean, that one. There you go.
It's not moving through. I need a tray. Just give me a Kelly. Sammy, we'll need some light. Come on, we.
All right. Put it in. You got it.
Stick shyly.
Give me the stick shyly.
Can you feel the cricothyroid membrane?
I'm through.
Okay, I've got no gloves on.
I'm through right there.
Okay.
2%, spread it wide.
How do we get this?
Crank up.
Is this station for somebody else?
I'll take care of the tank.
What?
Yeah. Got the
Okay.
Hold on, we just need to get the blood out.
Let me get in there.
The focus that close.
Give me the 2, Charlie. You did? I'm sorry, man. I see it.
Did RT ever answer back?
You did a good job.
Do you want the other case? Page and stat.
Syringe? Do we have a syringe?
We need a 10 cc syringe.
Right here.
All right, bag here. Give me a bag. The bag is right here.
Hold on. We gotta get this out of the.
Okay, I don't have gloves.
Have a listen to somebody.
We got color change.
You can get that tray off and belly.
Hook up the pulse ox, please.
Good sounds on the right. Good sounds on the left.
Good job. Green left, please.
I disconnected it.
Pull it off.
Again.
All right, guys. So we made it through the first day. Woohoo! And we have made it to happy hour, which is the best hour. We've got beers, we've got wine, we've got all of our amazing faculty, we've got Pepsi. So let's celebrate the first day.
Yay! So great job today. There's still some outstanding questions from the day. So Britt, do you want to run through a few of those puppies?
Yeah, there were just this conference generated a lot of questions and conversations. It was just so awesome to see everyone from all these different states and countries. Maybe I'm gonna this is group, but maybe more at you know how much he loves Raboa. So this is a question. Will placement of Raboa be difficult or dangerous in severe pelvic crush injuries due to vascular injury?
I think you should want that Sarah to answer this one. Sarah, that's up. Did you say Sarah? Let's have Sarah answer it.
Sarah, Chris, whoever.
But I'll hear Sarah's thoughts and I'll jump in.
Okay, and Sarah, I think you're on mute.
Sarah's muted.
Sorry about that. I think it's a cost benefit thing. I think that hypothetically, you could hypothetically end up in the wrong place. However, again, keep in mind, ideally, you're not doing this blind. You're doing this with X-ray guidance, hypothetically. But also, cost benefit. If your patient is bleeding to death and you think that they're going to bleed to death in front of you because you can't control the bleeding, then I think your cost benefit is in favor of doing it. Because I think the likelihood that you're going to end up in the wrong place is low. And so if I really believe that my patient needs it, then I would do it. Because again, the likelihood of something very improbable happening versus the likelihood that my patient who's bleeding to death in front of me is going to bleed to death, for me, cost benefit comes clearly. But Chris, what do you think about that?
Yeah, I completely agree. I think, when I trained, we were concerned about putting femoral lines in pelvic fractures. And I think we've successfully debunked that issue. And this is along those same lines, is yes, a severe crush injury that shatters the femoral vessels. You could argue is that going to be survivable anyway, but it is such a rare injury, whereas bleeding pelvic fractures that bleed to the point of death is rare, but certainly more common than that. And I think that your chances of getting into big trouble with that are very low. I would do it, and I agree. The benefit in this case outweighs the risk.
Yeah, you could. I guess you could say that if it doesn't work, that's why they died, right? I mean, yeah. So
but not because of you.
Yeah, I think, yeah.
Brett, you're muted.
Brett, you're muted. This is like COVID times again. It's just so painful.
It's so weird. I never use it. It's like I'm never on Zoom.
Yeah, it's really nice to know that after a year that we've all become really, really sophisticated. But yeah, really nice.
I would say one other thing about the Reboa is, and I said it before, I don't have the data to back me up, but I just think that Reboa in zone 3, which, and as we remember, is below the renal, above the bifurcation. It just makes sense that this could be the answer to pelvic fracture bleeding management, at least from a temporary standpoint, and particularly for our emergency physicians that aren't going to be able to operate and aren't going to do peritoneal packing. So I don't have the data yet to support that strong opinion, but I just believe that ultimately when we really get good data on this, it'll show it. Maybe it's wishful thinking.
No, but I think Reboa is going to be like ECMO. Like at first, the data on ECMO was really, really bad because we didn't know what we were doing and we didn't know how to do it. And now in centers that do this all the time and we really know what we're doing. So for example, our mortality rate at UCLA of COVID patients who ended up on ECMO, the mortality rate is about 35%. Now, in the initial studies of ECMO for any patient, let alone complicated COVID patients, that would have been an amazing mortality rate. But now we know what we're doing. And I think it's going to take us a while to figure things out with Reboa. And I think that personally, I think that the best use of it, and maybe the only use that's going to show up evidence-based wise, is zone 3. I think zone 2 never makes any sense, pretty much. Zone 1 is really dicey. I think if you think you need zone 1, just go to the OR immediately. If you don't have a surgeon, do a bedside thoracotomy and hope for the best. So that's my personal take.
I think Stuart agrees.
I was going to jump in and say, I'm very concerned that the data so far are negative. And so to me, that means this should still just be used in university centers and these patients should be studied. And the argument that we're going to get better at that is a powerful one. But for example, when there was first renal transplants, they were ridiculously expensive. They were like $2 million a patient. Now it's way cheaper to do a renal transplant than to have somebody on dialysis. So we're still at that phase, but this shouldn't be something that people out there in the community are like, am I not practicing the standard of care if I don't get Reboa? No, you should not be doing it. Let the universities work this stuff out, work out the techniques. But there are already devices that are becoming more and more portable. So this, by the time we get done with it, will be something that I think every emergency department will have. If it works, I'm not sure, but maybe.
Yeah, I was going to say that Mel and we have an upcoming interview with a surgical inventor, don't we, that was working on something that he thought might change the dynamics here. And so maybe to a certain extent, it's the procedure, it's the equipment, it's the technique that because I think the physiology is on our side for the person who's dying of a pelvic fracture. I think it's on our side. I think that we got stop bleeding here. So I'm still going to be optimistic. And Kenji also promised me that it's going to pan out. So I have that inside track.
When Kenji said it's going to pan out, definitely will.
He said, yeah.
I think the other thing that's going to happen with especially more rural centers, as we get better at this with the zone 3, what I've heard anecdotally from surgeons in the best course and surgeons who do this frequently and then go to the OR or IR is because, as somebody said, pelvic is often venous bleeding. Like it's much more rare that it's arterial. Like often you just have venous bleeding everywhere. And because you can leave up the zone 3 balloon for so much longer, what they're finding is often by the time they get to OR or IR, the bleeding stopped. And I think I'm just remembering, in Haiti when we had multiple young people die from pelvic bleeding, like they just died from pelvic bleeding. And so I think in a situation, even when you can't get them to OR or IR immediately, like in that situation, a zone 1 makes absolutely no sense, but a zone 3 might, because you might be able to fix them with just leaving the zone 3 up for a while.
Totally agree.
Right.
Chris, we'll find something to argue about later. I'm sure we can find something.
We have plenty, I'm sure.
Test tubes, probably.
You guys probably saw in the comments on that Craig video how we were all freaking out because the practitioner was not wearing a mask or a face shield, and that seems a little bit naked then, but now in the era of COVID, it just seems drastically naked with your nose in somebody's mouth.
I wonder who that guy's program director was. That he should be held responsible.
Yeah.
Yes, indeed.
Another good question, and anybody can weigh in on this. This was from the app. Was in a setting where CT access to CT is limited, like in low and middle income or low resource setting, is there a role for observation in a patient with penetrating neck trauma but no hard signs? And we discussed this a little bit, but maybe Chris Stewart, you want to weigh in on that one?
Go for it.
We said yes.
We said yes, absolutely. I think even in a resource-rich setting, there would be times when you wouldn't need a CT and you could observe these patients. Absolutely, when you're in some resource-stretched settings, this is a very reasonable approach to take. And as you say, without hard signs.
Got to use physical exam. Got to repeat exam. Got to yeah.
So Chris, when we're doing the pan scan, you're saying don't do the neck, just take that part out?
Just that, so that's not part of the pan? When you scan, don't pan the neck.
Oh, I've got this, and it'll help.
I don't think we had any more questions from there. Anybody else have?
Anybody in the YouTube chat want to ask some questions? Because we don't want to have dead air. So what are some of the things?
We got a lot of alcohol waiting for us downstairs. I heard. Is that true?
Yes.
Tremendous amounts of it.
There is a question from Ev and regarding teaching the transverse incision and then longitudinal for the crike. And is that still what we're teaching? And is that how you guys do your crikes?
I don't know what people are teaching, but I still find doing this longitudinal incision and then feeling the cricothyroid membrane and then penetrating through, I find that's the best way. I've done about 6 or 8 crikes, and that's probably 6 or 8 too many. I should have learned to intubate better, but it seems that you can get pretty good at it doing that.
You didn't have to.
Let me put in my 2 cents. How many times have you heard the expression the crike is a tactile procedure? How many times have you heard that? Right? We've all heard that a million times, and that's because it is. And for people that have generous necks, I just don't see any other way to do this other than make a nice, generous incision down, and then's when you start the tactile part of the process. You do the midline. I would do midline incision even before my major feelage, to be honest with you. If I have a big neck and I don't know what's going on, the incision first, and then I'm tactiling it. And so I think it's critical to get that first incision being a generous one from top to bottom. And just let me add the one more thing is the commonest error, because I've done it myself and I've seen other people, like the first time you're doing this and you're sweating all over the place, is to be too high, right? Is to be above where you're supposed to be in that, because that notch feels the same. And so those are sort of my two points on that.
Yeah, I can't imagine if we're doing it. The only time I would see a horizontal incision is when you're in the operating room in perfect conditions and you're really worried about a scar tissue and you're in that kind of a situation where you can avoid it. We're never like that in the emergency department. So I would say that when you're going to do this, you're going to do it vertically every single time for all the reasons that they've said. And Mal, the reason that you had more crikes is because we practiced in the time before the bougie. Once the bougie came along, no more crikes.
Well, and I don't know how much history we care to get into, but remember, we did 1 million crikes because ATLS in the beginning tied our hands, right? Told we couldn't give drugs, we couldn't, the C-spine fracture meant that we couldn't intubate them normally, and we learned all those things. So
You know, I love the expressions on Sarah, Britt, Ryan, and Jess's face. They're all looking at us like, what are you guys talking about? This is that long ago. This is like foreign language to anybody that's practicing now coming out.
They used to flunk. They used to flunk us in ATLS if we gave Haldol or something like that. You know.
DPL. This is the time of DPLs were common as well, I'm assuming.
Mm-hmm.
Yeah.
Time of the DPL. Yeah. And it was like a big thing, like whether you can read the newspaper through it or not. And then what kind of newspaper was it, like, you know, the Globe and Mail or the Washington Post? And it was, very difficult time.
There's a good question in here that I would like somebody to answer. I'm just going to turf it to Chris first. So if you've got a trauma patient, they've got microscopic hematuria, their CT is negative with contrast, do I need to do anything else, or do I just leave it alone, be done?
I guess I'd ask the question, why did we get the CT in the first place? But assuming that there was a good reason to get the CT, because microscopic hematuria by itself, I would suggest is not an indication. We talked earlier about that. And yes, if you've got something else on exam, some other injury, other issues going on, absolutely. But just simply the finding of microscopic hematuria shouldn't indicate a CT. But now the next step is, so negative CT, go home. And I would say yes, with the one caveat that I would, and then maybe this is overly conservative, I would have them follow up with either their primary care doc ideally, or if not, come back here and just make sure that that microscopic hematuria has ultimately cleared. And I'd give it, 3 or 4 days, assuming no other symptoms, to do that. But I don't know of any people that suggest you need to be more aggressive in that setting, and particularly with a normal CT.
Yeah, and I think this came from Stephen Lai's talk on GU trauma. And, I think one of his big points there was if you get hematuria or microscopic hematuria, that doesn't necessarily correlate with the degree of injury. You could still have some pretty serious injury with microscopic hematuria, but if you've already had a negative CT scan and you're incidentally finding this microscopic hematuria, then probably can do outpatient follow-up.
And Shannon, who asked the question, we asked Steve about this specifically, because I had actually emailed him, a month ago with the same question, and he kind of said the same thing that Chris said, which is, that alone shouldn't prompt you to do further imaging, but if you have a really high suspicion or there's high mechanism, then you might want to pursue that further with further imaging.
Right.
Hypotension, that used to be the big thing, was if they were hypotensive at any point, that you had to, go further with things, because, with microscopic hematuria and a history of, I guess it goes along with any other bad clinical signs.
Hypotension alone bothers me. More than the microscopic
explanation for that at some point.
And I love the comment earlier that Stuart about stable vital signs and what does stable mean and what's normal. And we're going to talk about this tomorrow with the geriatric trauma, but what is a normal vital sign in a lot of patients, and what represents stability? I agree. I think we get off on the wrong path. Stable makes me want to say, oh, okay, it's stable. I don't have to worry about it. And it gets you off on the wrong foot right off the bat in a lot of these cases.
I guess there's that concept. Then there's also the concept of normal vital signs, which, it's harder to criticize. I mean, there is such a thing as normal vital signs, I guess, if you look it up in the dictionary. But what's normal about, going back to our traffic accident, what's normal about being thrown 20 feet off of a motorcycle? Not much, And so you really got to take every single vital sign and think of the different factors that might be influencing in both directions, that might sometimes make normal vital signs actually be big warning signs.
And what's normal for an 88-year-old?
And the age of the patient, and right, exactly. Really important.
We'll talk about that a little tomorrow.
Really important.
There was another question whether or not we're going to see the EMA folks, and are we going to see the EMA?
Yeah, we're going to see them tomorrow.
Yeah,
we're super excited about that segment. Lots of good stuff.
So
Mike and Sanjay are going to answer all of our literature questions.
We still have them. They're still locked in the room downstairs in the studio.
We're hiding them in the closet.
Only Mel has the combo.
Yes. I'll let them out on my terms and my terms only. Got any more questions? I really want to wrap this up because it's time for a drink.
Yes.
I think we did it.
Thank you, everything.
It was a fun day.
Awesome day.
Britt's busting to tell you about a little thing she's going to do next year.
Oh, Oh yeah, so I guess one of the other questions that came in through the app was that everyone was really excited about the ultrasound nerve block talk that Arun gave, and they were asking if there was going to be some hands-on ultrasound courses and conferences that they could attend. And it turns out that I think we're going to put, well, I don't think we are going to put on a EMRAP conference in person. We don't have to do this virtually over YouTube anymore. It's going to be in April, a year from now. And one of our pre-conference courses is a ultrasound workshop, and we're definitely going to talk about nerve blocks, and it's going to be awesome. So it's coming soon.
Yeah, we love doing these virtual conferences, and somebody said this is really changing the whole idea of what a conference is, and I agree with that, but there's still something magic about being in the same place. So once a year, we're going to do a big conference, get together, drink beers together, do some fun education. Sarah's going to be doing some real innovative stuff in ICU education, video games and crap like that. And then you've got to go to physically do airway stuff, physically do ultrasound. So we'll do that next year. And what's the name of the conference?
Video games and crap like that. That's how we get that.
That's what it's called.
EMRAP 1. We're super excited about it. So coming soon.
See you tomorrow.